Health will come to order. The clerk will call the roll.
Click,
Present.
Collier,
Present.
Jaton,
Here.
Johnson,
Here.
Oliverson,
Here.
Smith, Tinderholt,
Present.
Price.
Here.
A quorum is present. We will resume testimony on the bill. The chair calls back up Dr. Jessica Zwiener. Dr. Zwiener, if you would be so kind as to state your name, that you are representing yourself in your position.
My name is Dr. Jessica Zwiener. I'm representing myself. I am opposed to this bill.
Thank you. Please begin. Dr. Alverson.
Thank you, Madam Chair. Dr. Zwiener, I truly appreciate you hanging around, and I know it's important to you, and so I'm glad you're here, and just wanted to finish our conversation. So first of all, you had mentioned before the break, we were talking about some studies, and you had mentioned the Turban had published 2 studies. And I just wanted to ask you if you were aware that there are some strong criticisms of those 2 studies based on the fact that what the study actually said is that it reduced the incidence of suicidal thoughts, but it had zero effect or not a statistically significant effect on reducing suicidal behavior. In other words, patients self-reported that they felt less suicidal, but there was zero change in terms of whether or not it actually prevented suicide. Are you familiar with that?
Yes, it's
And
also...
that was consistent with both of the studies, that there was that same methodological flaw.
It's difficult to assess the rate of completed suicide in people who have already completed the act of suicide. They cannot answer questions in a survey.
Well, of course they can't, but it'd be pretty easy to find that data if you were really looking for it. I mean, because there would be records, there are death records, right? So, I mean, if you were already following somebody, I feel like it's, and this is kind of the thing I wanted to explore with you a little bit more, is that we do recognize that we're treating a mental illness condition, and I don't mean any disrespect to anyone who identifies as transgender by calling it a mental illness or a mental condition, because I think you and I would both agree that it's not a physical issue like diabetes or high blood pressure. This has to do with a person's perception of themselves and how that affects their mental state, right? We would agree? Mm-hmm. So it seems to me like we're prescribing a medical therapy and potentially even surgical therapy to treat a mental illness. Would you agree that that's kind of what we're doing here?
I would agree that we don't currently know the biological basis for what makes somebody transgender. Currently, all we know is that it is in someone's perception of how they see themselves. But
Right.
yes, we do treat that with physical medications because that's the treatment that works.
Which is unusual, right? You would recognize that we don't typically treat schizophrenia with diabetes medications.
Correct.
Or depression. We don't typically treat that with antihypertensives. Mm-hmm. Okay, so that is a little bit unusual. The other thing is that when a person, and I want to talk specifically about WPATH. I assume you know the WPATH standards pretty well. So when a person presents with gender dysphoria, or what you perceive to be gender dysphoria, how do you make that diagnosis? What is the criteria in gender affirming care? How do they ascertain that a child, in fact, has, gender dysphoria?
So for the younger kids, that's done by a psychologist or a therapist, somebody who has more training with those small children.
Okay.
For my teenagers, I follow the DSM-5 criteria.
Okay. And is it true that the WPATH standard would state that, and this may be a better question for a psychologist, so I totally get it if you don't know the answer to this, but that the WPATH would state that a child's self-perception essentially is the rate determining factor as far as determining whether treatment is indicated. In other words, you're not checking blood pressure, heart rate, weight, height, There's no lab test that you can order. It's basically whatever the child says is happening internally, that's your best window into what's happening, right? Whatever the child says.
Just like with every other mental health condition, yes. There's not a blood test for depression or for anxiety. It's all based on what the patient reports to you in their history.
Well, agreed, right. Now, I understand that, but I think when we're talking about anxiety and we're talking about depression, there are other somatic things that can go along with that, but that's not really what I'm asking. What I'm asking is, how often in this process are we depending our diagnosis on what the child says? An 11-year-old says, I feel like I'm born in the wrong body. Is that sufficient to make the diagnosis of gender dysphoria?
If an 11-year-old comes to you and says once that they feel like they're born in the wrong body, that's not sufficient to make the diagnosis.
So what other criteria would you have to have in order to make that diagnosis?
This has to persist for at least 6 months, has to cause significant clinical impairment or trouble with functioning, and it has to be something that a mental health professional agrees with, and that there's not.
I'm going to ask the same question of the mental health professionals, because I understand that is a little
they'll have a
outside
better
your
answer
area
for
of
you.
expertise. Have you ever, last question I want to ask, have you ever had a child or a young adult? Well, first of all, how long do you follow these folks? Like, what's the longest someone's been a patient? How old?
I started my clinic in 2017, and I still have some of those patients.
So what's the maximum age range? What's your oldest patient? How old are they?
My oldest patient's about 75.
Your oldest patient is 75.
Yes, I treat children and adults.
Oh, okay.
Adolescents
I'm
and
sorry.
adults.
Let me be more specific. What is your oldest patient that you saw as a child?
18.
Okay, so you have been following them since 18.
I mean, when I start children, adolescents on hormones, they generally start when they're 16 or 17.
Gotcha.
And then
have you had any detransitions in your clinic?
I have had 5 patients report detransition. None of them were minors. One of them told me that they wanted to stop taking hormones, and then they continued with therapy for a few months and said, nope, I just needed a break. And 3 years later, now they are still on hormones. And then my other 4 were adult transgender women who all stopped specifically due to discrimination, stigma, inability to find work, inability to preserve their marriage or continue in their church or have contact with their children.
Okay, so, and I don't mean to be crass, but I'm just trying to understand. So you said they were adult. When you say you said trans, are we talking about somebody who was born as a male who transitioned to female?
Yes.
Okay. And so they were in a married relationship, and as a result of that relationship falling apart, they wanted to go back to being a man?
Not as a result of their relationship. In general, when I see this very frequently with my adult patients, when you are a little bit further in life, you have more attachments, you may have a career, you have a family, you have long-standing friendships with people. When you transition, it can be a lot more tricky. You have a lot more people who can have opinions about what you are doing and if it's the right thing or the wrong thing. And particularly if you are self-employed or you rely on just good PR or something to get business. If word gets out that this person is transgender, sometimes all your business dries up. And the point of transition is to be happy.
Yeah.
And some people decide that living in the gender that they want to live in is not worth losing their financial stability, losing their friends, losing their church, losing their family.
So they make a decision to go the other way? Mm-hmm. Okay.
Sometimes they come back.
And do you provide those services as well?
Of course.
So you help people detransition? How do you do that?
It's pretty straightforward. You just stop hormones. And then what I normally do is I'll check a blood test a couple months later to see if their body's making their own sex hormones again. If they are, then great. If they have any other questions, anything else that they need from me, I'm happy to provide services or referrals or anything like that. If they're not producing their own hormones, then we
Yeah.
usually start hormone replacement.
Okay, so that does happen? Okay, and, because I had read that sometimes you can, essentially permanently suppress the, I think we call it correct, you're the endocrinologist, but I think it's the hypothalamic pituitary gonadal axis, right? Right, so that can be permanently suppressed
Yes.
in some individuals. Okay, all right. Okay, Dr. Zwiener, I appreciate you being here today, and I hope this wasn't too hard on you, but I'm glad you're here. So
Thank you.
thank you.
Thanks for listening. Who's next?
Representative Jones.
I have one question for you.
Yes, ma'am.
Earlier, before we broke to go on the House floor, there were some discussions you were asked about why is it complex to define what a woman is. So I have a question for you. I had a friend who was born with doctors couldn't figure out and parents couldn't figure out. Was born, I think you're called intersex, with what they thought was a penis and a vagina. Parents picked the boy. Person grew into maturity. The penis didn't get any bigger, and she presented as a woman. So basically, her parents picked wrong. As a consequence, she had to go into surgery to have. She identified as a woman. She grew breasts, small breasts, but breasts nonetheless. But she considered herself a woman. Would you, and ultimately had the penis cut off, whatever it is you do, I don't know what you do. But is that what you meant? Was that an example of what you meant, that it's complex to define what a woman is?
It can be, and I think it's important to distinguish between biological sex and gender identity. So biological sex, for most people, you're a man or a woman. If you have XY chromosomes, you make testosterone, you have a penis and testes, you're male. If you are XX, you have a uterus, ovaries, vulva, you're female. Intersex folks, it's not common, but it does happen, and that's when you're some combination of those things. They don't line up. Then we also have gender identity on top of that, which is how you personally identify what your brain thinks of your gender as.
So are you saying that the definition of a woman isn't just what you're born with?
Correct.
Is that accurate?
Yes.
Okay, thank you.
Chair recognizes that Representative Shalonda Jones, Representative Campos, Representative Vinton Jones, and Representative Smith are now present. Anybody else with questions, members? All righty. Thank you very much.
Thank you.
Chair calls Luis Sapper. If you'll state your name for me, who you represent, and your position on the measure.
Good afternoon, Chair Click, members of the committee. My name is Lior Sapir. I'm a fellow at the Manhattan Institute, where my research and writing focuses on pediatric gender medicine in the United States and abroad, both the scientific research and the public policy. Earlier this morning, Representative Oliverson made a claim. He said, by the way, I'm speaking in favor of the bill.
And you're representing yourself?
I'm representing myself.
Thank you.
Representative Oliverson said that if the medical profession cannot or will not regulate itself in the interest of patient health in a particular area of medicine, the state has a right, let me rephrase that, a duty to step in and protect children from professionals who are not doing their professional duty. So what I want to do in the time that I have is I want to highlight that the doctor who testified here before me, Dr. Zwiener, actually gives us very compelling evidence for why the state of Texas cannot rely on its own doctors to regulate themselves in this area of medicine. And what I'm going to do is I'm going to put on the table 8 of the points that she made. I'm obviously not going to have time to address all of them, but I would urge you to ask me follow-up questions about the points that she made. Those points are, number one, social transition, which she claimed is, quote, fully reversible. Number two, puberty blockers, which she also claimed are fully reversible. Number three, she claimed that puberty blockers resolve gender dysphoria. Number four, that surgery either doesn't happen at all or at least is not within the standards of care. Number five, that gender-affirming hormones are known to reduce suicidal ideation and behavior. Number six, that the Dutch protocol is the best we have and that the 6 months of assessment are required in order for medical practice in this area to be ethical and appropriate. Number seven, that ROGD, rapid onset gender dysphoria, is not a thing. Number eight, that the state of the science is actually quite good. I want to address all of those if I can, but I'm going to start with social transition and the claim that it's fully reversible. This claim is not true. It doesn't stand up to minimal scrutiny. There have been 12 studies to date on the question of persistence and desistance among prepubertal children. 11 of those studies, which were done up until 2022, the last one being in 2013, and I'm happy to provide citations if you'd like, found that the vast majority of children with gender dysphoria desist by adulthood, most of them during the period of adolescence. A reanalysis that was done in 2018, following criticisms of these 11 earlier studies, found that the rate is over 70%. So the vast majority of children with gender dysphoria resolve that dysphoria by themselves without any need for transition. However, a study in 2022 by Christina Olsen et al. At Princeton and published in Pediatrics found that 97% of children who were persisted in their gender dysphoria 5 years after they were socially affirmed. So the question is, how do we reconcile the fact that 11 previous studies found that the vast majority of children desist with one study that found that the vast majority of children with gender dysphoria persist? Well, the answer has to do with a very important fact about the Olsen study. Because you see, unlike the other previous 11 studies, the children in the Olsen study were all socially transitioned. That was a condition of their eligibility to participate in this study. So there's two possible conclusions that you can draw from this. The first is that the clinicians and researchers who were, doing this research, Christina Olsen and her colleagues, were remarkably efficient at picking out the, so to speak, true transgender children from among all the children who had trans-like behaviors or desires. That's one possibility. The other possibility, which is far more compelling, is that social transition itself is what caused these kids to persist. And I would submit that the second possibility is the possibility that falls within the principle of clinical research known as equipoise, which is when researchers take a step back from their own biases and assumptions and ask, what am I really observing here? And are my own biases clouding my ability to detect the effect of an intervention? And sure enough, medical authorities in other countries have recognized for decades that social transition is, as the UK's NHS recently put it, and the Cass report recently put it, quote, not a neutral intervention, but an active psychosocial intervention. Meaning, by socially transitioning kids, we vastly increase the likelihood that their gender dysphoria will persist, meaning will not resolve, meaning that they will not come to terms with their own bodies, meaning that they are much more likely to, so to speak, require medicalization. And sure enough, about 60% of the kids in the Olsen study were medicalized by the end of it. So you're talking about a huge number of kids, because the study was over 300 children, a huge number of kids who very likely would have desisted if not for the social transition, who are now on medication. So that's on the question of social transition. And I should point out that recently Finland proposed a gender self-identification law, and activists wanted it to apply also to minors under the age of 18. The chief psychiatrist at Finland's Tampere University, who is the country's top expert in pediatric gender care, Dr. Rita Kartu-Kaltiala, said that this is very, very bad practice, precisely because, as she put it, 4 out of 5 kids desist. The Finnish Pediatric Society, which is the equivalent of our American Academy of Pediatrics, wrote a letter to the Finnish parliament telling them, do not extend gender self-identification rights to minors, precisely for this reason. The Finnish Medical Association, which is the counterpart to the American Medical Association, also submitted testimony saying it's not good policy, it's not advisable to allow children to have the legal right to self-identify their gender because it's likely to lead to persistence. So this is just one example of how the medical science shows that what Dr. Zwiener said about social transition being fully reversible is not correct. The medical science shows that what she said is not correct, and that health authorities in other countries have recognized this fact. And I'll finish by saying that in the UK, the National Health Service issued new guidance, new medical practice guidance in October of last year. And in that guidance, the NHS said, for social transition, we discourage social transition in prepubertal children, and even in adolescents, they recommend it only on the basis of a gender dysphoria diagnosis and with informed consent. Why? Precisely because it has what's known as an iatrogenic effect, meaning that the intervention can cause the persistence of the very illness or the very pathology or the very problem that it's trying to resolve. So what Dr. Zwiener said here about social transition is contradicted by the evidence and by health authorities in other countries. And that's just one example of why doctors in this country, and especially in the state of Texas, who practice gender-affirming care, either do not know or do not accurately represent the state of the science. So I'll stop there for any questions.
Representative Alverson.
Thank you, Madam Chair. Mr. Sapir, I appreciate you being here today. Okay, so I want to go back to the whole suicide thing, because this is sort of, I think, one of many issues that gets bandied about by all sides, and I really want to kind of be able to put our arms around this and understand the data better.
Yeah.
So we hear that there is a higher risk of suicide, suicidal thoughts, attempted suicide, completed suicide amongst youth who are identified as transgender than the general population.
Mm-hmm.
So first of all, is that true? And if it is, can you explain why that is the case?
Okay, thank you. This is a very complicated question. Here's what I would say. The evidence shows that minors who currently, and that's a very important qualification, who currently identify as transgender are at higher risk for suicide and at higher risk for suicidal ideation. What the evidence does not show us is why they are at higher risk, and it certainly does not show us that medical transition reduces that risk. Okay, so let me kind of walk through some basic facts about the suicide issue. So just starting with some empirical numbers, a study in the United Kingdom, this is Michael Biggs' 2022 study on youth, clinically referred youth at the UK's Tavistock Clinic, found that between 2010 and 2020, so very recently, a period spanning an entire decade, the suicide rate among clinically referred youth to the UK Gender Identity Development Service was 0.03%. I just want to correct the record. It was earlier said 0.3. It's 0.03. Or 4 deaths out of 15,000 clinically referred children. And by the way, 2 of those kids were already receiving gender-affirming medical interventions. So, you know, obviously every single death is a tragedy, of course. But the idea that kids who identify as transgender are at imminent risk of suicide if they don't get medication doesn't stand up to scrutiny. In the United States, we don't have data on gender-related suicides, but what we do know is that in the period of time before 2009, which is when hormones began to be offered here in the United States, we did not see wave after wave of teenagers killing themselves because they didn't have access to puberty blockers and cross-sex hormones. We didn't see that. And Dr. Zwiener said that, you know, these kids have always existed. They're just, presumably they're just coming out of the closet now because they feel more comfortable. If that's true, and if you look at the fact that between 2% and 9.2%, depending on which studies you're looking at, the 9.2% is taken from Kidd et al. It's a peer-reviewed medical research study on kids in the Pittsburgh school district now identify as transgender. Between 2 and 9%, you would think if these kids, if that rate of teenagers always identified as transgender, you would think that we would have noticed an epidemic of suicides before gender-affirming hormones became available. but nobody has ever noted anything like that. There's zero evidence that anything like that ever happened. In fact, the rates of suicidal behavior and completed suicide over the last decade, since gender-affirming hormonal interventions were rolled out, has increased so much that the CDC recently issued a new report saying what we all intuitively know to be the case, which is that the state of mental health among teenagers, and especially female teenagers, is in a state of collapse. Okay, so we do have some evidence, I should point out, that medical sex changes do not reduce suicide. There's a study from 2011 in Sweden, a country known for harboring very pro-LGBT attitudes, that showed that adults after transitioning were still 19 times more likely to kill themselves, to commit suicide, compared to age-matched controls in the general population. And I should point out, that is not evidence, this is sometimes misinterpreted as evidence that gender-affirming care causes suicide. It does, that's not evidence that this happens. But it is evidence, or at least it suggests, that these treatments do not reduce the actual chances of suicide. Okay, so as I said before, it's true that minors who identify as transgender are likely to have more suicidality, meaning more suicidal ideation, gestures. Suicidality is not the same thing as suicide. Those two terms should not be confused. But here's the crucial point. Studies from the United States, United Kingdom, Finland, Sweden, Canada, and most recently the Norwegian health authorities have all shown that adolescents presenting with gender-related distress over the last decade have extremely high rates of comorbid psychiatric diagnoses, and that in the vast majority of these cases, the psychiatric diagnoses predate the onset of gender issues. Okay, so in the United States, over 70% of youth referred to gender clinics were found to have at least one pre-existing psychiatric diagnosis. This is from Tracy Becerra-Kulke et al., a paper published in Pediatrics in 2018. Now, what's important is that these underlying and unresolved mental health problems are themselves known proxies, known predictors of suicidal behavior. So it's possible, and in fact likely, that teenagers who already have poor mental health, who already have suicidal tendencies, are gravitating towards a trans identity rather than kids who are already trans are suicidal because they're trans. In 2019, a group of researchers decided to test this hypothesis. They published research on gender dysphoric youth in Canada, in the UK, and then in the United States. They compared trans-identified kids to kids who were not trans-identified, but had similar mental health comorbid conditions, right? So you take one kid for every kid you have with gender dysphoria and depression, you compare to one kid who doesn't have gender dysphoria, but also does have depression. And what the study found is that the disparity in suicidal ideation and behavior, the disparity between trans kids and non-trans kids reduced almost to the point of insignificance. Meaning, this further confirms that the high rates of suicidal ideation behavior among trans-identified youth are not because of the trans identity, and therefore they cannot be resolved by medical transition. The problem is that by assuming that gender identity is the source of the suicidality and that medical transition is the only solution, we're missing the bigger picture here, which is the collapse of mental health among teenagers and teenage girls in particular over the last 10 years. So we're misdiagnosing the problem.
Okay.
And it's no coincidence, I would point out, that teenage girls are the demographic that represents 2/3 to 3/4 of all referrals to pediatric gender clinics in the past decade. I do want to say mention one more point, if that's okay. It's not just that the transition or suicide narrative has no evidence whatsoever. The problem is even worse, because that narrative itself has been linked by the CDC and by transgender and LGBT advocacy organizations to suicidal behavior, meaning suicide and suicide-related behaviors are known to be socially contagious. We know this through research over decades. The CDC has guidelines on how to discuss suicide in a responsible way. And what these guidelines say, they caution against, quote, presenting simplistic explanations for suicide because suicide is, quote, never the result of a single factor or event, but rather the result of a complex interaction of many factors and usually involves a history of psychosocial problems. In 2017, a document titled Talking About Suicide in LGBT Population, published and co-sponsored by the Movement Advancement Project, the American Foundation for Suicide Prevention, the Human Rights Campaign, GLSEN, the Trevor Project, GLAAD, PFLAG, the Transgender Law Center, SAGE, the Center for American Progress, and the National LGBTQ Task Force, said this, and I'm quoting, "Do not attribute a suicide death to a single factor, such as bullying or discrimination, or say that a specific anti-LGBT law or policy will cause suicide. Suicide deaths are almost always the result of multiple overlapping causes, including mental health issues that might not have been recognized or treated. Linking suicide directly to external factors like bullying, discrimination, or anti-LGBT laws can normalize suicide by suggesting that it is a natural reaction to such experiences or laws."
I appreciate that. And so one more question for you, and then I know there's other members who want to ask you some questions too, but you sort of glanced on it. I got kind of a grimace when we were talking earlier about this rapid onset gender dysphoria and the change. And you kind of said in your opening thing that that was something you wanted to talk about. So, I mean, I think that's really bizarre, that all of a sudden you have this complete reversal and then it just keeps on going. It's not just like there was 100% switch. It's like suddenly girls outnumbered boys and then it just kept going.
Right.
And it's really weird. So can you explain to me, what does the literature say, or what do we know scientifically about this whole, I guess they call it rapid onset gender dysphoria?
Okay.
Is that a real thing?
Yes. Okay. So because this was also addressed by Dr. Zwiener, I do want to address it as well. So up until the late 2000s, even mid-2000s, referrals to pediatric gender clinics were extremely rare. And the vast majority of kids referred were boys, natal boys, whose onset of symptoms of gender dysphoria began usually in toddlerhood, sometimes a little bit later, but definitely before puberty. By the mid-2010s, that had completely flipped, so that now the vast majority of referrals to pediatric gender clinics, including here in the United States, and we have data backing that up, are teenage girls with no history of gender dysphoria before puberty, and meaning adolescent onset of symptoms. Many of them, not all, but many of them have what's known as sudden or rapid onset, meaning that it occurred quite suddenly and out of the blue. And maybe most importantly, the vast majority of them have extraordinarily high rates of comorbid psychiatric diagnoses. Okay, so that's the clinical cohort we're talking about when we're talking about ROGD. Teenagers, especially but not only females, adolescent onset of symptoms, and comorbid mental health problems. Okay, let me read off some because Dr. Zwiener said that it's just a hypothesis. It was proposed in a highly flawed.
She said there was one study.
Right, highly flawed.
Are there more than one study?
Oh yeah.
Okay.
Highly flawed study by Lisa Littman in 2018, and therefore we don't have to take it seriously. Okay, let me read off some citations from medical journals, just so that you see that this is a problem that's happening not just here in our clinics, but across all countries that have pediatric gender clinics. Okay, first citation, DeVry et al. 2020, published in Pediatrics, that's an American journal. However, authors, quote, authors of case histories and a parent report study warrant that gender identity development is diverse and a new development pathway is proposed involving youth with post-puberty, adolescent onset transgender histories. These youth did not yet participate in the early evaluation studies. Okay, so it's a new cohort. The UK Gender Clinic, the citation is Hutchinson et al. 2020, published in Archives of Sexual Behavior. Quote, while some of us have informally tended towards describing the phenomenon we witness as adolescent onset gender dysphoria, that is, without any notable symptom history prior to or during the early stages of puberty, certainly nothing of clinical significance, Littman's description resonates with our clinical experiences from within the consulting room. So these are clinicians in the UK confirming in peer-reviewed medical research that what Littman said in 2018 resonates with their clinical experience. De Graaf et al. 2018 Archives of Sexual Behavior, quote, "The steep increase in birth-assigned females seeking help from gender services across the age range highlights an emerging phenomenon. It is important to follow birth-assigned females' trajectories to better understand the changing clinical presentations in gender-diverse children and adolescents, and to monitor the influence of social and cultural factors that impact on their psychological well-being." I have other quotes I'm happy to give from the Netherlands, Sweden, Finland, and Canada, where researchers said, yes, what Littman described in her 2018 study absolutely conforms to what we've been seeing dominating our clinics over the last few years.
And so, I mean, I think as I was watching testimony on this before, the argument was made with respect to this issue that, well, it's only because people are more comfortable to be who they are. And that's why we've seen this massive explosion of adolescent girls. Is that, I mean, can you critique that statement?
Yeah.
Is that factual, or does that make sense, or does that comport with the literature?
It does not comport with the literature. It does not make sense to me, and I'll tell you why. If the rise of transgender identification among youth over the last 10 years, sometimes we hear the analogy to left-handedness, right? That left-handedness increased 300% over the course of a few decades, but this is not because of a social contagion of left-handedness. It's because school teachers no longer forbade students from writing with their left hand, right? So these people were always left-handed, but they were now just allowed to be who they really are. So that's the analogy that's given, and that's the way that people on the other side explain away ROGD. There's no way that that's convincing, and here's why. The rise in left-handedness was 300% over 60 years, between 1900 and 1960. Within the last decade alone, when we're talking about gender dysphoria, the UK recorded a rise of 4,400% in referrals to its GIDS clinic at the Tavistock. That's between 2009 and 2018.
4,000?
4,400% increase. Wow. And that's in less than a decade. So you're talking about 300% over 60 years versus 4,400% in 9 years. We've seen the same steep increase in trans identification here in the United States. The DSM-5 lists the rate of gender dysphoria in the general population as being between 0.002 and 0.014%. And this is, the DSM-5 was published in 2013. Presumably, let's assume that all these people were also trans as kids, whereas now what we're seeing based on a Gallup poll from 2022 and the KIDS study that I mentioned earlier is rates of trans identification of between 2% and 9.2% depending on the area of the country and the school district. So you're talking about an increase of from 0.002% to 9.2%. That's, I'm not going to do the math very quickly, but that's, you know, many thousands of times what it used to be, again, just a decade ago. And then the final point that I think corroborates the ROGD hypothesis is that if, in fact, it was the case that more and more kids are coming out as who they really are, and most importantly, who they're always going to be as adults, because that's the justification for medicalizing them, that their trans identity is settled and permanent, and it's never going to change. But if that was really the case, we would expect to see a more or less even balance in the sex ratio. We'd expect to see it more or less 50-50, girls and boys. But that's not at all what we're seeing. Data from the United States and every other country with pediatric gender clinics shows that the percentage of girls, of natal girls in these clinics and who identify as trans, although non-binary is fast becoming the biggest category, the percentage identifying as trans is between 2/3 and 3/4. So no, it doesn't make sense to me. If it was a very small increase and evenly distributed across the sexes, I'd be more willing to buy it. But given the numbers that we've seen in such a short period of time across Western countries, it just doesn't make sense.
Yeah, it sounds to me like I mean, I know we don't like to say this, but it sounds to me like a peer pressure mediated kind of thing. Like it's.
Yeah, again, I don't want to suggest that all kids who identify as trans are ROGD. That's not what I'm suggesting.
Right. I'm not either.
Yeah.
But I'm saying, like, when you hear what happened at the clinic in Washington University in St. Louis, I mean, that's exactly what you're talking about, right? Is that this person observed people coming in, they were all about the same age, all female. Turns out they all went to the same school, they knew each other.
That's right.
Very
Come out
bizarre.
in friend groups. I mean, that's what Lisa Littman found, too, in her study, that many of these girls were coming out in friend groups, in clusters. We don't, again, we don't have perfect evidence of this. It remains a hypothesis. I've spoken to Lisa Littman. I know she always emphasizes this was a hypothesis. I never meant it to be settled science. I was calling for more research.
But the
that is
fourth-
what a good scientist does.
The 4,400% increase, that's not a hypothesis.
No, that's not a hypothesis. So what happened is that she proposed
Insane explosion.
Right. So what happened is that she proposed the hypothesis, and then pediatric gender clinics and researchers across the world said, yes, what you're describing comports with what we've been seeing over the last few years. So that lends further evidence, further strengthens the ROGD hypothesis.
Well, I know I could talk to you forever, but in the interest of time, and I know I got other committee members here that want to ask you some questions too, I just want to say thanks for coming here today, and thank you for being so thorough with us.
Sure.
I feel like you could get lost in the weeds, but
Right.
I feel like it's really important to understand the science, the
Right.
data. Everybody's, as I said, bandying these things about, but
Right.
very few people get up and actually quote the author, the year, here's the methodological methods that, the methods that were used, here's what the results said. I mean, I think that really helps us, and I want to commend you for doing that.
Yeah, thank you. Appreciate that.
Representative Smith?
Thank you, Madam Chair. Sir, thank you for being here. Appreciate the information and your work and your research on this. A moment ago, I heard you say,
Excuse me, it's hard for me to hear you.
yeah, no, I can't hear you very well either over there. I'm sorry.
Oh, I'm sorry.
Can you hear me better?
Yes.
Okay. A moment ago, you said, and I think I'm paraphrasing, that the real problem is the collapse of mental health among youth, particularly girls.
Right.
And then we've heard some of the discussion about some of the research and some of the things that kind of verify around that. Does any of the research that you've done go to the heart of that as to what, I know we're trying to broad brush here, we're talking about individuals.
Right.
But is there any research that gives us some indication as to what the major cause of the mental health is? Or first of all, what it is?
Yeah.
Is it anxiety, depression?
Yes.
And then do you have any research that shows kind of what the cause of that is?
Right. So what we know based on research on the pediatric gender kind of universe over the last 5 or 6 years is that the most common comorbid psychiatric diagnoses, and this is, the countries that have collected the best data, for example, the UK, they usually it's focused on a small number of diagnoses: depression, anxiety, eating disorders, ADHD. Autism is extremely common. 1/3 of all the kids referred to GIDS had autism. And as I said, all of these are independently linked to suicidal ideation and behavior, independent of gender issues. So those are the psychiatric diagnoses. That's what's most common, especially in the ROGD group. In Littman's study, she found all of those diagnoses and a few others. But the question of what's causing this that is an open question. Social scientists, social psychologists are studying this question as we speak. People like John Haidt, Jean Twenge have done excellent work on this. So Jean Twenge, for example, has managed to trace, quite credibly, the crisis of mental health to the advent of the very potent combination of smartphones and social media, which became available to youth roughly 2007, 2008. And what you see, if you look at charts, you can see that the mental health crisis really starts exactly when teenagers, and especially teenage girls, because they are the ones most negatively impacted, first got their smartphones and their social media. And incidentally, that's also when ROGD started to take off. Is that a coincidence? I don't think so. Do we have, settled science showing that the two things are related? No. But we don't do settled science here. We do we issue policies on the basis of the best available knowledge.
I mean, if we had, with that time frame, 2008 to present, have we had time really to do the studies that would be necessary to be able to make that determination?
The determination that it's linked to
To a particular thing,
Yeah.
would be like, so for particularly the
Yes.
social media.
Right. So the two names that I mentioned, they've been focused on this issue very much. That's not my area of expertise. What's causing the kind of the collapse of mental health among teenage and especially teenage girls? I'm focused more on pediatric gender medicine, but they've done quite good analysis showing that yes, there's a very, very strong link there.
Okay.
Yeah.
All right. Thank you.
Representative? Representative Collier?
Oh, thank you so much. Sir, it says that you're a fellow with the Manhattan Institute.
Correct.
Do you live in Texas?
I do not.
Do you provide health care to transgender youth?
I do not.
Do you have any research projects that you've done on your own?
What do you mean by research projects?
Well, I keep
yeah.
hearing you read
Yes.
about, you're reiterating other projects.
Right. So, for example, last year, so one of the most commonly cited articles in support of gender-affirming care is an article that was published in Psychology Today.
But is it yours? Did you write it?
I'll get to that in 1 second.
I know, I just need a yes or no.
Yes, I wrote it.
Okay, thank you. That's
So-
all the question. No. That's all.
No, but
No, I don't have anything else.
okay, but what I just told you is
I
incorrect.
have nothing
then.
else for you. Thank you, sir. Have a great day.
Representative Price?
Thank you, Mr. Sapir. Thank you for your testimony. We've heard a lot of questions so far today that have been answered with percentages and statistics and causes and relationships, all helpful. But, a lot of conflicting information even to this point in the day. One thing I don't think we've heard a lot about, which I don't know if you can answer, but maybe about rates of for instance, detransition and regret, if any, for individuals who transitioned as minors who are now adults, because we hear a lot about what is happening.
Right.
But what I guess I haven't heard is what's that rate look like, if there is one that can
Right.
be articulated, and because I think that could be significant. And so if you have that information,
Sure.
I'd like to hear it.
Yeah. If I may just finish what I was
Yes,
trying
please.
to say.
Sure.
The article in Psychology Today is one of the most commonly cited articles in support of gender-affirming care. It's by Jack Turbin, whom Dr. Zwiener cited, and he goes over 16 studies that he claims support gender-affirming care. Last year, I wrote a long critical analysis of this Psychology Today article of all 16 studies, showing that not a single one of them actually shows what Jack Turbin says they show. Not a single one of them actually shows any causal evidence, any causal link between hormonal interventions and improved mental health. After I published this article, Psychology Today issued 4 corrections to the article, and in addition, 2 or 3 stealth edits, meaning they changed what Turbin had said but didn't acknowledge it. And I know that because I saved the original version, because I knew that was going to happen. So one of the leading experts in the country writes this publication full of falsehoods. I come and correct it, and the corrections are accepted. So yes, I have published on this issue, and so let me just put that on the record. Okay. On the question of regret and detransition, the only honest answer to the question of how common regret and detransition are is we don't know. And the reason we don't know is because anytime you hear somebody citing numbers like 1%, 2%, we heard that in the Senate last week, those numbers are based on studies that were done on adults who transitioned as adults, or that's the vast majority of cases, but in a small number of cases, minors who were transitioned under the Dutch protocol. In fact, it is the Dutch study. The Dutch protocol and the affirmative model of care are very different. And in fact, European health authorities, especially the CAS review and the NHS, have explicitly rejected the affirmative model of care because it lacks adequate safeguards. That's how they put it. It lacks child safeguards. So we cannot say with any confidence that the rate of regret and detransition among teenagers who have been transitioned over the last decade, especially when ROGD and adolescent onset of symptoms have become by far the most common presentation, we cannot say that it's 1 or 2%. That's highly misleading. So the reason we don't know the true rate of regret and detransition is precisely because gender clinics across the West are now seeing the rise of a new clinical presentation. Adolescent females with high rates of comorbid mental health problems and no history of gender dysphoria before puberty. However, we do have some reason to believe that rates of regret and detransition will be significantly higher than 1 or 2%. And here's why. First of all, 3 recent studies, which did include patients from the new clinical presentation, found a 10 to 30% rate of regret and detransition. The citations are Christina Roberts et al. 2022, Ruth Hall et al. 2021, and Isabel Boyd et al. 2022. Okay, so already we're starting to see new research emerge showing that the rate of detransition and regret is likely to be much higher than 1 or 2%. And by the way, for any medical treatment, and Dr. Oliverson will correct me if I'm wrong, but for any medical treatment, if you have a 30% rate of false positive, false diagnosis, and inappropriate medical treatment, even if you have 10%, that would be brought to an end immediately. So that's number one. Number two, a study in 2021, also by Lisa Littman, Littman in that study also said, this is not a representative, fully representative study, but this is a hypothesis generating, or at least it's a call for more research, found that 75% of 100 detransitioners that she interviewed had not reported their decision to detransition to their doctor. 75%, meaning as far as their doctors are concerned, they have no idea if these people detransitioned and regretted their decision. They might even assume that they're perfectly content with their transition, but 3/4 of them were not. So again, we can't make any firm conclusions based on this study, but it does suggest that there is a problem that needs to be examined thoroughly before we allow these medications to take place. And number 3, I think most importantly, the affirmative model of care, which as I said is very different from the Dutch model. The affirmative model of care, which by the way, a Reuters investigation from last year interviewed clinicians at 18 pediatric gender centers across the United States and found that not one of them, not one clinician, said that they were following, and this is almost a direct quote, you should look it up if you don't believe me, not one of them found anything like the months-long mental health assessments required by the Dutch. That's what they found. So that's why when Dr. Zwiener said, yes, the Dutch 6-month-long requirement of mental health assessments is good practice, that's standard, that's what we should be doing, well, it turns out that American gender clinics are not doing it, which again is the justification for the state of Texas regulating. But the affirmative model of care itself, what it does is it basically says 2 things. Number 1, kids know who they are, and clinicians should follow the child's lead. In the Senate, we had a psychologist last week who was asked, when a kid shows up at your clinic and says, I'm trans, do you believe him? And she said without missing a beat, yes. Dr. Zwiener said also, I believe my patients in one way or another, right? So the affirmative model does that, the Dutch model does not. It does assessments, exploratory therapy, in order to determine precisely in the era of ROGD whether the gender identity issues are secondary to, meaning caused by, underlying mental health or unresolved problems like history of sexual trauma and abuse and so on and so forth. So that's number 1. It assumes that kids know who they are and they have a settled identity from a very, very young age, and they can't get it wrong. Number 2, the affirmative model, unlike the Dutch model, uses what's known as the minority stress hypothesis. And that means that if a teenager presents with a complex state of mind with many psychiatric comorbidities, under the minority stress model, a clinician will say, well, this girl has anxiety, depression, eating disorders, ADHD, autism, whatever. That must be because she's really trans, she's not being accepted as trans, therefore all these other issues are secondary to that. In fact, Diane Ehrensoft, one of the leading proponents of gender-affirming care, in her 2016 book says, gender transition can cure autism. I kid you not. And she cites 0 research for that claim. So if you take these 2 facts together, the fact that they follow the child's lead and that they subsume all comorbid psychiatric problems under the gender issues, it stands to reason that we're going to get a lot of false positives. We're going to get a lot of kids who are struggling with other issues and who are not going to grow up to be trans and have lifelong acute gender dysphoria being misdiagnosed as gender dysphoric and treated medically on that basis. And so we're likely to see many more kids detransition, many more adults detransition in the years ahead. But that data is going to take time. Yeah.
Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here today.
Yep.
I'm just going to cut to the chase. Do you think these detransitioners we're talking about should have the tools necessary to go to court to file against these clinics for the abuse they received as a child?
Absolutely.
Would you consider this child abuse either by the medical professional or the parent?
By the parent, no, I do not. And I think that the reason is that parents are themselves misled. For every one mom who is gung-ho about transitioning her kid, there's 9 parents who have been misled by their own doctors using the suicide narrative. So no, I do not think that parents should be criminalized, prosecuted, or anything like that. With regard to providers, whether they are guilty of child abuse is a technical term. I wouldn't apply it so easily here. I would just say they were acting in gross negligence of their ethical duties and duty of care, and that at minimum their license should be revoked, at minimum.
There's a reason I ask that, because I see the potential for parents to do two things. Number one, I think some parents may be misled like they are right now and may do telemedicine and have puberty blockers and different medications shipped in. Do you think the parents should be held accountable for that in any way?
No.
How about if the parent takes them to another state to have the surgery done?
No.
Okay. Thank you very much for your time. I appreciate you.
Sure.
Representative Jones.
I got some quick questions. So I just want to be clear. You're not a medical doctor, right?
Correct.
You're not a psychiatrist, right?
Correct.
You're not a psychologist, right?
Correct.
You brought up this example about lefties,
About what?
left-handed kids.
Oh, yeah. Mm-hmm.
And you threw that out there. Interestingly, my son is a lefty. When he was in preschool, and he was always a lefty since he was born, when he got to preschool, they started making him use his right hand, right? So when you talk about, and he thought something was wrong with him, right? Because at the school that he went to, which by the way, I took him out of that school, and I found myself having serious discussions with the school who made my son believe that something that he wasn't, right? On account of they were experts over me. So I sort of look at that in the same light here. But I think what is extremely curious to me is that you talk about the question about why suicide, how it relates to being trans, is not settled,
Right.
right? Yet you argue that we should do what you say because your opinions on it, is dispositive. I'm really struggling with that.
Yeah.
And I'm not asking for an explanation, right? Because I've heard a lot of explanations by you. But I think as a child of a dad who killed himself, that anybody who gets up and says, why some people leave letters, leave notes. They tell you why they did it, right? They do. And then some people don't. So to determine why somebody did something when they didn't tell you why they did it is offensive to the family of the people who lost their loved one, right? Especially when you use it to support your hypothesis, which is just that, a hypothesis. It's not scientific. And also one other thing I wanted to make sure of, you haven't performed any individual research on your own. Accurate?
What do you mean by research of my own?
Have you gone out and have you done your own research? I see you.
You mean on kids with gender dysphoria? No.
All right.
No, that's not the kind of research I do.
You're a political scientist.
Correct.
PhD.
Correct.
Okay, so that's your doctor.
Correct.
Okay.
No, my doctorate is in transgender civil rights, actually, but yes,
Okay.
I pivoted to this issue, which is related, transgender civil rights.
So you're with the Manhattan Institute.
Correct.
Is that a conservative think tank?
We believe in free markets and.
Is it a conservative think tank?
Well, it depends what your definition of conservative, but yes, we are right of center.
Okay.
Yeah.
You're struggling with that answer.
Well, no,
It's like
because
it ought to be simple,
people have
like-
different definitions of conservative, and I want to know what you mean by it.
Simple, like
Yeah.
whether you're a girl or a boy. But other stuff. Thanks.
Touche.
Thanks.
Yes, can I answer, or is this a question? No, okay. Okay.
Madam Chair,
Representative Tinderholt.
I want you to have the opportunity to respond to that.
Thank you, I appreciate that. Okay, so a few things. First of all, I certainly don't mean to cause offense. That's not why I'm here. I'm here to try to make accessible the best available scientific research that we have on the question of pediatric gender medicine. On the question of my credentials, it's a totally legitimate question to raise. When my kid is sick, I don't take her to a political scientist. I take her to a doctor. But I would say a few things about this. Number one, the expert opinion of a doctor in evidence-based medicine, EBM, is the lowest tier of the pyramid of evidence. Much higher above are other methods of synthesis of information, and at the very top is the systematic review that Dr. Oliverson mentioned earlier. And every single systematic review of evidence on the suicide question, on the question of the relationship between hormones and suicidal ideation and behavior, every single systematic review of evidence that has examined that question has come back with the exact same answer. The certainty of evidence, the certainty that hormones have a positive effect on reducing suicidality is, quote, very low. And it is not the case that doctors and researchers and medical authorities in the UK, Sweden, Finland, Norway, France, Australia, New Zealand, it is not the case that doctors and medical authorities in these countries don't care if kids kill themselves. They absolutely care. But what they're trying to do is to say, these are extreme interventions. They are. And we want to know if we're going to use the suicide issue as a justification for these extreme interventions, we want to know that they actually work. Dr. Zwiener before me cited the two Turbin studies from 2020 and 2022 as she put it, the best available that we have. Let me point out a couple of things. For number one, those studies were excluded from the systematic reviews in the UK because they were too low quality to even be taken seriously. The systematic review done by the experts in research methodology at McMaster University did look at the Turbin study and found that it was very low quality. Why? Because the study design did not allow for any causal inferences. And I would also point out lastly that if the best available research that we have on the suicide question, according to Dr. Zwiener, started in 2020, but we started giving puberty blockers in 2009, that means that for 11 years we were giving puberty blockers without good research. That is experimental medicine by definition. And the last thing that I'll say on this is that recently Dr. Rita Kaltiala, who again is Finland's top expert on pediatric gender medicine, told the Finnish version of the New York Times, the country's liberal newspaper of note, that the narrative that if you don't give kids hormones, they'll kill themselves is, and I quote, purposeful disinformation, and that's using that narrative is, and I quote again, irresponsible. So again, medical authorities in other countries do not accept that the suicide question is settled on this issue, and to the contrary.
Representative Smith.
Thank you, Madam Chair. Just real quick, and I'm sure I missed this earlier, but tell me, do we have some type of understanding as to the number of children that fall into the category of gender dysphoria in the United States?
Yes, we do. I don't have the numbers at my fingertips. Actually, yes, I do. Yes, so Reuters is really Reuters published the first of its kind effort to collect data on rates of diagnosis of gender dysphoria over the last 5 years. This was based on information collected by Komodo Health, based on insurance claims. So keep in mind, this potentially dramatically, undercounts the true rates of rise in gender dysphoria diagnoses. And what they found, if I can find it, what they found was that between 2017 and 2021, between 2017 and 2020, the number of gender dysphoria diagnoses rose by 20% annually. And then between 2020 and 2021, it rose by 70%. Incidentally, that was the year of the pandemic, COVID, right? Everything was shut down. Kids were on social media a lot more, on the internet. Is it a coincidence that that is the year that we had a 70% spike in the rates of gender dysphoria diagnosis? I don't think so. But yes, the diagnoses have skyrocketed in recent years.
And so do you know what the numbers are?
I can find them if you give me a second, but
Well,
if you don't want to, that's fine too.
Maybe that's one of those things that you and I can just talk about.
Yes,
Take
yes.
committee time.
I remember off the top of my head, actually, I remember exactly. Over the last 5 years, the number of new gender dysphoria diagnoses that have been added is 121,882. And you can fact check me on that. That's from Reuters. 121,882 new diagnoses.
New diagnosis.
New diagnoses.
You know what the
total number?
the total number?
No idea. But it's probably quite a bit in excess of that because, again, this is based on insurance claims, and there are other ways to code for gender dysphoria diagnoses. So I don't know.
And do you happen to have access to numbers that would show for Texas?
No, I don't know that.
Okay.
Although I believe the Reuters investigation broke it down by state, but it included data for some states, not for all of them.
Okay, well, we can talk about that.
Right.
Thank you.
Yeah, absolutely.
Other questions, members? All right, thank you very much for your
Thank you.
testimony.
Thanks.
The chair calls Megan Mooney. Megan Mooney. Dr. Mooney, it shows that you are with the Texas Psychological Association and yourself. Is that correct?
Yes, ma'am.
And you're testifying against the bill.
Yes, ma'am.
Alrighty, please begin your testimony.
Thank you. Good afternoon, Chair Click, members of the committee. My name is Dr. Megan Mooney. I am here representing myself as well as the Texas Psychological Association in opposition to the bill. I'm a licensed psychologist practicing in Houston, and I have the privilege to serve parents and their children in my practice. I'm an affiliate member of the National Child Traumatic Stress Network and have been a trauma-focused provider for almost 20 years. It's through this work of focusing on our most vulnerable children, those who've experienced trauma and loss, that I began to also focus on serving LGBTQ+ youth, especially transgender youth. I worked for over a decade at a large outpatient mental health clinic in Houston and headed our trauma program there for many years. Over that time, I began to notice a trend in LGBTQ+ youth being referred regularly to our team for evidence-based services. This observation continued when I then moved to work at a trauma and grief-focused clinic in the Texas Medical Center. I began to read and to learn more about transgender youth specifically, and realized that this pattern I was noticing in my clinical practice was supported by a large number of research studies. Transgender youth experience disproportionate rates of verbal, physical, and sexual abuse as compared to their cisgender and heterosexual peers. The data is becoming clear that these high rates of trauma are because of others' perceptions about a young person's gender identity and expression. In other words, trauma doesn't cause kids to be trans. Being trans causes them to be traumatized by others. What data also seems to suggest is that gender nonconformity is one of the biggest risk factors for predicting harassment and discrimination. Thus, if kids don't look like their peers or how others think that they should, they tend to be harmed more often. HB 1686 seeks to prohibit medical care that has the potential to actually help decrease trauma in youth. And in fact, in 2022, the NCTSN issued a statement that gender-affirming care is trauma-informed care. Both the Texas Psychological Association and the American Psychological Association support gender-affirming psychological care and psychologists' important role in helping parents make decisions about possible medical care for their children. The role of psychologists and other mental health professionals in the care of transgender youth includes a careful assessment of DSM-5 criteria for gender dysphoria, with particular attention to a young person and their parents describing insistent, consistent, and persistent gender identity that does not align with sex assigned at birth. Furthermore, psychologists support parents in understanding normal child and adolescent development and provide treatment recommendations for parents to make the best decisions in the best interest of a child's health. Psychologists follow our APA guidelines for practice with transgender youth, which includes a careful and thoughtful process. Our assessment and treatment process is not quick. It may last months, if not years. This treatment process, like all others for mental health care of youth, is collaborative and involves considerations of the goals of the young person, as well as their parents, in the context of professional standards of care and evidence of effective therapies. The role of psychologists often includes supporting transgender youth in the context of harassment and discrimination I referenced earlier, as well as helping them manage expectations, anxiety, and dysphoria while assessing for potential suicide risk. We have considerable important data about the mental health benefits of medical interventions, including puberty blockers and hormone treatments for transgender youth who desire to have those treatments. Research has demonstrated that gender-affirming medical care decreases thoughts of suicide and suicide attempts. I do have your citation, Dr. Oliverson. Depression and anxiety, as well as increases self-confidence and improves body image. With appropriate medical care, transgender youth may have a decreased need for therapy and psychotropic medication. In addition to the evidence of the positive mental health impacts of gender-affirming medical care, we also have data about the potential psychological harms of delaying treatment when youth desire it. For example, beginning medical treatments at a later age has been associated with worsening mental health, including increased risk of suicidal ideation, suicide attempts, and self-harming behaviors. Furthermore, these youth continue to experience gender dysphoria, and this may worsen, which can result in increased or continued reliance on psychotropic medications and therapy, thus requiring a young person who seeks evidence-based gender-affirming medical care to delay it is not a neutral option. It is one that creates increased risk for psychological distress. I urge you to consider what science tells us consistently. Gender-affirming medical care is a recommended evidence-based approach to treat gender dysphoria in youth. It is supported by every major mental health and medical association in this country and is in keeping with my ethics code as a psychologist. To restrict or prohibit this care will create worsening mental health for a population of young people that are already disproportionately impacted by trauma compared to their peers. At a time when we already have a mental health workforce shortage in our state, I'm concerned that this bill may result in increased demand and lengthier wait times for psychological treatment for an already vulnerable population. TPA and I thus strongly urge you to oppose HB 1686.
Questions, members? Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here today. Psychiatrist or psychologist?
Psychologist.
So do you assist some of these folks, young children, in transition?
I assist in their mental health care during transition. That's what you're asking, sir.
So are you supportive of it with the individuals?
I think that's a fair statement in the context of, doing, again, a careful assessment, collaborating with parents, collaborating with the young person.
So as we go through this, if this bill passes the way that it is, you can continue to do the services you do. They just won't be able to get the medication, and they may not be able to get the surgery. Is that correct?
That's correct.
So you could continue to emotionally or mentally transition them. Is that's what it sounds like is accurate, correct?
Yeah, I don't think I would use the language to emotionally or mentally transition a young
What would
person,
you
but
say?
I would still be able to practice, which I believe is your question.
But when you practice, would you be assisting them in their goal of transitioning, if that's what they wanted?
I assist young people and their parents in their goals that we reach collaboratively. And if this bill is passed and medical interventions are no longer possible, I would not have that option in the state of Texas. So I would work on other mental health treatments to help, try to relieve symptoms of dysphoria, anxiety, depression, those sorts of things.
Would you recommend that they maybe go out of state or do different things if you thought that they really needed it?
I think that would be a question that is better served by legal counsel than a psychologist for that sort of care.
Well, but that's why you're here today, is to tell me what you do, what you would do, how you do. Like, if you believe someone that really needs help, would you recommend them? It wouldn't be illegal in this bill, so would you do it?
If it was not something that would put parents and young people at risk and they were able to get and receive appropriate care elsewhere, that might be an option I would consider.
Well, I think what's happening right now puts them at risk. So I'm going to ask you the same thing I do everybody else.
Yes, sir.
Do you teach?
No, I'm on clinical faculty at Baylor College of Medicine and UT Health Science Center at Houston, but I don't teach per se. I occasionally guest lecture.
And one of those at least is public school, correct?
Yes, sir. I receive no financial funding from either of those institutions. It's a voluntary clinical appointment at both places.
What's a woman?
So a biological woman or a woman, female, is somebody that generally we would describe as having XX chromosomes, uterus, eggs, vagina.
Okay. Can a man have a baby?
Thank you for circling back to that question. So what I believe I understood your question earlier, right, is a biological man, somebody who has an XY chromosome profile, testes, penis, et cetera, could that person have a baby? And no.
But can any kind of man have a baby? Any at all?
If you're talking about someone who identifies as a transgender man who has the biological profile of XX, uterus, eggs, that sort of thing, that person would be able to have a baby. But that's really about gender identity as opposed to their biological sex, which is how I understood your question.
So you're basically saying that if someone was a female biologically, transitions to what you would call a man, that they can have a baby?
Somebody with, yes, with XX chromosome profile, uterus, that sort of structure, and identifies as a transgender male, that yes, that person is able to have a baby.
Even with all the medication that's given to them and all the atrophy and all the things that happen because of the medication, they could still have a baby?
Oh, so that is a level of medical detail that I would rather leave to my physician colleagues, if I might.
Okay. Thank you for answering my questions.
Yes, sir.
Representative Smith?
Thank you, Madam Chair. Doctor, thank you for being here.
Yes, sir. Thank you.
Kind of helping us dig down into this and giving us kind of a ground level view. I appreciate it very much.
I'll do my best.
How long have you been practicing? I missed that.
So I have been licensed in the state of Texas since 2008.
And since that time, have you been, can you give us the parameters of your practice? Is it just children or is it adults and children? What do you do?
So my primary specialty is children and adolescents. I do see a few young adults and occasionally parents or, adults who maybe I had seen their children before. We've established rapport, that sort of thing.
And can you give us an idea as to what percentage of your practice currently is involved with children who may have some indication of gender dysphoria?
I was trying to make a guess about that this morning, and I think probably right now in my current caseload, maybe 50%, somewhere in that neck of the woods.
Okay. And so I think you were here, and did you hear the information from the previous witness? And I think I'm pronouncing this wrong, Mr. Sapir?
Yes, sir.
Did you hear that testimony?
Yes, sir.
Did you hear what he said about the increase in numbers that some of the research has borne out? In your experience in Houston, has that been your experience? Of course, you've just been practicing since 2008.
Right, yeah, and did a lot of other things also prior to really kind of being known for some of this care. So, and I think that actually speaks to the point of once I became known as somebody who had done a lot of work kind of catching up to speed on research, standards of care, that sort of thing, my referral rate did increase for transgender youth. Because of that reason, families were seeking out people who had information. And so while I can't speak to that specific statistic about the UK center with the 4,000%, I think that trend does make some sense in terms of when centers or providers become known for providing good care, they do experience some increases in referrals.
Okay. And did you see, when you see someone that presents with what you could think is gender dysphoria, is that's a subjective evaluation on your part, is it not? As opposed to an objective?
No, gender dysphoria has diagnostic criteria laid out in our DSM-5 statistical manual. So I have to meet those criteria to diagnose somebody with gender dysphoria.
And is that information something that you gather from the patient, or is there an objective test of some sort that you can give them to determine that?
There is not a test per se, no, but through interviews with the young person, with their parents, sometimes collateral information from physicians, schools, that sort of thing, maybe other important caregivers in their lives. So it is not just based on a young person telling me, which there was a reference made to my Senate testimony earlier by the previous witness when asked if a young person tells me they're trans, do I believe them? The answer is yes, I believe that that's how they identify. And also, I gather a lot of other data from the young person, from their parents, from other important people.
But understandably, and that's just the work that you do, is that you have to rely on what's told you by an individual. There's not some type of objective test that you can give a child and say, oh, you have just...
So there are lots of objective measures that we can check for, like other mental health diagnoses that might be comorbid. So different, child behavior checklists, things like that. So when needed, if I've got a complex diagnostic question and I'm not sure that I can kind of tease that apart objectively through interview, I certainly can give other measures to help me clarify that.
Okay. You heard Mr. Sapir's testimony about the spike in the COVID time period.
I'm so sorry. What was that last part, sir?
In the COVID time period, 2020, somewhere in there. In your experience, in your practice, did you see that spike for gender dysphoria during that time period?
Specifically tied to COVID, I don't know that I would say that.
Maybe not specifically tied to COVID, but during
Okay,
that
but just
time
sort of in recent years, is that what you're
Yes.
asking? Yeah, I mean, so I think there is a trend in terms of more people telling us that they're trans, right? I think, a lot more information is out there. Kids are learning language to describe some of their experiences. And so I think that it's fair to say numbers of children reporting that to us seems higher, but also there seems to be data that tells us overall that the rates are about the same in terms of like presentation to clinics. And I believe one of my colleagues coming up later today is going to talk a little bit about that data.
Maybe explain that.
Yes, sir.
In your practice, do you ever see children that come in as a part of these, I think the word that was used was clusters, friend groups? Do you ever have a situation where someone presents with what you believe to be gender dysphoria just based on talking to all the folks that you talk to, but then you find that there's this influence, this peer influence that goes into it?
So clusters, I don't believe was my word, but what I do think is true is that young people find other like young people, right? So trans young people might well find other trans young people who understand their experiences, just like, other young, other teenagers of other demographic groups might kind of cluster together. It feels good and it feels comfortable to be around others of your same kind of age and kind of similar experiences.
Sure.
But to the question of do I think they're being influenced by their peers, that has not been my experience. And I would say that, again, through the kinds of questions that I ask, through interviews, through assessment with young people and their parents, that is something I'm attentive to be sure. It's a question I'm asked regularly by parents, as a matter of fact. Oh, my child's friend group, they all seem to be LGBTQ+. Is this them just trying to fit in, that sort of thing? So I certainly am careful and cautious about asking those sorts of questions in an evaluation to make sure that I'm providing an appropriate diagnosis.
Do most children that present with gender dysphoria also present with any other issues, emotional issues?
Yeah, thanks for that. I think yes, right? So data is pretty clear that our trans kids have a lot of depression, a lot of anxiety, and as I referenced in my testimony, a lot of history of trauma, that they tend to be abused, harassed, et cetera, at school and communities, things like that. So I also, because I'm a trauma-focused person, see higher rates of post-traumatic stress disorder, acute stress disorder, those sorts of things as well.
Do you ever have a child that you believe presents with complaints of gender dysphoria, but that you do not believe should be transitioning?
Not with gender dysphoria, but there are kids who come to me and say, I'm not cisgender, right? Like I don't identify as the sex I was assigned at birth. And I say, okay, well, we need to talk about this some more, right? Like they're not saying I am this or I am that, and I'm having the kind of clinical distress that would be required for the criteria of gender dysphoria. So yeah, I do have young people that I see that we have a lot more conversation and that actually have never been referred for medical treatments.
Now, have you ever had someone who's received medical treatment to transition that you believe should not be transitioning?
No, sir. The young people that I've personally had contact with have had really good evaluations and assessments prior to medical treatment, if that was done by other providers prior to me.
Okay, so there's never been a time when you said, you know what, I just don't think you ought to be transitioning.
No, sir, not that I can recall in my practice.
Okay. Now, on the referral sources, you've got word of mouth.
Yes, sir.
Right? And by the way, I'm left-handed. I didn't realize I was such a victim. I may need
My
to
grandfather
come talk
was
to you about
too.
this. Absolutely. But on the referral sources, you have word of mouth, but then you have physician referrals.
Yes, sir.
Right? And so you work closely with these physician referrals.
Yes, sir.
Right? And I don't know, I'm just a lawyer, but do we have specialties now in gender issues, gender transition issues?
I don't know about kind of like medical credentialing for specialties. What I would say is that in my practice, the kinds of providers that I work with most are pediatricians, adolescent medicine specialists, endocrinologists. So that tends to be the spectrum, in addition to, of course, psychiatrists, that sort of thing.
And then you have some of these doctors, though, they may be a pediatrician, but they've decided that they're going to specialize in gender transition issues.
That's my understanding.
Okay, and it could be the same way for endocrinologist or any of the other specialties that you named, right?
Right, like even talking about myself and my own license, I'd be a good example, right? So there's not a specialty within psychology for gender-related care. I'm a general practitioner, I'm a licensed psychologist, we just kind of have that category in the state of Texas. And then there are some specialties, but this is not one of those specialties in the field of psychology. But according to my ethics code, what I have needed to do is go on and do additional research, training, read as much as I can to try to make sure that I'm competent to this practice. So I can't speak whether that's the same sort of criteria for physicians, but I would expect so.
And I appreciate that.
Yes, sir.
And not to get too off into your own business, but just so I understand, 50% in connection with this, what percentage comes from referrals?
Comes, what kind of
Well,
referrals?
you said 50%
Sorry.
of your practice is in connection with dysphoria.
Yes, I think that's probably about
What
right.
percentage of that comes from physician referrals?
Oh, from physician referrals. I don't know. I would be happy to look back at my referrals and get that to you. I would say, if I was going to spitball it with you, maybe half of that half, so maybe a quarter of all of my
Your
clients.
practice? Okay.
Maybe, but again, I think that's probably an overestimate because the more usual procedure is for them to come to me first before they're with physicians. So it might be that a pediatrician has referred them to me, but it's not usually like they've already initiated some sort of treatment for gender-related care before seeing me, if that makes sense.
And in your experience, these doctors who, whether they refer to you or you refer to them, that are involved in this area, these guys are becoming more and more specialized in this area. Would you say that's fair? The doctors that you deal with?
I would say the doctors that I work with closely are working very hard on their continuing education, continuing medical education to make sure that they are up to speed on the kind of data that we have concerns about here today.
But you have doctors who just solely specialize on gender transitioning issues. Wouldn't that be correct?
No, sir, I don't believe so. I think
Where
the
most
ones,
of their practice is?
I think there are certainly ones that's the majority of their practice. I don't think there's any that's the only thing that they do.
I got you. And are these doctors in clinics that handle the majority of their practice in the clinic is in connection with these issues?
I mean, they are all tied to some sort of medical clinic or another.
Right. Okay. Because I remember in the last time we heard this bill that there were several clinics around the state with medical doctors that this is really what they dealt with.
Mm-hmm.
And so I'm wondering, I don't know if you deal with any of those or not, and I'm not going to ask you that. But it's fair to say that since 2007, the business of all this for doctors has grown exponentially to the point where you now have you have a lot of physicians, or you have a number of physicians who the majority of their practice is in connection with gender transition, correct?
I think that's a fair statement. And these are also physicians who do a lot of other things also, or could.
But the majority of their practice may be in connection with this, right?
And I think that's in part because there's so few of them. So the demand and supply issue becomes real for a lot of families seeking this care.
I know, but at the end of the day, what we're talking about is really having a negative, with this legislation, we're going to have a very negative impact on a few doctors, aren't we?
I think the negative impact will be on children and their families.
And the doctors?
I don't.
Will have a negative impact, and that could be the reason why we're seeing some of the testimony here today. Isn't that correct?
The doctors I work with are not motivated by finances. They're motivated by care for children.
Well, I know doctors just don't care about money at all. Thank you very much.
Representative Oliverson.
Thank you, Madam Chair, and I'm glad to hear us laughing occasionally in here. That gives me hope for humanity. So, Dr. Mooney, it's great to meet you in person, and I'm glad you're here, and appreciate you bringing some studies and stuff. So, I did want to ask you, with respect to, you were talking about, you said something which I thought was very interesting, and it kind of contradicts, you know, some of what we've already heard. So I wanted to explore it with you a little bit, and that has to do with this concept that that essentially the transgender identity is essentially the root cause of other comorbid psychiatric conditions. Is that, I thought that's what you said, that essentially a lot of the trauma that people experience is because they're trans, and so once they identify as trans, then their life is traumatized. Is that?
So
Let's talk about that.
yes, thank you for asking me to clarify on that. So what I would say is that what data in the trauma world suggests is that when children have what's described as a gender nonconforming presentation, so they don't look like somebody thinks they should, that seems to be one of the factors that sets them up to be abused and harassed more than their other peers. Now that, for the record, is not just trans kids. That's other LGBT kids also in the samples that that when they don't kind of look like their peers think they should. Look, I work with kids every day. They can be kind of ruthless sometimes. I love them. But sometimes, you know, they say kind of mean things to each other. And so that is one of the things that sets them up, especially for school-based bullying and harassment, is peer-based kind of comments, really awful things that other researchers have kind of classified that are said to and about transgender kids at school. So that's one of our big sources of data, is kind of school-based data that's collected by GLSEN every other year, that they kind of tell us the rates of discrimination and harassment the kids are facing at school. So that's one of the areas.
So how is that data collected?
They do large surveys of high school kids across the country every other year.
So it's a self-identified, self-reported survey kind of thing again?
Correct.
No control group?
That's correct.
No, okay. All right, so, okay, and you said you had some studies for me. So when we're talking about this issue of, you know, these comorbid mental health issues arising as a result of someone being transgender, are there studies to back that up?
So you raised an interesting point earlier about causation being one of our problems.
Yeah, because I really want to drill into this.
And what I want to be clear about is that being trans does not equate to somebody being mentally ill. That is not what I am trying to imply or to communicate here today. What I do think that, again, the research I see in trauma literature is that kids who are trans are experiencing worse rates of being discriminated against, harassed, you know, than their peers. And that then sets them up for, it could be, you know, depending on the severity of harassment or discrimination, it could be post-traumatic stress disorder, anxiety, depression, et cetera. So there was a reference earlier, I'm sorry, it's getting a little hazy at this point in the day on who said things. But, you know, kind of this idea that we shouldn't just blame this or this or this and say that causes suicide, right? And that's absolutely true, right? That suicide risk is determined by a complex amount of factors. One thing is bullying and harassment based on gender identity.
Makes sense.
One thing is, you know, that peer victimization that seems to be moderated or moderates effects of already existing depression. So some kids are already sort of naturally depressed, not anything to do with their trans identity. And so that combination does seem to be something that, you know, kind of particularly predicts potential suicidal ideation for young people.
So, and I'm going to throw a study back at you, and if you haven't heard of it, that's totally
Gotta help me,
cool.
I've got a stack. We'll see what we can do.
So, Becerra, 2018, looking at this very issue, concluded that 70% of kids who had comorbid mental health issues, that the mental health issues predated any diagnosis or symptomatology affiliated with gender dysphoria.
I certainly can't dispute what was in that study. What I would say is...
Well, I mean, that's really the opposite of what you just said, honestly.
Well, No, because what I said was that trauma then does seem to, so PTSD is one of those rare diagnoses we can say has, kind of a
Right.
causal identifying incident or incidents, right? So again, with my lens as being a trauma-focused person, that's part of what, and how I came to this work, is looking at my
Yeah.
kids who'd experienced that kind of harassment. So I had sort of like causal events in a timeline, and I can look and see, did we already have a gender dysphoria diagnosis prior to that harassment? Did we not? So
Right.
certainly as part of the kind of considerate care I was describing over here earlier, that, I want to pay attention to those timelines, right? Did a kid already have symptoms of depression, anxiety, et cetera, that predated any sort of signs of, gender identity that doesn't match the sex assigned at birth, or them telling somebody that? I mean, yes, it matters. It's not the only thing that determines my treatment.
Well, I understand that, but I think it's, I guess what I was trying to get back to is just the idea of, I do think, and this is one of the conundrums that you face in this area of psychology that you're practicing, is that it is very much a chicken or the egg kind of hypothesis, right? It's sometimes difficult to unwind which came first. Was it the comorbid psychiatric conditions, or was it the gender dysphoria? How, in your practice, in your experience, and I know there's good studies on this, but I'm not going to quote data to you. I'm just wondering about your experience. Do you see a higher rate of autism and autism spectrum disorder for your transgender identified youth?
Yes, and that is definitely.
Why is that, do you
literature.
think?
There are some great studies being done on that right now. John Strang at Children's National in DC is working on trying to understand that. There seem to be some genetic links that might underpin both. We don't have good understanding of that. Other theories are that sort of the wonderfully creative thinking of autism, people with autism spectrum also allows them to be creative about gender identity.
Yeah.
I don't have an answer for you about that, but yes, that certainly holds up in my practice.
And so what other comorbid mental health? I mean, well, okay, we've talked about, suicide risk. We've talked about anxiety, depression. What about eating disorders? Is that more common amongst trans youth?
That is certainly in the literature. I have not had that in my practice, which I think you
Okay.
also asked me to address, but yes, I
Yeah.
do see that in the literature as well.
Okay. So one of the things that, as we talk about this, and again, I just kind of want to make sure everybody's, get all the facts on the table here. What we all need at the end of the day is a comprehensive worldview of what is known and what is not known, what is thought to be known, and maybe what is assumed to be known that may not be true. The Cass report, in its decision to basically close the Tavistock Clinic, highlighted an issue that is very close to what you and I have been talking about, which is diagnostic overshadowing. And that is the idea that because the mental health issues in this population are so complex, it is difficult to sort out the gender dysphoria issues from the comorbid mental health conditions, and especially as relates to feelings of depression, anxiety, suicide. There are many, many, many other reasons why a child could potentially feel those things. But there seems to be a rush, at least in this country, to sort of shove that all into the drawer of, well, it's because they're trans.
All I can say to that is not my experience in terms of how I operate clinically and the providers that I know.
Okay.
That I don't see a rush to treatment happening here in Texas. I see that the clinicians I work with are very careful and are working very closely with parents to make sure that they are providing as much information as possible for parents to make a good decision for their young person.
Okay. And you said, this is sort of last question, and it just sort of occurred to me, because I'm looking at the witness list here. You said that about 50% of your practice is in this area of specialty.
Right, is some sort of gender diversity?
So do you,
yes, sir.
So do you refer patients to Dr. Zwiener?
I don't know that I have referred anybody to Dr. Zwiener. She is certain, not specifically. What I usually do for my clients is I have a list of providers that I know specialize in gender-related care, and so I usually provide that list. And Dr. Zwiener's practice is on that for older adolescents. And
She seems to be kind of authoritative and very involved. I noticed that you guys have a connection to, I think, Baylor as well.
I think she mentioned UT Health. I think.
Oh, did she say? I'm sorry.
That's
I might
okay.
have misheard.
But
Okay,
you know,
my
it's a large
apologies.
institution, so I don't think I even knew that till her testimony today.
So how many physicians so you're in the Houston area, she's in the Houston area, so how many physicians do you work with, endocrinologists, as you refer to?
So it's a little bit tricky. There are clinics that have kind of multiple providers in them, and I'm kind of trying to think of like how many providers in those clinics right now. So I would say there's like,
So how many clinics?
I think there's 3 or 4, I would.
3 or 4?
Yes,
and,
sir.
and they're all in the Harris County,
Yes,
Houston
sir.
area? Okay. Okay. All right, and just, and I'm not trying to be ugly here, but I am curious. I've always been curious. So I know that medical insurance pays for a lot of transitioning services, so I would assume that an endocrinologist services would be covered, but do they pay for psychology, are your services reimbursed by insurance?
I actually don't accept insurance in my practice.
So you're cash pay?
Correct.
Okay. All right, thank you. I appreciate it, Dr. Mooney, and I appreciate you. I know you were here for the Senate side too, so thanks for coming back and visiting with us.
Thank you, Dr. Oliverson.
Representative Campos?
Yes, I have a question. So all of your patients, are they adolescents that are transitioning or?
No, ma'am.
No, okay, so some of them are maybe not sure whether or not their gender, can you kind of?
Yeah, so again, I'm a general practitioner by training, right? So I see lots of kids and teens for a whole bunch of other stuff that doesn't have anything related to do with gender. So that's kind of the other 50% or so on average of my practice. And then even within those who are referred to me for gender-related care, not all of them are doing anything medically related or even necessarily, kind of as we talked about earlier, social transition. So some are still figuring out what is, how do they identify, what's the right language to fit, they've got questions, and that's part of my role to help them figure that out.
So when they come to you, are they already on medication and going through counseling, or do you get them started on medication? Like, what is your process?
So as I said before, I don't think I'd be hard-pressed right this moment to tell you that I had anybody that I am seeing currently or have previously seen that had started, certainly not hormones, maybe some who had started blockers before coming to me. They'd been assessed by a different mental health treatment provider before coming to me, that sort of thing. But so usually the referral is they come to me first for help with evaluation, assessment, treatment, before there's a referral made for a physician for possible consultation about medical care.
Okay, thank you for that.
Yes,
Representative Tinderholt?
Thank you, Madam Chair. So when you do these referrals to these doctors, and I'm going to include any clinic, hospital, doctor, medical professional, are there any fees that change hands because you refer them?
No, sir.
Okay. I just had to ask because I don't know how it works.
I appreciate it.
so.
No, sir, never.
Thank you.
Other questions, members? Thank you.
Thank you.
The chair calls Karina Khan, or Cone. Karina, if you could state your name for me, and I understand you're representing yourself, is that correct?
Yes, Madam Chair.
And you are for the bill.
I am in support of the bill, yes, ma'am.
And your last name, did I pronounce it correctly? Or not?
Cone, yes, ma'am.
All right, thank you. Please begin your testimony.
Thank you. Chairman Click and other committee members, my name is Corinna Cone. I'm here today in support of HB 1686. When I was 15 years old, my psychologist diagnosed me with gender identity disorder. I started taking estrogen when I was 18. In 1994, when I was 19, I had sex reassignment surgery. Although I believed I was changing my sex, I now understand fully that any such change is merely cosmetic. This is a realization that every sex-changed child will eventually need to come to terms with in adulthood. Over the past 2 years, I have encouraged Republicans and Democrats to work together on regulating the practice of pediatric gender care. I also make a point of having open and good faith discussions with people who oppose this bill. One thing all of us share is a passion for the welfare of children. I believe that the best outcomes require that all parties come to the table with parents, policy experts, and dissenting doctors and therapists so we can close the major gaps between the evidence and the practice in this field. Those of us here testifying in support watched, unsurprised, as countries such as Sweden, Finland, England, and Norway have brought their practices into alignment with the data. And the result is tight restrictions on clinics who specialize in sex-changing children. Having spoken with opponents of HB 1686, I now realize that our two sides are working within different paradigms. Our side, those in support of this legislation, oppose it on the basis that it is not good medicine, and it's not good medicine because there is no solid evidentiary basis that it's effective. We oppose it because we see a steady flow of young people, irreversibly harmed, tell their stories of how they were neglected by the system. We call these detransitioners. We cannot see eye to eye with our opponents because they were here on the basis that gender-affirming care is a gateway for people to achieve their authentic selves. In fact, this very morning, I joined the clergy who opposed this bill as they gave a prayer, and in it they acknowledged and thanked the Creator for making our bodies fluid. For our opponents, this bill must be stopped because it will delay children from achieving their destinies as members of the opposite sex. I'm sorry to say, but our opponents are misguided. Authenticity is something you discover by living and growing, not by taking hormones or having surgery. Every person in this building has come to this day by trying and failing and learning from their experiences. We cannot protect children from growing up, and the misguided attempts through medicalization will only lead to future pain. It is time for Texas to follow the evidence and for this body to take up its proper mantle as regulator of last resort. Even though you will hear sincere and passionate emotional appeals to oppose this bill, you are our last chance for protecting children. Thank you.
Questions, members? Representative Jones?
Thank you so much, Madam Chairwoman, and thank you so much for your testimony. I wanted to ask, just to clarify, as far as, and I just want to make sure I'm getting language correct, your transition did not start until 18? Or I guess, could you explain, I know you mentioned 15. Could you explain to me 15, 18?
Yes, around middle school, I came out to my mother and, I'm sorry, a little bit earlier than that, I started having ideations about having a sex change, basically. I wanted to grow up and become a woman. I came out to my mother when I was 15, and she brought me back to the child psychologist that I had seen when I was 15. And after working with her for several appointments, I was diagnosed with gender identity disorder. And so that would be the point that I first had a clinical diagnosis of being transgender, I guess you would say. We didn't use that language back then, but that's maybe updated for the times.
No problem. And then during that time, after you received diagnosis, could you just share a little bit, as far as what you're comfortable with, just sharing what happened between that time and between then and to actually becoming an adult?
Yeah, thank you for asking. I testified last week and took it out of this week's. I have a pretty good claim to being one of the first people to find a pathway to transition on the internet. In 1992, before the World Wide Web even existed, I found a community of other similar people to me on a system called IRC, which is a chat channel. And I was somebody who had a pretty difficult time in high school, or any school, I should say, K through 12, making friend groups. And when I was able to get onto a community online, I discovered back then what a lot of young people who are marginalized and excluded discover, which is that there is actually a lot of people out there who will accept you. And I found that there were a number of adults. And keep in mind, the community back then was very, very much, we would say male to female transsexuals at the time. But they were generally older, 30s, 40s, or 50s, and they were extremely affirming of me, gave me a lot of support. And to be fair, at that time in my life, I didn't have very much of that in my school or in my home. When I came out to my mother, I hope she's not watching because this is totally different now, but she flipped out. She was dealing with some of her own issues at the time, but I ended up being kicked out when I was 17. And as far as an emotional support network goes, I totally understand why the online community is so important. But what I've come to discover in retrospect is that the people who you meet online don't have any sort of obligations to you. So while it is easy for everybody to boost other people up very easily and give a lot of affirmation and tell you that you're beautiful, tell you that you're important, if you need them to stop by your house and feed your cat because testimony is running past the time that your flight's supposed to leave, they won't do that. But the people that you actually interact with in real life and become friends with will. So thank you, Aaron and Carrie, for watching my cat tonight.
And before I get to my last question, first and foremost, I want to say, regardless of what side of this issue that you're on, I have a lot of respect for you for getting up and sharing your story, because it's very important for your story to be told. Very much so different sides of this conversation. And so one thing I just wanted to ask you, talk a lot about the influence of the internet. Can you talk a little bit about the influence of parents in this conversation? We hear a lot about parents persuading their children to do this. Could you talk a little bit about that and how did that play off in your life?
In my personal experience, Representative, my father was indifferent, unfortunately. He was saying if you wanted to do that, you need to do whatever makes you happy. So I guess he was neutral on the issue. But my mom was very bitterly opposed to it. And I didn't have any family support. It's a little more difficult for me to broaden that to other families. I have heard, of course, I've been part of the community for 30 years, so I've heard all sorts of different stories from people whose parents were affirming and those who weren't. But I think that you'll find the stories across the entire range.
Thank you so much. I really appreciate it.
Representative Tinderholt.
Thank you, Madam Chair. Karina.
Yes.
Brave. I'm going to ask you some sensitive questions. You don't have to answer them.
Please do.
But I want to ask because I think I know some of the answers, but I don't want you to feel obligated to answer them. What's communication within the trans network like in regards to suicide?
In the last year, the communication that happens in the online communities that I track, which is Twitter and Reddit, there has come to be something of a fever mood about the idea that there's an oncoming genocide that is being conducted by individuals such as yourselves and me. There are accusations that anybody who's taking any position on a policy that's this sensitive, that if they're on the wrong side of it, then they're complicit in the deaths of people. And when it comes to suicide, one of the most common messages that is used in tandem with opposing this class of bills, which I'm here to testify only on a youth medical bill. But there's, of course, a larger spectrum of bills that would affect people who identify as transgender. Regardless of any of those other types of bills that are being discussed, it is very common that in tandem, people are urged to oppose them because they will cause people to commit suicide. I'm sort of on the outs of my community. I do have a couple of people with whom I communicate privately, and I have been trying to persuade people that we should lower the temperature, specifically on that sort of language, because we know from, for example, the Samaritan's Media Guide, that certain types of messaging about suicide can plant ideas about committing suicide. And so it's even for people who oppose this, which, I adore we have this democratic process that people can. I would really ask for everybody on the opposition side to not make a claim that people will commit suicide if they do, because unfortunately, that From what we know from the research, that seems like it's going to make it more likely that suicides do happen.
Well, when you say my community, I would say that you and even the people on the opposite side are our community, Texans. Regardless of whether we agree what's happened during your childhood or even in adulthood, we're all a part of the same community, and we need to respect one another. Today I'm trying to protect children, and when we do that, you said 30 years.
Yes.
You've been dealing with so that's interesting, because my next question kind of pertains to that. Do you think there should be protections for people like you to be able to sue people that may have assisted in the abuse that happened as a child, maybe 10, 15, 20 years, 30 years later, for you to go back and detransition? Do you think there should be some kind of mechanism for that?
Yes, sir, I do. That is a little beyond the bounds of the bill, so I'm going to keep my comment short on that.
The reason I'm asking is obviously I'm talking about the same things, and I'm going to want to try to see if we can get something like that in there, because I think you deserve it.
From the work that I've done over the last several years and from many of the stories that I've heard, sir, there is a large gap between what the standards of care are as published by WPATH, and even there that's a little contentious because there's some questions whether that's really even a standard of care. But if you read the World Professional Association of Transgender Health Guidelines, they have a lot of explicit information about what constitutes being able to assess competency in adolescence, as well as what it actually takes to achieve consent in that relationship between the parents, the child, and the team of doctors. What we know is that every doctor who participates in this sort of care according to the WPATH standards should be making an independent call and judgment on whether the patient that they're treating is competent. What we know from stories from people inside of our network and people who detransition, you'll hear some more of these stories today, these assessments are not happening. And so the standard of care that everybody in this practice should be adhering to, they're not doing it. What's more is that in direct conversations that I've had with clinicians in several states in the last 2 years, I've been told repeatedly by practicing clinicians that in their opinion that the WPATH standards are too conservative and that they are not closely followed inside of their own practices. And sir, that includes one of the co-directors of the Indianapolis Riley Children's Clinic, who told me the same thing. And what I said to him is that if the standards of care, if the practices of the clinicians were at a much higher level, then one, we wouldn't see so many detransitioners coming out of the woodwork. They're here because there was no proper assessment for the most part. In some cases, you'll hear that there was a proper assessment and people detransitioned anyway, but we know that the standards are just the corners are being cut. And when we try to talk to the clinicians and we say, there is the standard, you can get certified in it. And they tell us, frankly, no, we think that that's too much of gatekeeping. We would rather allow people to come in and accomplish their goal of their personal development goals of transition than having any of these sorts of gatekeeping processes. We believe that they're telling the truth. They're professionals in the business. But it's very disheartening because the other mechanisms that we might have available in order to make sure that bad practitioners are not in the business are more or less unavailable. And I'll give you just the most urgent thing. Most lawyers will not take phone calls from detransitioners because there is not enough for their firms to be able to build a case on for injury. And so even when the injury is apparent, and it goes beyond just an assessment of competency, but when the injury is actually a health injury and causes disability, even then lawyers will not take up those lawsuits because there's just nothing for them to build a case on as it stands. And that might change in the future, but I've heard personal anecdotes from many people who have looked at suing, And I've heard of more people giving up trying to sue and not being able to even have a meeting with attorneys just because of the nature of their injury.
And I think that cap is like $250,000 right now. I think that's what the number is. So I'm just going to ask you one more question.
Okay.
When you started the process, was there any time between the beginning of the process and the time that you transitioned where what we hear when we talk to people that are detransitioning, the medical professional, specifically the psychologist, and you may not know, told mom that your child will commit suicide or we need to do this process? Have you heard that with you or with any of your peers?
Not with me, but you'll hear several stories like that from some of the other detransitioners. It's a very common thing. I speak with parents as well, and that is one of the most common, I guess you'd almost say a trope of the clinical practice, is for children often in front of their parents to be, or parents often in front of their children to be told, if you don't let this child transition, they'll kill themselves.
So I said one more question, but I'm going to add one more too, because you kind of led me there. Would you say that some or all of the mental health professionals are assisting or participating in or pushing the transition? That they are part of the process, a huge part, and they're actually pushing it?
Yes. I can talk about some of my own personal experience with clinicians who, of course, I'm not a mind reader, so this is just my opinion or my inferences. But I have worked with a number of clinicians over the last 30 years who take a real pleasure in watching me be trans. My first endocrinologist was a woman in San Francisco who, and I know there's doctors in the room and on this panel, so I've heard only one thing about this, so I might hear a conflicting thing today. But she used to feel my breasts every single appointment that I would visit her to assess my breast development. I'm given to understand that that's actually not something that ought to be happening, particularly by the person providing you hormones, but she seemed, I'm guessing that that's not standard practice. Yeah, it was confusing. And I do get the sense, this wouldn't be all clinicians that I have worked with, but certainly some of them really seem to get something from their particular client base.
So you like this bill because you're for it.
Yes.
You're supporting it, and so do I. Do you have concerns that those psychologists may still be able to continue their part of the work?
If psychology is working correctly, and
so let me stop you there.
Yeah, go ahead.
I'm talking about the psychologists, like the one we had speak earlier,
Yes, sir.
will be able to continue the emotional and mental transition without the surgery. Do you think that's a problem if this bill passes without holding them accountable as well?
Sir, if they are open to other strategies other than only gender-affirming therapy, then they should be able to continue working with those client bases, trying to find other methods of therapy that would address any comorbid mental health care problems, as well as finding good strategies, effective strategies for managing their feelings of gender dysphoria.
What about the percentage that are pushing people to get medical procedures done?
I hope that those people who are actually pushing people to have transition surgeries, I hope that those people are properly reported to their medical boards, investigated, and if that's truly what's happening, I hope that they face a hearing to defend their license.
So am I hearing that you hope that they're held accountable?
They absolutely must be held accountable.
Thank you.
Representative Alverson.
Thank you, Madam Chair. Karina, it's great to see you again. And this is obviously not the first conversation that you and I have had, but I think one of my colleagues was just texting me a minute ago that you are far and away the most authentic witness. And I think we all just tremendously admire. I know I personally admire your courage and just your authenticity for being here. And you came all the way from Indiana to testify today, right?
Yes, Representative.
Which is your home state.
It is.
And I think a lot of folks don't know, you kind of alluded to it, but your familiarity with the online community stems from the fact that that is your occupation, is you work in IT, right? So I mean,
Yes, sir.
been doing that for many years. So you kind of talked about this a little bit, but I just want to kind of go back through this conversation because I think this is testimony that you can uniquely offer, given your perspective as a member, of the LGBT community, right? And obviously you don't harbor any animus of any kind against. Nobody's going to argue that that you're anti-trans or that you're anti-LGB, right?
I'm sorry to contradict you, sir, but there are people who argue that I am both of those things.
That say that you are?
Yes, sir.
That's crazy. I guess the first time you and I had this conversation, I remember there was somebody in the room who asked a very pointed question about the suicide issue, and you were talking about your experiences sort of being a member of a lot of these support groups and how adolescents are treated nowadays when they come in and they're basically confused and sort of like, I think I might be
Oh, yes.
trans, and I'm and somebody will. Can you talk about that? I found that to be just fascinating, a conversation that's sort of going on out there in cyberspace that we don't even realize.
Thank you for asking, Representative. You might have heard sometimes in the media, you'll hear that there's like a if you start following the wrong YouTube video, it'll lead you to become radicalized. I don't know if you believe that or not, but what I can tell you is that if you start searching online for the question, am I trans? And you start to go into the websites where those answers exist, that for sure you will not find any sort of independent or neutral evaluation that you would get if you were to see, for example, a psychotherapist. What you see in the online communities is a trend towards reaffirming or affirming to the person asking, well, you wouldn't even be asking if you thought you were trans, if you weren't even a little bit trans. And you can go on Reddit if you're interested. There are a number of communities, for example, like Ask Transgender or M2F or Trans, or there's quite a few of these communities. And you can see that nearly on a daily basis, there will be questions posted by people who are questioning their identity. And although there are sometimes a small number of responses saying something very rational, which is you shouldn't be asking the internet for God's sake. You should be asking your psychotherapist. There are nevertheless a lot of people in those communities who say, well, if you feel a tug of joy when somebody calls you she, that means you're transgender. Or if you imagine changing your name, and that thought makes you happy, you're transgender. Or if you like wearing clothes of the opposite sex and that gives you a form of euphoria, that means you're transgender. So a lot of people who are looking on the internet for guidance, which I think every time any of us are sick, we type that in Google and figure out what it is. They're being led to all of these sorts of communities where they're getting the message over and over. If you doubt at all, then you should consider that you're transgender. And by the way, here's some quizzes that you can take. There's a pretty popular guide. Unfortunately, I don't have it referenced here, but there's a whole guide that exists to knock down arguments of why somebody is not trans.
Are there conversations in these groups and support, channels, and I don't know the right terms, but in these internet groups, are there conversations that crop up about self-harm and what do people say to somebody who's, honestly, like, I'm thinking about hurting myself kind of thing? What kind of conversations come up then?
I don't recollect any particular conversations about that. I know I've seen it in passing, but I don't, at the top of my memory, remember specific conversations about that.
Okay. Do they ever talk about, strategies for dealing with your parents if your parents maybe aren't supportive, and what you should do and how you should approach that issue?
Yeah, there's online, there are a number of people that you might call influencers who provide what you might also, if you're being generous, call guidance to youths who are in that position. And there's, in fact, a whole vocabulary around helping young people to connect with role models, adult role models outside of their families to help facilitate access to transition resources, which include, by the way, access to hormones without a prescription that will provide young people these drugs just by them saying, I really need some help. So it's sort of these networks, informal networks, providing sometimes overage or extra hormones, or sometimes even what the lingo they call it is bathtub estrogen, which is
that doesn't sound good.
Made in somebody's residence and then shipped out from other countries to the United States, which I should point out that in states where these sorts of bans take effect, there will be a small number of people who continue to seek these types of resources, either through these informal networks or through estrogen overseas. But there's also this idea called a glitter family, which is these are the adult peers who help to teach you about being trans or being gay or lesbian. And I think that there should be good resources. I think the Trevor Project, when it was formed, was developed to have this mission to be a good resource for teenagers who need this sort of assistance, where their parents are disapproving or even hostile towards them, so that these people can get into networks of having help. But what I have observed is that there's no more oversight or adults in the room making sure that these types of networks are free from abuse or manipulation.
Last question. We were talking about lingo, and you kind of triggered something that I think you were talking about over in the Senate hearing,
Yes.
but I wanted to revisit with you. What is cracking the egg? Can you talk about that? What does that mean?
Sure. The term is cracking someone's egg. This is trans lingo, and relatively modern. And the idea is that if you find somebody that has a little bit of indecision or confusion about whether they should identify as transgender or not, that if you are able to take that person under their wing and coach them so that they feel like they're comfortable to come out, then they do. That is said to be cracking somebody's egg, and you'll hear people use maybe the reflective term. They'll say that I hatched on this date, and this is very common lingo now. But hatching is when your egg has been successfully cracked.
And are these medical professionals that crack eggs, or are these just sort of people that like your glitter family and people that you meet and stuff like that?
Sir, I think that if there's any more medical professionals testifying today, you should ask them.
Okay. All right. Okay. Well, Karina, I thank you for being here today. I appreciate your testimony.
Representative Jones.
I think I only have one question.
Yes, ma'am.
I think I heard you say that you believe that people should be able to sue doctors or psychologists, years later you realize you want to detransition. Did I hear you say that? Just want to make sure I heard that.
Ma'am, if I remember correctly, Representative Tenderholt asked me a question that might lead to an answer like that, but I didn't answer in the way to provide that sort of response. So would you like me to answer that question directly?
No, I just thought I heard you say that, but since you said you didn't answer, then I'm cool.
Okay.
If you did answer, I had a question for you.
All right, that's fine.
Thanks.
Corinna, can you talk to the extent that you're capable of medical issues that you might be experiencing over the years?
Representative, thank you for asking. I'm 47 now, and I've been on estrogen for 30 years. And I'm getting to the point where I think it's reasonable. Like, I never thought that I was even going to hit 30, but now I think I want to hit 70, I want to hit 80, and I want to be healthy when I do. But because I am not able to produce my own hormones anymore, at least up to some point in time, I should still be continuing to take some form of hormone replacement therapy, and I do take estrogen still. The last time that I visited my gender clinic, I asked them with this as the context. I said, what do I need to worry about in terms of this gender care in order to make sure that I'm able to reach my senior years and be healthy? And the response that I was given is that, well, as you get into your 50s, we will start to reduce your hormones so that you may experience menopause like other women do. And I said, I beg your pardon, but I'm not a woman. I'm a male who's been taking estrogen, and there's not really a purpose for me to simulate menopause. But I've been doing some research on hypogonadism in men, which is probably the closest analogy to my situation. And I have some specific concerns related to my neurological function, because from what I discovered in my research is that low testosterone levels in men is linked with dementia. So what I was hoping is that when I approached my gender clinic, and as it stands now, it used to be that you would find professionals in the city who had a small number of patients who had my needs, and they would help us. But now everybody gets referred to the gender clinic. My gender clinic, at least as of last year, does not have an endocrinologist on staff. And so they were not able to provide me very much guidance about what sort of long-term harms I might encounter while being on estrogen. What they did say is, well, we have other patients who are in their 60s and even their 70s who are doing fine on estrogen. But my response is that I've been on it for 30 years, and my patient profile is going to be substantially different from somebody who just started on it when they were 70 years old. So there's not even a fair comparison. But ma'am, there's no research at all on people in my state of progression in this medical path, because I am one of the first ones, and I have not been asked to be involved in any sort of research. And I've made a couple of inquiries, or offers, I should say, for people who are involved in this sort of research, and I've been rebuffed. But I think it's going to be extremely important for all children who are coming along this medical pathway that there be a complete set of medical research on what young people are going to have to look forward to as their endocrine systems are stripped away and as their natural sex organs are stripped away. Like, what are the long-term effects of being on hormone replacement therapy, and how are you even going to get access to care? Because for the types of complications that people like me are prone to develop, and I don't want to get too personal, but I'll say that I had sex reassignment surgery, and I don't have anybody who can provide follow-up care for that at this point. And it'd be very difficult to find it without going to California for specific care. These sorts of problems, the gender clinics right now are backed up so long. You're going to hear testimony from people who are righteously upset that it's taken 6 months or a year for their children to be brought to these gender clinics. There's going to be the same wave after wave in every medical discipline as young people who start to develop complications related to this type of care seek help, and the people who they're hoping are experienced in treating these complications just don't exist. But they will.
Thank you, Karina, for sharing that. When we met recently, I know that you, in your role online with the online community, talked about folks that are wanting to detransition and the difficulty they may have in seeking care or finding care.
Yes.
Could you speak to that?
Madam Chair, I'll speak very briefly, but I hope that the testimony of one of the detransitioners will be more useful than mine. This alludes to what I was getting to. For me to be able to get care related to some of the things I've been through is very, very difficult. For the detransitioners, they face not only the same difficulties, but they also face stigma, both from the clinicians that they worked with to facilitate their transition who, in many cases, no longer want to maintain relationships, telling these people that if you're no longer trans, there's nothing I can provide you. But they also face similar sorts of problems trying to access care outside of the gender clinics because doctors will say, what you've been through is not something that I can help you with. You should go see one of the gender specialists because they should have seen this sort of thing already. So some people get trapped in a limbo trying to access care because the gender clinics don't want to do it, and it's very, very difficult to find people outside of them who are willing to.
Representative.
I'm so sorry. I meant to ask you one more question, and I apologize for double dipping, but your medical needs now, much more complex than I think you probably thought they would likely be at age 18. I mean,
Yes, sir.
you have a job, you're working. Does insurance cover this detransition stuff and sort of some of the side effects of your treatment? I mean, how do you get care? Assuming you can find someone who's willing to talk to you, because I've heard from other folks in the detransitioner community that once they make that decision, unfortunately, a lot of times their providers just drop them like a hot potato.
Yes,
but
sir.
assuming you can find somebody that will take care of you, how do you pay for that?
I hope the detransitioners who testify will be able to answer that more completely, but it's rare for insurance to cover it. There have been cases where people fight and fight and fight and fight, and the insurance company finally gives in. There are cases where some insurance coverages are good enough that they provide a little bit of help, but maybe not for everything that might be reversed. I hate to even use the term reversed because there's no reversing any of this. There's cosmetic reversals, but there's no functional reversals.
It's kind of just dealing with the wreckage, right? I mean, to a certain extent, you have these issues now that you didn't have before, and you have to deal with those things, right?
Some people may see it as wreckage, other people may see it as complications.
Okay.
Regardless, they are obstacles that they would not have imagined having to deal with, and most likely were not properly informed by before they started the medicalization pathway.
Okay. Well, again, I just appreciate you being here, and it's my hope that, that the folks that are kind of early in this pathway or are considering it will consider your testimony and maybe really think about what life's going to be like 20, 30 years from now.
I hope so too, sir, but it's so difficult for young people to imagine that. I know I certainly...
Well, maybe their parents will.
I hope so, sir.
All right. Thank you, Karina.
Representative Chatan.
Thank you, Chair. A quick question, and I missed part of your testimony, and so sorry if you already answered this. But one thing that was kind of alluded to earlier is, just mental health professionals make their recommendations based on what information someone's willing to provide to them. Within those online communities that you referenced, is information disseminated on what to say or not to say to get the outcome that you'd like, so that mental health professional provides a reference, referral?
And this isn't new. This has been going back since before I was part of the trans community. There's always an in-network advice on what to say in order to get past the gatekeeping. I think that as fewer and fewer barriers stand between a patient seeking medicalization and they're being granted it, that these networks may, over time, fade. But it has been the practice continually up until this day of what to tell a therapist, up to and including, unfortunately, this is quite common, to say, well, tell your parents that you're suicidal in order to get access to care. This is something that you can verify for yourself pretty easily by just dipping into these communities and see how they talk about it.
That's extremely disheartening to hear. How long is that time frame? Do people talk about how long it takes to go, to make that first, conversation with the mental health provider to when they're actually getting medical service?
I'm going to try to answer that, sir, but something just came to mind is that for young people, there also exist such things as guides on how to come out to your parents. So they include strategies on how to catch your parent off guard so that they're not able to put off the conversation. There's basically templates to use to tell your parents that you're trans. And if you hear from any parents of children who are going through this, what you might hear in testimony over and over is the same story of, oh, they left a note for me on the way out to work, or they told me to watch this video. It probably has 1.9 million views at this point. It's just these templates on how to come out to your parents, which on one hand makes sense because if you've never come out before, I'm sure that after you look out, do I have COVID? Am I transgender? How do I come out to my parents? Makes sense that you would run into one of these notes, but it seems almost like it's manufactured in a way.
Gotcha. Yeah. It's kind of going back to that timeline. How long is that average time between when someone gets that reference guide or told what to say to a mental health provider to that mental health provider providing, some referral to a physician to prescribe anything?
I don't have any average times for you, sir, and I think it's going to vary very much by territory, even within a state, depending on the bandwidth of the providers that are available. But you will hear parents opposed testify to you, very likely that they'll tell you that it took 6 months to a year and a half for their child to actually be seen by the gender clinic.
Okay. All right. Thank you.
Other questions, members? Thank you very much for being here. Chair calls Frank Gonzalez. Frank Gonzalez. I have your name as Frank Gonzalez, and you're representing yourself, and you are opposed to the matter.
That is correct.
Alrighty.
My name is
Please
Frank
begin.
Gonzalez,
Thank you.
and I am here to represent myself. And I here to testify against HB 1686. Can I start? Yeah, thanks. I'm a proud father to 3 amazing kids. My family has been coming here to testify against legislation that would hurt our family for many years. Chairwoman Click, I know you spoke briefly with my daughter Libby in 2021 after a hearing, and many of the members here have seen her around the Capitol over the last 6 years. I appreciate the opportunity to share with all of you today a bit more about my family and my journey and how we came to this very moment. As you can imagine, it's not easy to share so much personal information, but I feel strongly at this point that we've run out of other options. And to be honest, I'm terrified to be here, be this vulnerable in front of you. So I hope that you'll understand the impact this proposed legislation will have on my family and my ability as a father to keep my children safe. When Libby was born, we thought we had a son. We were over the moon. My wife was and still is an incredible mother, and we learned how to navigate those early years of parenthood together with all the hiccups new parents come across. Though as time passed, my child had no interest in what I think are stereotypical boys' toys. She wanted to dress up with her friends who were girls, and I thought it was different, but kept dismissing it. By the time she was 3, she was desperate for us to buy her girls' dress-up clothes. I full force refused to let it happen. So she proceeded to turn every baby blanket, towel, or big t-shirt into a dress, skirt, or long hair. She would spend bedtime laying in the dark talking about how she couldn't wait to grow up and have long, beautiful hair. And to be honest, things would have been much easier if this was all it was, even though I still had a hard time understanding that. It was so far from my childhood. I played every sport I could all year long. And when I wasn't playing sports, I was hunting and fishing. By the time she turned 4, she was refusing to cut her hair. I felt strongly that we as her parents should force her to cut her hair, but my wife felt strongly otherwise. It created a serious divide in our marriage. I really stepped up my engagement with her, encouraged her to kick around a soccer ball, go fishing, and do the things that I thought must be missing for her. I really blamed myself and thought I was a reflection of a failure of mine as her father. But the harder I pushed, the farther she pushed away. She would oblige and do things I asked until she would ultimately ask if she could go back to playing what she wanted to play. I don't even know exactly how to describe the mental gymnastics I went through trying to process what I was witnessing. My wife began to really listen to our child before I would even consider it. When she was 5, I will never forget the disappointment on her face Christmas morning. She had received dozens of gifts. It wasn't a kid throwing a fit because she didn't get what she wanted. She was sad. Up until this point, I was hell-bent that this was just a phase, that we would push through this. But over the next weeks, she really unraveled. Ultimately, we had to be called into school to meet with her kindergarten teacher because she was acting out so badly. When my wife sat down with her to see what was really going on, she broke down crying and said she needed Santa to turn her into a girl. This wasn't a surprise, but it was the moment I realized I needed to set my issues aside and figure out the next steps. We were terrified. As we did research, we realized that we had no idea how to support our kid. We found therapists who did not specialize in transgender issues to help us out, to help us sort out the next steps. She started wearing dresses and skirts to school. We contacted her classmates' parents, and when they told their children, they acted like it was old news because they knew Libby. They've always known who she is. They spent all day, every day with her. I realized that I was the last one to really understand how badly my daughter needed me to see her for who she was. And yet she still didn't change her name for another 6 months because we insisted on taking it slow. I tell you all of this because there seems to be a narrative circulating that parents like me have their kid, tell them they are transgender, and in the snap of the fingers, a transition has happened. That's simply not true. I want you to understand that I struggled. I struggled a lot. My wife struggled too. We had different struggles, but it really put a strain on our marriage until we could come together and figure this thing out. I don't expect you to understand all of this. I don't know what I would say if I hadn't experienced this myself. Never did it cross my mind when I became a parent that this is where I would end up 13 years later standing in front of you. We're a regular family with a really regular life, juggling kids' schedules, working and getting dinner on the table. But coming here is now part of what I need to do as a father to keep my family safe and healthy. Fortunately, things seem to settle overall for Libby. She still has the same best friends from preschool and a ton more. She returned to being the happy, outgoing kid we know and love, which is what the research shows happens to most of our kids when they are supported. We've been really careful to make sure that she's in safe places. Her teachers, classmates, our neighbors, the people that know us and know Libby are here to support her and make sure she has every opportunity to thrive, just like her friends and classmates. But I should also tell you that as she began to get closer to puberty, it became harder for her to sleep. She began to have anxiety about her development. After years of providing Libby with the most supportive environment we could, we had a series of very extensive consultations with a team of physicians and health professionals. And with a very clear understanding of the risks and benefits, we allowed Libby to begin puberty blockers. Here's the thing. We're the type of family that uses Tylenol sparingly. So it was a real struggle for my wife and I to wrap our heads around any kind of health care Libby might need. We also knew that she was living in terror of her body changing. I can't begin to imagine what that must feel like for her. She began to sleep solidly through the night almost immediately when she understood that the puberty blocker would help prevent or at least delay changes in her body that she feared. I didn't bring Libby today because she shouldn't have to come back here. Again, this is terrifying and traumatizing for her to have to constantly defend herself publicly. But I'm her father, And I'm here to tell you that you don't have to understand her, but I ask you to allow me the right to support and protect my family, including my transgender daughter. Just like any other parent, all I want is for my kids to be happy and successful in life. I've had some major doubts, but since I set aside my own issues and supported my daughter, I have no doubt in my mind that this is the right thing for her. And we have all the evidence watching her thrive. I am begging you, as a father, to trust that I know my kid. She has been persistent from the moment she could talk, and this is what sets apart transgender kids. If you pass this bill, I'll be forced to uproot my entire family, our livelihood, and leave the family and community support we have around us. It would be devastating to all of us, but it would be the only choice to keep my daughter safe. Please don't put me in that position. I urge you to oppose HB 1686.
Questions, members? Representative Jones.
Well, Frank, thank you so much for that testimony and sharing that story. We've heard a lot about undue influence when it comes to children transitioning or families having to make the hard decision about transition. Where do you feel Libby received the language at such a young age? Was it the internet? Was it other circles? Where did the language come from at such a young age?
So until she met a transgender person, she thought she was the only one. She thought that she was carrying this burden herself. She had no other influence. So that's not our experience.
Representative Smith.
Thank you, Madam Chair. Thank you, Mr. Gonzalez, for being here. You're going to make Texas a better place with your testimony. However this committee comes down, you're taking part in the process and providing us great information, and I appreciate it very much. I looked over your statement. Thank you for providing this to us. I was listening to you. I didn't hear how old she was whenever you began the puberty blockers. Could you tell us that?
Well, I'm not comfortable sharing some of our private healthcare information, but I'd be happy to speak with you privately.
Perfect.
Yep.
Yep, we can do that.
Happy to do that. I mean, 'cause public record, you know. Yeah.
Well, and thank you. That'd be great. Thank you for your time.
Yep.
Appreciate it.
Representative Collier.
Yes, thank you so much. Mr. Gonzalez, I appreciate you sharing your family's story. And I don't know and understand everything, but what I do understand and connect with is your desire to get the best health care for your child. And so what I'm concerned about for you and Libby and your family is what would happen if you're not able to get this health care for your family. What will happen?
So, as a father, I'm going to do the best thing that I can do and keep my daughter and family safe. And so, we would be forced to leave the state.
Okay, so then, is that your biggest fear for Libby and yourself? Is that you have to move and uproot your whole family?
That is my biggest fear.
And so, one of the things you talked about was that you started to look for options. You wanted to see if there was something out there. Did anybody force you to do anything that you didn't believe was helpful for your child?
Absolutely not. You know, we spent years just supporting her. And I'm sorry.
No, I mean, it wasn't a decision you made overnight.
No, not in the least.
In fact, you were trying to go a different way. It's just
Yeah, I was trying to force her into what I knew.
right. And that's why this can be uncomfortable for everybody. But when you love your child and you're trying to find the best health care, it was helpful that it was available.
Correct.
And that helped your family.
Yes, and so first and foremost, I believe my child. And it took me a while to realize that this wasn't just a phase. But once I saw everything and saw her really come back to us, that's when I knew.
And it was because you had access to health care.
100%.
Thank you.
Representative Tinderholt?
Thank you again, Madam Chair. Thank you, Frank, for being here today. I couldn't imagine this. I have a couple of small children. You stated that you would move. If there's loopholes in the bill that allow you to order drugs into the state, or if you could leave the state and do surgeries or any of the types of things you need to do and then come back, is that something you would consider?
So as long as we could receive health care and medication, then it's something that we would consider.
Okay. Thank you, sir.
Representative Jones?
I need to ask a clarifying question.
Sure.
In response to what Representative Tinderholt said, you said that if you could consider it, does that, I guess what I want to know is, if this bill were passed, because let me just be clear, you could go somewhere else. You can go to other states right now.
Absolutely.
Right,
We
and
could have
get-
left years ago when all of this started.
Okay, so if this bill passes, regardless of whether you could go somewhere else and get health care, Texas would not be your home. Is that accurate?
Yes.
So where are you from?
Where am I from?
Is your family here in Texas?
So my wife is fifth generation Texan. So my children are sixth generation Texan. I'm from the West Coast.
But you have, the support, like your extended family, grandparents, aunts, uncles, cousins, they're all in Texas.
No, mine aren't.
Right, but
My
I mean,
wife's
your
are.
wife's are.
Yeah.
Do your children have relationships with your wife's family?
Yeah, yeah.
So if you moved outside of Texas, would it make it more difficult for your family, for your family to have the type of relationship that they have with your wife's family now?
Absolutely. So we moved out here to be closer to my wife's parents. Her father has since passed away. And we're close with her mom. Her mom is watching my youngest right now. She's very, very much a part of our lives. We have Sunday dinners all the time, and she's there for every birthday, and she's just a normal part of our lives. To not be there would change the dynamics significantly.
If you don't mind me asking, I shouldn't ask how old a woman is. I'm 57. I don't have it. But
Very good.
but does she need your help? I mean, would she be okay being here by herself, or does your family provide her with anything? Your grandmother.
My
children.
mother-in-law?
Yes, your mother-in-law.
She's in good health right now. Yeah, she doesn't need help. She's a widower, and it's a hard time for her. That and alone, just we're her support.
So it sounds to me from your testimony and what I read, like you were like a manly man. It sounds like
much
you were
so.
like, yeah.
I'm a 4-year letterman.
Okay. Me too.
Ah.
Okay.
3 sports.
We don't want to go there. More than that, but it's okay. What did you have to do, like, even emotionally for you, to have to recognize that your little bitty baby who wasn't influenced by the internet, but who just was born in the wrong body, did you have to seek psychological counseling?
So my wife and I have both had counseling through this. And, you know, I'll just go back and just say that, you know, when my child was first born, I remember having this feeling of like, oh my gosh, here's this precious being that has the potential to be anything in life. And I remember this wave of emotion of, as a parent, as a father, I just don't want to screw it up. You know, I think parenting is one of those imperfect things, you know, and you do the best you can with the knowledge that you have as it presents itself. And yeah.
And so you said that your wife got it way before you did, which is, you know, women just, sometimes we just smarter.
She is smarter than I am.
But now, are you guys fine? I mean, are you guys fine?
We are. She wishes I worked a little less hard sometimes, but yeah, but yeah, we're good.
So do you believe that your daughter is like well adjusted now?
Absolutely. My daughter is, you know, when I say she's thriving, she is doing great in school. She's got a ton of friends. She's happy. Most times when she comes home from school, she's smiling and can't wait to tell us, you know, every day at dinner, you know, when we sit there, we have gratitudes and then we talk about our day.
So I guess my final question is this. If you and your wife were not allowed to determine the health care for your daughter, and let's say you didn't have an option to go to another state, you had to stay in Texas. Tell me, as a dad, what would happen to your daughter and your family?
Well, I'd hate to think about that, you know. I would hate to see her slip back into that reserved self, that not confident of herself, the sad self. I mean, I look at her now and you know how when you see somebody smile and you see that sparkle and twinkle in her eye? For that period, it was not there. For a short period, it was not there. And I would do everything that I can. I mean, a parent's love doesn't stop, you know, and so I'm going to continue to do what I need to do to make sure that she is going to be healthy and safe.
And I'll end with this. When you were talking about who she is now, once y'all figured it out with the healthcare providers, like I could see the glimmer in your eyes. And by me just merely saying, what if you were stuck in Texas and you couldn't get her the health care that you and your family and your doctors came to, I could see the difficulty and the sadness, and the glimmer that I saw in your eyes went away. So I think you helped me understand how it would affect your family. Thank you.
Thank you.
Other questions, members? Freddie, thank you very much. Excuse me. We're not able to, we have to maintain decorum in our hearings and during our committee hearings. And, you know, clapping is not appropriate, so please refrain from that. Chair calls Soren Aldalco. If you'll state your name.
Hi, Hi, yeah, I'm Soren Aldaco.
And you're representing yourself as?
Yeah, I'm representing myself and I am testifying neutrally.
Neutrally. Okay, please begin your testimony.
Hi, my name is Soren Aldaco, and I'll be testifying neutral on HB 1686 as someone who experiences gender dysphoria and who has found peace outside of medicalization. I believe that children deserve better than plastic surgery and hormones, but this legislature needs to prove to families that there is a path forward through expanded access and funding for mindfulness-based therapy programs. As contradictory as it sounds, I fit the definitions of both trans and detransitioned. I began social transition at age 11, started testosterone and estrogen blockers at age 17, and by age 19, I had undergone a double mastectomy. Massive complications did not elude me, however, and I was gaslit, then ghosted by my medical providers after demonstrating weeks of concern. Emotionally vulnerable and with zero pain meds, I spent 8 hours in an ER bed alone before they cut my scars back open, sewed drains in, and aggressively expressed over 3 cups of blood from my raw chest cavity. This got me thinking, why do we uphold material solutions as the end-all be-all treatment for distress that's mostly mental? What could I do to conquer this beast while accepting that my greatest fear, my female body, was just as much a part of me? Less than 6 months later, I stopped hormone replacement therapy and began what I like to call a process of reclamation. Material solutions pushed me deeper into my ego, so I became determined to integrate with the world around me. I questioned my conceptualization of manhood and womanhood in the context of sexism and pain, and I learned how we develop our sense of identity through comparison to other people, role models. So in thinking of my 10-year-old sister and what kind of other I wanted to be for her, I realized that I needed to find an alternative way of addressing my gender dysphoria, one which didn't posit my body as wrong or my negative feelings as triumphant. I achieved part of this through self-compassion, which, according to research done by Kristen Neff, involves 3 key components. 1, mindfulness, or the practice of accepting negative thoughts and emotions, like gender dysphoria, for what they are. Common humanity, or the practice of recognizing that all humans are imperfect and prone to pain. And self-kindness, or the practice of extending grace to oneself always, especially when it's hard. Our handling of gender dysphoria is not an exception to this nation's mental health crisis. In fact, the gender-affirming care I experienced in adolescence was an elaborate placebo that allowed me to identify outside a lifetime of neurodivergence, trauma, and gender nonconformity. I was no longer a loud, butch, autistic weird girl. I was a cool, happy-go-lucky lad. Kids need affirmation. That much is true, but how you affirm them matters. And if this bill is to move forward, we have to ensure that there are mechanisms in place to support self-expression, resilience, and healing. Not everyone who transitions experiences gender dysphoria, and not everyone who experiences gender dysphoria transitions. Just know that right now, best practice is code for only practice, and accountability for a medical system that prioritizes ease and conformity over health. It's the first step towards developing care that actually systematically works. And by the way, I'm from Texas, born in Texas, and this is happening in Texas.
Questions, members? Representative Alverson.
Thank you, Madam Chair. Soren, thank you for being here today.
Yeah,
appreciate your testimony, and admire your courage. And I really kind of dug in when you were saying, that when we're talking about medicalization as a placebo, and what you really needed was love, support, mental health kind of things to help you with the situation that you found yourself in, and some of the things that you were feeling. I don't want to put words in your mouth, but I'm just telling you that's kind of what I heard you say, which is, I think, ultimately what we're trying to do here is get back to what we know fundamentally works for the majority of young people in your circumstance, which is support and therapy and reassurance and acceptance. and to stop pushing the drugs and the surgery, which causes permanent changes. I'm
For sure.
so sorry that you went through the mastectomy. I mean, that's awful.
Yeah, I mean, it is pretty hard, but this isn't the first time that I've personally experienced that sort of medicalization when it came to me not fitting people's conceptions of like what my behavior should be. I was actually put on stimulant medication at age 6 years old because I couldn't sit still in a traditional classroom. But what I'm learning today at 21 is that what I needed was to be challenged. You know, I needed people who saw me for who I was and didn't think that I was the problem, understood that my environment was the problem. You know, we're really conforming people to places and things, and not the places and things to the people. Like, you know, your kid shouldn't have to come out to you as a girl for you to be okay with them cutting their hair how they want to and dressing how they want to. Like, that's a sexism problem, not a problem with your child.
Yeah, I hear you loud and clear, and I see you. And I think the other thing I'm getting out of what you're saying is that we need to stop trying to put people in boxes.
Yeah, no, absolutely.
Stop this business of saying that, you know, we're just going to give you a pill and it's going to cure all your problems. And, and everything, life is just going to get better. And I think you're living proof that it is just not that simple.
Yeah, no, at one point, the same doctor who prescribed me testosterone had me on 11 different medications. Today, I'm on one for my thyroid and a probiotic, you know, like the rest of us. So, I mean, and it's not to say that I didn't have problems, but it's much easier to address these symptoms than digging deeper and understanding why these symptoms are occurring. Like, behavior is communication. You can't just take it for what it is. You have to, you know, unpack it.
Yeah, well, I just hope that you will continue to share your experience, your strength with others who may be wrestling with some of the same issues that you've been wrestling with, because I do believe that there's hope there. And so I'm just grateful that you're here. Thank you.
Yeah.
Other questions, members? Representative Tinderholt.
Thank you, ma'am. Soren.
Hi.
We haven't met. I wanted to try to meet you earlier today, but I think you've been pretty busy today.
Yeah.
So explain barista and scholar. What are you doing?
What?
Your registration says
as a scholar.
barista and scholar.
Oh, yeah. So I put scholar instead of student because, like, I'm a student, but I'm a student of life. So I try and learn from every experience I have. But I'm also a barista because I love knowledge and meeting people, but that gets you pretty stuck in your head. You know, that's where I was as a teen, was in my head. And working with my hands, I actually work at a local coffee shop. Really helps me with the connecting to my body thing, the thing that got me into this position.
So you say you've been in Texas for a while. What area?
DFW, which is the suburbs between Dallas and Fort Worth. It's pretty traditional. I mean, it's the women look a certain way, the men looked a certain way, and I didn't fit neatly into either of those categories of self-expression, which, you know, learning about how children developed helped me a lot because I discovered that we develop a concept of self, like who we are, based off of the people we have to look up to. So we take on roles, like kids play cops and robbers, right? And they determine, you know, what it's like to be strong, what it's like to be mischievous. And when you grow up gender nonconforming, you don't really have those role models. So you see other people liking the same things you like you're a little boy who likes having long hair, who likes wearing dresses, and you only see girls doing those things. And when you get pushback from people on that, you know, for being a boy and liking what girls like, you start to develop a concept of self based around being a girl. Like, it makes total sense. So that's where I was personally.
Right. Well, that's where I'm from. As a matter of fact, up in the DFW area.
Oh, really? Where at?
In the DFW area. So I have a couple questions, things that I actually wanted to talk about with you earlier today. I had heard that you may have talked to some attorneys at some point about this. Is that true?
Yeah, about my malpractice.
So what did they say to you?
So following the complications with my mastectomy, where my providers dismissed me 3 times and then told me nothing was wrong the night I showed up to the ER and, you know, something was very wrong, I spoke to probably about 10 different attorneys, and all of them had pretty much the same thing to say to me, which was, you know, we'd love to help you, but this is going to cost more than, you know, we're going to make from it. So here's another person you can go check in with. But of course, they had the same thing to say because, you know, at the end of the day, you have to put food on the table. So,
would you like to see laws change in Texas regarding that cap of $250,000?
Yeah.
Why?
Well, because it's preventing people from getting justice.
And when you say justice, can you explain that?
Well, when you've had something happen to you like this, I wasn't even in it for the money personally, but there was no one to even take on my case, even if I took not a single penny from it, to hold these providers accountable for their negligence. And, if raising the cap is what it takes to get these people into the courtroom, then that's what it takes.
Is there a large number of people that you know in the detransition phase?
I know several. Some of my friends who have had the opportunity to see me embrace maybe an alternative way, because for me, transition wasn't necessarily I was really trans. I really genuinely believed I was born in the wrong body, and so I think people realizing hey, medicalization isn't the only path forward. It can be inspirational to some degree, but I've had a lot of other people who have also experienced medical complications, and in coming to terms with them, the hormones and stuff really exacerbated their issues.
Do you feel at all like maybe the psychologist you used or the psychologists that you used perpetuated any of this?
Oh, yeah. So my very first therapist, I was one of very few trans clients she saw. And I was sort of a novelty to her. So it was her opportunity to, for me to educate her, basically. And I was maybe 15 at the time. The therapist I saw after that had a transgender ex-wife who she constantly compared me to. And that I felt was very inappropriate because it was almost as if she was projecting the things she wished she could have done for that person onto me. And, that's part of why I mention mental health care, because, obviously mental health care has been around, but we're having a mental health crisis in this nation, so something's not working. And, part of why I think we're turning to these medical options is because the people just aren't there. And that's something we need to address for more reasons than just gender dysphoria.
Do you wish that this bill would contain something around around those psychologists that are still perpetuating, not the ones that are trying to assist with someone that might have some mental health issues, but the ones that are perpetuating and pushing someone to go get surgeries and hormones and blockers?
Well, when it comes to affirmation only, in my opinion, yes. But that's because so many of us, as you all have heard today, have comorbidities that I feel should be addressed before we assume that this is the most necessary course of action. It's like the chicken and the egg. We don't know which really came first, and we won't if we don't investigate it. I have a history, like many others my age, of childhood sexual trauma. I have a history of CPTSD, of social rejection. And my clinicians, despite acknowledging those things, still felt that gender transition, and of course we use gender we use gender and sex much the same in these discussions, even though many have distinctions between them. So I want to make that clear, but they still felt that gender transition, enabling me to be perceived more as the opposite sex and the sex I was born, was most appropriate, even though we know things like, with autism, and I've heard this mentioned too, and this is what I study in school, is autism and neurodiversity. That people with autism and ADHD have difficulty with socialization and being socialized into the norms of a society. And a huge part of those norms is, sex-based. It's, what do you do when you're a woman? What do you do when you're a man? And so it makes a lot of sense that we're seeing this connection. And in my opinion, due to the health effects of it, a lot of people talk about eugenics, and I'm not going to throw a word around, but the negative effects are disproportionately affecting neurodivergent people. And that's sort of worrying to me.
Well, I want to thank you for being here today. It's not just brave, it's very kind of you to share your story with everyone. And so I'm very appreciative of you, and I just wanted to say thank you.
No problem. I like making friends.
Other questions, members? Thank you. Chair calls Colt Sant-Armand. Colt Sant-Armand. Chair calls Joe Burgo. Joe Burgo.
Colt Sant-Armand?
Yes, I'm sorry.
Hello.
You had registered twice.
Apologize for that. Must have been my internet.
And what I need to know is which address would you like to use, the one on Wynwood or 20th?
Wynwood.
Alrighty, and we can delete the other one?
Totally.
Alrighty, thank you.
Yes, ma'am.
Okay, and I have that you are testifying your position on the bill, and who are you representing?
Yes. Opposition, representing myself.
Okay, thank you.
Thank you. Good afternoon. My name is Dr. Colt Sanema, and I am a Texas licensed physician and a Texas licensed psychologist, the only person in our state to hold both distinctions. I was born and raised in Texas. I went to Catholic schools in Beaumont, Texas. I went to Rice University and U of H in Houston. I completed my MD at UTMB in Galveston, so I am your Texan. I'm currently in my final days of my family medicine residency at the Mayo Clinic up in Minnesota, but this is so important to me that I came here. I've been conducting research in the area of transgender health and providing health care to this population since my early days in training in 2009. My dissertation is the first study in Texas to demonstrate the positive mental health benefits of hormone therapy using a longitudinal and controlled design. I am representing myself in my strong opposition to this bill. In fact, it's because of bills like these that I made the decision not to return home to Texas to practice. A theme that keeps coming up in our legislature bills that is to restrict and to deny rights to my people, from bathrooms to sports and now healthcare. I'm here because of the harms this bill has already caused and will cause in the future, should it pass. As part of my testimony, I have 18 empirical peer-reviewed research studies that demonstrate positive health effects in healthcare in this population. Time and time again, you'll review the findings of improved quality of life, body image, depressive and anxiety symptoms, and decreases in suicidality. As the committee is well aware, this community is at high risk for suicide. So why would you want to ban life-saving treatments in my community? Because that's what the bill clearly communicates. What do you want me to tell my patients when they ask me why you don't want them to have health care? I feel very confident in the treatment guidelines and the standard of medical care that exists to guide our intentional and careful assessment and treatment of transgender adolescents and adults. We've had guidelines since the late 1970s, which continue to be updated based on the most recent research, as with all medical care. These guidelines exist to make sure that youth and families are protected. The standard of care for adolescent health care is interdisciplinary in its nature. There are multiple team members that work with each family to determine the best treatment recommendations based on each individual case. And as with all medical treatments, risks and benefits are clearly communicated and reviewed with parents and youth to make informed decisions. Physicians should know that low-quality evidence is not the colloquial low-quality term. There's an actual standard that is set, and if it's an observational study, it won't get any higher than low-quality evidence because of the nature of the design of the study. Doesn't mean it's a poor study, doesn't mean it's a bad study. Things that we do routinely in medical care, like Tamiflu, vitamin D, Aricept for dementia, and statins are all based on low-quality evidence, but they are the standard of care, and you're not trying to ban those. I understand and I share the common concern that we need to protect young people from receiving treatments that they do not need, that are not medically necessary. However, a complete and total ban on care that some Texas adolescents actually do need is not only unethical, but unconscionable. My question for y'all is, how do we work together to protect the adolescents who really do need this treatment, as well as those who do not? Thank you.
Me, Johnson, thank you so much. You mentioned that you want to be part of this dialogue, that we should not have kids getting treatment that they don't need, but that this ban would go the opposite other way. What would you describe as that middle ground in our creating state policy?
I think it should be very clear that the professionals who provide this care should be required to have training and continuing education in this area. There are plenty of people that put up their shingles and say they work with transgender patients that I've never seen at professional conferences. I have no idea who they are, where they came from, and are giving parents information that I'm not sure where they got that information from. So I would be a big fan of making sure that we hold all professionals to the standard that they're supposed to have of practicing within their scope of practice, and making sure that they are educated on the care that they're providing, and that they're not just done once they've gone to one conference, that they participate in continuing education in this area. They also, if we're working on with adolescents, which is what we're talking about here, we need to have folks who work in multidisciplinary teams. Now, they can be spread out, so a therapist can be in San Antonio and somebody else can be in Austin, and the family can, work with 2 different cities. That's fine. They don't have to be in a clinic altogether, because that's not really feasible and will reduce access to resources. But we need to make sure that we support these interdisciplinary teams who are trying their best to provide really good care to these families. Those would be 2 of my suggestions.
We heard earlier some of the testimony and somebody with regard to research and all of these differing studies. Would it be fair to say, 2 questions here?
Sure.
One, that hormone therapies and hormone treatments are long held and have a reliable practice. Yet where we are now with gender dysphoria, we again may be in the beginning of a stage of medical practice where we may continue to see evolution, and we should be part of a science-based study in that area.
I definitely think we should continue the research. It's been done since the 1990s, so it's not brand new compared to a lot of medical treatments that we have these days. It's actually quite old, even with transgender patients. And so we do have over 30 years of documented research. So sometimes people say, oh, this is brand new. And I would say that's not consistent with my understanding and expertise in this area. So I do think we definitely need to continue studying. The challenge is, where's the funding going to come from? I've had to piece together all sorts of different funding because nobody really wanted to support this research. And I'm not sure I can count on my state to give me funding for it. You know what I mean? So if we're really invested, if we really want to do the study, then we need to front the funds in order to support this as well, if we're really that concerned.
And what about the issue of puberty blockers or hormone treatment? What would you say to that?
What's the specific question, Representative?
So is the practice of puberty blockers or hormone treatment, we've heard about things like precocious puberty. Does the medical profession apply? And even in this bill, we know that those treatments will be available to some, but not to those that identify as transgender. What's your take on that?
It's clearly discrimination. We're treating one group with the same medications that we're not treating the other group with. And again, we have research since the 1990s on pubertal suppression. We're having more and more data come out, so over 10 studies in the last 3 years to support the practice of pubertal suppression. So the idea that only some people should be able to have access to treatments, but not the transgender people, for me is clearly discrimination. And if you're saying, oh, well, I'm going to argue, no, it's not, well, I'll tell you, it sure feels that way.
Okay. Let me also ask, earlier we heard testimony from Libby's father. And Libby's father talked about Libby starting to get to a point of having trouble sleeping with fear that Libby's body was going to begin to change. And I've heard my colleagues say, why don't we just keep up mental health treatment until people get to 18? How do you correlate that with somebody like Libby, whose father genuinely let us know about the authenticity of the love for that child and the authenticity that that child has for who she is? How do you balance that concept of just give mental health treatment until 18 with somebody who is actively already identifying that puberty is not going to be okay for them?
Absolutely. Denying access to medically necessary care is not neutral and is harmful. And I'll ask one of my assistants to bring me my stack of research papers, because there's actually one that uses a control from the Netherlands that looks at youth who just have psychological counseling and then compares them to youth with psychological counseling and pubertal suppression. And guess which group does better in terms of mental health? Those who have access to both counseling and pubertal suppression, but not just, we just give pubertal suppression to anybody after the appropriate assessment and diagnostic workup.
And what would your fear be if Texas passed this bill that says all of a sudden, no more care? What would we do about those population of children who are already receiving care here in Texas?
Yes. We'll continue to see the development of many folks' mental health, and so the deterioration. So I've already seen this, and, you know, I'm openly transgender myself, and I have access to community, and so I see as both a professional my own patients and then as a member of my own community. So I have both insights, if you will, personal and professional expertise. And what I see is folks have been so scared already, just that we're debating if they could even access care in their home. And so I know many families who have already moved out of state preemptively. And y'all know moving out of state is not an easy task. And also, these are families who have means. So we are going to disproportionately impact folks who don't have money to just leave the state. And that's going to impact Black and brown folks more, disabled folks more, folks who can't just get up and move. And so we're going to be harming already vulnerable populations, but even more folks with several disparities already. And I think the challenge is, and I know we want to be very sensitive to the suicide conversation, because that is a real conversation, and I think there's been a lot of all over the place with that. But I do know that for some folks, treatment is a life or death issue. And I can say that with certainty. I've had, let me give you an example of, I'll de-identify so you don't know who the person is and give a couple of details. So this person's 16 years old. Before they came to see me, they had been in and out of inpatient psychiatric hospitalization 3 different times for months at a time. And this young person was very clear, you know, I'm a boy, even though everyone was treating them like a girl. And we did counseling and more counseling. And we'd still have the same effect of trying to kill themselves. We came to treatment. We started allowing that person to live as who they were saying they were. And with any treatment, it's always a trial. Would you agree? Any single treatment that we give someone, it's a trial. That's why we have them come back and we see if the treatment worked or not. So we allowed him to live as who he was, and he wasn't going to the hospital anymore. And then we did further evaluations over several months about would medical intervention be appropriate for this child or not. And I would say adolescents, pardon me, because we're 16 years old. Let's get really clear with that. And so by the time this person was 17, we had over a year of improved mental health, and we were able to start testosterone. And to this day, this person has not gone back to the mental institution since then. And so in terms of life or death, when you talk about totally banning a treatment that keeps my patients out of the hospital, I have to fly here from Minnesota to talk to you.
Thank you. Thank you, Vice Chairwoman.
Sure. Yeah. Thank you, Doctor, for being here. Appreciate you taking the time. I'll tell you what I said to the last witness that I questioned is thank you for trying to make Texas a better place, and whatever side of the issue we fall on, taking part in this process does that. So where are you licensed to practice?
Medicine or psychology or both?
Well, both, actually. Yeah, thank you.
Sure. Psychology in Texas, and I have the SciPact certification, so 27 different states as well. And then medicine, Minnesota and Texas.
Minnesota, okay. And do you have like one office in a particular place, or do you have an office in both Minnesota and Texas, or?
Great question. So I'm in residency, and so I'm pretty much only doing residency. However, because of the extra special expertise I have in this area, there are folks who still want to see me outside of my residency, so in my psychology career. And so I do have an office down here, and whenever I'm visiting down in Texas that I can use, and also virtual support services down here in Texas.
So when were you licensed to be a psychologist?
I believe it was 2014 was when I was licensed to be a psychologist.
Okay.
And I've kept that license.
When did you receive it? So you have an MD degree?
I have an MD and a PhD.
When did you get your MD?
2020.
Oh, okay.
I've been going to school forever. But this is worth it, if that makes sense.
I understand. A moment ago, you said what we need is the appropriate assessment and workup. Yeah, I'll get you something to drink there.
We're good.
I think I need
Glad to be here.
Yeah, absolutely. That made me start thinking about it. Can I have your water?
You may.
Thank you very much. I just
all
took water.
drink.
Yeah, that's right, sure. A moment ago, I thought I heard you say that the appropriate assessment and workup is necessary.
Absolutely.
Okay. In your experience as a psychologist in Texas, do you believe that the appropriate assessment and workup is being accomplished in Texas currently?
If families go to providers who know what they're doing, if folks are practicing in their scope of practice, absolutely.
And do you have an understanding do you have any idea as to what percentage of providers are doing that?
The ones in my network all are, but I've had a few patients come to me and tell me about people who have told them these other things, and then I get that corrected and I report those folks to their boards.
Okay. If you don't mind me asking, I think a moment ago you volunteered that you transitioned yourself.
Yes, sir.
How old were you when you began the process?
Sure. So informally, because I was born in '83 and then lived in Beaumont, we had no information. So I started living as a boy, gosh, as soon as I told my mom I didn't want short hair, but it wasn't formally so. I had a bowl cut from probably like, Mom can bring pictures, 4, 5, or 6 years of age, up until 6th grade. And pretty much everywhere people who didn't know me would assume that I was a boy, and I wouldn't correct them. And so I would say I kind of made my own way. I made my own social transition the best I could. And being a tomboy is a lot easier than being a boy who wants to wear a dress. So let's just talk about how I had a lot of privilege and a lot of good experience because we allow so much more room for girls to act like boys or whatever we want to call it. So let's call that what it is. So I was, treated well. People were like, oh, you're androgynous. Okay. I went to Catholic schools. They didn't make, I wasn't going to wear the skirt. I was not going to do it. So my mom went to talk to the principal and was like, look, I really want to go to Catholic schools. This is really important to us. Like, what are we going to do? And she said, as long as you use that same material, and I'll tell y'all, it was the ugliest plaid. I love you, St. Anne's, but it was the ugliest red and black plaid in the world. But so instead of my little jumper, my mom, thank goodness for her, she knows how to sew. She has a sewing machine. And so she made overalls. And so I got to wear overalls to school and go as myself in Beaumont, Texas in the late 80s, early 90s. And I wasn't bullied.
Did you ever go through a time where you went through, you had puberty blockers or some?
Oh, great question. In terms of my medical transition. Okay, so that was my beginning social transition. But then when I was 12, it started to become really clear that people were kind of wondering about me. And are you gay or not? And in my faith belief, that was wrong. And so I was just like, no, I'm not gay, but I don't feel like I'm a girl, but I don't have words for this. And so I just tried my very best to live as a girl. I grew my hair out really long. I tried to date boys in high school, do all those things, but that did not work at all. You can only be what you're not for so long of a period of time. And so there wasn't pubertal suppression available. And in fact, the closest experts in care for transgender people were in Galveston, Texas. There wasn't anything in our medical center, our biggest area, our hugest area in the whole state. Our medical center had nothing in Houston. And so I had to drive from Houston to Galveston, Texas for care and received hormone treatment there. And I, just so you know, I don't talk about my genitals in these public spaces, so I will not be answering questions about my genitals.
I won't be asking any about your genitals.
You'd be surprised, people do, and I just want to clearly communicate.
I will not do that to you.
I just want to clearly communicate.
So, no, thank you. So how old were you when that started?
Let's see, I was 23 when I learned what transgender was and was like, oh, got it. Because at first I was like 21, 22, and I was like, oh, I'm a lesbian because, I like women. But then I learned other lesbians didn't want to be men. I was like, oh, crud. I guess that's not it. And so then I met a transgender person, and we call this phenomenon mirroring. I saw myself in someone in a way that I had never seen myself before.
Okay. Now, a moment ago, you were talking about and I'm sorry for jumping around, but
It's getting late. You're all right. You've been doing your job.
Matt and clean up. With regard to suicide.
Sure.
You talked about a real conversation.
I would love that.
I know we don't have all night here, but just tell me in summary, what do you mean by that? You're saying we have a real problem, we need to deal with it, need to have a real conversation, we need to have a real conversation about how we handle it, all of those things?
Absolutely.
Tell me what you mean.
Absolutely. We have clear data, multiple studies that show decrease in suicidal ideation with treatment. And I'm glad to bring all of those studies and put them right on your desk. And in my population, if I can get a decrease in people thinking about suicide, I don't care if it's my population or anybody else, I think that's good. I think that is good treatment. And I want to make sure that I have the ability to prescribe and have folks access that.
Do you have those with you?
Yes, and my friend should be coming with that at any time. It's in my backpack, all of the studies, please, that I've clearly labeled, and they called me and I didn't get them because I was running in here too fast. So, yes, I will bring those out. So we have clear data. I think the other part of the puzzle is I never had suicidal ideation myself. And so, I was like, well, I didn't. Why am I different? And I'll tell you why. Thank you, Mom. I had the support of my mother, the support of my father, the support of my church, the support of my school, the support of my friends, the support of people I dated. I had all support. I wanted to stay alive and stay here. But that is not the truth for the overwhelming majority of my patients. And when we lose those supports, one after the other, after the other, after the other, that's when we're at risk for mental health issues. And we can turn to things like alcohol and wishing we weren't here. And suicide is a part of that. So I can bring them out. I've annotated them for you as well. We have some with control groups if you're excited about those. Pubertal suppression control groups. These are all mostly from the last 3 years. So after this 2018 data that y'all keep talking about, we got more and new stuff that I want to make sure is informing y'all's practice. We even have control groups with transgender people, youth on testosterone versus those who are not on testosterone. So the control group of actual transgender people, psychoneuroendocrinology as the chapter. I will note that the person, Shapiro or Jesse, before he said he published, he's not in any peer-reviewed journals. I just wanted to make that clear. He's on Psychology Today. He's not in any published peer-reviewed journals. I'm in dozens. So I want to make sure that we're clear with our expert witnesses. Dr. Cooper, who's going to present later, they have a paper on hormone therapy and decreasing depression symptoms, anxiety symptoms as well. And I want to talk about, we talked a lot about it reduces suicidality, it reduces depression, but there's good things too that come with the treatment. There's like good positive, not just getting rid of the negative, but also positive. Body image, self-esteem, participating in school, getting better at academics, participating in different groups, joining society, coming back to life. These kids wake up and come back to life. And so we got all of these. Longitudinal hormones.
I'll tell you what.
What you need.
I surely appreciate it.
Yeah.
Why don't you go ahead and leave those with Dr. Oliverson?
Please, and I would love to personally review any of these with you.
Yeah. And then I don't have any more questions for you, but I really appreciate you coming, providing us with that, and thank you for your time.
Thank you so much.
You bet.
Thank you, Madam Chair. Doctor, thank you for being here today. You said something earlier that troubled me, and that was when you were talking about observational studies.
Sure.
And you said that the basis for our understanding of how statins work is through observational studies.
Through
but that's
low-quality evidence.
in fact not true.
Low-quality evidence.
Multiple randomized controlled trials and meta-analysis on top of that, systematic reviews that document the effectiveness of statins in terms of lowering cholesterol as well as preventing the recurrence of heart attack. I think what you're talking about when we talk about observational studies is more along the lines of, does coffee lower the risk of cancer? Does chocolate help improve mental function? These are observational studies where they look at a large population subsection, they do their best as they can to try to eliminate all the confounding variables, but at the end of the day, it's neither prospective nor is it randomized.
Right, and the randomization of, if we talk about why don't we have RCTs in this particular population?
Yeah, because I think that's a true limitation of pretty much everything you're talking
It totally is, and I get why people are doubting our science. I totally get it. I went to medical school, I got my PhD, I do research.
Good.
The issue is when we know a treatment is successful,
But
if
do you
we
know?
put them, absolutely, without a shadow of a
Because
doubt.
there are
this is my-
randomized controlled trials that say so? So you don't really know. It's
I absolutely
observational.
know. And we make plenty of medical decisions based on observational data. And I absolutely know from my own clinical experience, from participating in international conferences, learning, being educated, meeting hundreds of patients.
International
I know that
conferences,
these
let's
are
talk about that. There have been 4 systematic reviews looking at this issue abroad.
Which issue?
And none of them looking at the issue of whether these medications are helpful in treating gender dysphoria and or lower the risk of suicide.
Have
And
any
they've
of those
all
been published in peer-reviewed journals?
Well, there's,
The answer is no.
I think the answer is they have been.
They have not.
Okay.
They are commissioned and they're not published in peer-reviewed journals, what you are referring to.
Okay. So my question still stands. Systematic reviews are obviously a much higher level of evidence than observational
Absolutely.
studies. Why don't we have any systematic reviews that support your position that these are helpful?
We do, and one is in there. It shows less than 1% regret. It's a meta-analysis and systematic review as well. It's in there.
Okay, great. I'm going to look for that. You wouldn't happen to know the author's name by chance, would you?
I could find it real quick if you'd like me to.
Sure, that'd be great.
The other thing is, because this is such a small patient population, trying to do research in general on it has been challenging, especially when we don't have funding or interest in folks funding this particular research. So there's a lot of things against us when we're trying to conduct these studies, and that's why just recently, thank goodness, we've had more research come out, and that's why I'm able to cite this. Because when we were doing this many years ago, we didn't have this. But that is how medical practice works. We practice, we get clinical experience first, then we do research, and once we have done the research studies, then we change our standards of care and our standards of practice.
Well, you find it?
Yeah, last one.
Great, thank you. Okay. This might take me a little while to read this here, but
No worries. So that particular article is specifically on surgery and outcomes in surgery and regret in surgery. And I want to take a moment to talk about regret. I think this is really important because whenever I was going through the Rosenberg Clinic in Galveston, they don't have it anymore. The providers, they've passed away. It's been so long. And they were very worried that we would regret treatment, regardless of what age that we were starting. So I started testosterone at age 24. I'm 39, going to be 40 this year. Woo, I'm still in school. And so they were very worried about regret. And they were very much like, anytime you want to stop treatment, we can stop treatment, no problem. You know, it's not a problem. We'll still take care of you, which is what I tell my patients to this day, because that was important for me. And so in my own practice in psychology, what I'll do is my initial questionnaires for my patients is I say, do you have any regrets related to your transition so far? If so, what are they? Because I'm worried about this too. The overwhelming majority of my patients say, nope, I have absolutely no regrets. Of the patients, probably about 1 in 10 who say they have regrets, 99% of them say, I wish I would have started this sooner. That is my regret. The one person who said they have regrets and it wasn't about starting it sooner said, I wish my mom would still accept me.
Okay, I'm still looking over this. I'm probably not going to be able to get back to you right now, but we'll have a conversation about this later.
I would love to.
I would like to know, though, by the way, that so meta-analysis here, looking at this, were these surgeries all performed on children?
No, we don't perform surgeries on children. You know that.
Well, actually, I know that we don't perform some surgeries on children, but I think we've heard testimony that you do mastectomies on
I'm
girls
not
under
a surgeon.
the age of 18.
I don't do surgery.
Well, I understand that, but since you're quibbling with me, I just want to set the record straight on that, that obviously.
I want to be clear.
We know that that does happen, at least the top surgery happens.
Right, no genital surgeries. That's
Yeah,
correct.
well, but the top surgery is not reversible either.
That's correct.
Yeah.
Plastic surgeons will tell you, oh, we can put
Absolutely.
breast back on.
Seen
but
that a lot.
You already know.
Let's talk about WPATH. I want to understand why there's such a disconnect between the European community looking into this and doing at their level best to understand the research and study it. And maybe they even have better funding than we do because they have national health services and we don't. Why do they come to such a dramatically different conclusion with regards to gender-affirming care?
What conclusion are you referring to?
So I'm referring to the fact that you have country after country that has rejected the idea of gender-affirming care, which WPATH promotes, and they've actually started closing a lot of their child gender clinics in other countries, right?
No, there's been
No,
one
you're telling me that
hospital-
Tavistock is still
Please
open.
allow me to finish, Representative. There's been one hospital in the UK that closed. However, they're not going to stop providing gender-affirming care. They're opening it up to regional hospitals. So the idea that they're stopping providing gender-affirming care in other countries is false, and I don't appreciate folks continuing that narrative.
Well, that's certainly not what the Cass report said. And they actually shuttered the clinic because they felt like it wasn't evidence-based,
They did
right?
not. No, that wasn't the case. They felt like the evidence was very low quality, as we
Yes.
talked about.
Right.
Which we know,
Okay.
and we still have a preponderance of evidence, but they said, you know what? Different countries have said, we need to study this more, and they put, they're following the same standards of care, so I'm not seeing these huge changes in standards of
Well, they're obviously doing something differently because they're not doing the pediatric gender treatments that they were doing.
Some of them have stopped all surgeries completely, but many of
Look
them.
like they stopped more than just the surgeries. It
Many
looks
of
like they've stopped, and then we have other countries as well that have put out the same systematic evidence to reverse some of these things, or at least put the brakes on it. I guess the question I want to, what I want to understand is, again, you're making I think what you're saying is that there's no difference between the Europeans and the Americans. I think the bulk of evidence
That's
would
not what I'm
suggest that
saying.
there's a lot of difference.
That's not what I'm saying. Bottom line is I'm here about kids, and Europe has not banned care like this bill would do.
But they have significantly turned the corner on doing what we're currently doing in America. They are not allowing children to essentially make the diagnosis and drive the train as far as self-identification, which is what WPATH recommends, yes?
That's not true. Children do not make the diagnosis.
Really?
Licensed healthcare providers make diagnoses,
By talking to the children.
which is the same with depression, anxiety, and other mental health professions.
So the children who are adolescent or pre-adolescent who apparently are going to undergo treatments which are life-altering, you would agree that many of the treatments that these children undergo are not reversible.
Many of them are not reversible. Some
Yes.
are partially reversible, and some are reversible.
So there's no going back. I mean, if you make the wrong call as a 12-year-old, I mean, we've just heard testimony from folks that obviously it didn't work out for them like it was promised.
And there are some that it absolutely does work out, and they need access to care that this bill would cut off from them.
But how do you self-regulate as a profession when you have a treatment failure rate that seems to be growing at an alarming pace?
I have 3 studies that are more recent that show only 2%. So I'm not sure what research that y'all are looking at, but I can give these to you. And they're international as well. There's 2 of the 3 here.
The other question I want to ask you is, are you familiar with WPATH 8's decision to remove recommendations regarding a minimum age limit on gender-conforming surgeries?
Yes.
Why did they do that?
That was a big argument that was going to happen up until the day of putting it out there. We're all clear as a field that this is a highly individualized care. There's not the same two people that come in and I say, okay, you're going to need hormones at this age, you're going to need surgery at this age. That's just not how it works. It's very individualized. And so if we put age limits, we would not allow for the individualization of care. And also, as puberty keeps starting earlier and earlier these days, if I got a kid that's starting puberty and is in precocious puberty, I need to be able to take care of them. But if I have a guideline that says you can't do anything till 12, this
Why
person
12?
is stuck.
I mean, you were just saying a second ago, we don't do surgery on
I'm not
adolescents.
talking about surgery. I'm talking about pubertal suppression.
I'm talking about
and hormone
surgery.
therapy.
I'm talking about them removing there was, if I remember correctly, if I read correctly, in the earlier versions of the WPATH guidelines, there were recommendations on a minimum age limit for surgical, gender conforming surgery. My understanding is that's been removed in WPATH 8. And my question is why? Especially if we're arguing that these things never happen on adolescents, why would the leading organization promulgating so-called standards of care in America basically remove any guidance as far as minimum ages for surgery?
Because they wanted to put that into parents' right to protect their children and physicians' right to work together, collaborating with families to figure out what the best care plan that with that patient would possibly be.
So what you're saying is left to the providers to essentially, do what they think is best in consultation with patients and family members. We very well could see surgeries on children under the age of 18, according to WPATH. And that may be perfectly normal, okay, super good stuff.
This is adolescents that we're talking about.
I'm talking about people under the age of 18.
Very rare cases, incredibly rare cases,
So it does happen,
incredibly rare cases.
but it does happen.
Of course, very
You just
rare
told us that it doesn't happen.
I said genital surgery. Let's get really clear, because I think you and me really are on the same page.
I'm not sure we are.
I think that you and I both want to take care of the adolescents in this state of Texas. I think you and I both have an investment in their health care and keeping them alive. Is that true?
I think that you believe that what you're doing is evidence-based and supported by multiple independently confirmed trials, and
Which I have brought.
strongly disagree with you. I think you are operating in essentially a scientific no man's land where you are, as by your own admission, using extremely small sample sizes that don't lend themselves very well to research or control groups or randomized controlled trials, and you are just sort of figuring it out as you go along.
I showed you
I
a trial
commend
of
you for-
20,000 people. I'm not sure
And
what you
how
want.
much of that was survey?
What else do you want?
I want actual prospective trials.
Where are you?
That is where medicine
Have you been
finds
funding
its
those?
strengths.
Have you been funding those? No. You know, what I really need this committee to know is that there are adolescents who absolutely, it is medically necessary that they receive this treatment, period. And this bill would completely ban their access to life-saving treatment. So if we want to get and work together, which I hope we do, then we need to work on the regulations so that the right patients get access to this treatment.
Okay, last question for you, and I don't mean to be crass, but I'm just trying to understand. So WPATH 8 also put out something that I, quite frankly, have never heard of. But since you know a lot more about this than I do, can you explain what is a eunuch gender?
Sure, it's actually in the Bible. I don't know how many folks are familiar with the Bible, and they talk about eunuchs, and Jesus says some eunuchs come into being eunuchs by
Is
themselves.
that a psychological condition that somebody expresses a gender identity that they want to be a eunuch?
I don't have experience working with eunuchs, but I do know that the idea of eunuch has been around for thousands of years, and there are folks who come to treatment. They haven't come to my office yet that still need supportive care and standards of care on how to work with them, and we finally now have some standards of care set for this population.
Interesting. Okay. I mean, you learn something every day. I appreciate you being here, Doctor.
Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here today, and I have to tell you that I think your resume is pretty impressive. Mayo Clinic is pretty impressive, Rice University. I don't have the wherewithal to do the amount of school you've done. It's a lot. And
I'm tired.
I bet. I have to ask about the button, because I've been looking at this button on your jacket, and I'm just out of curiosity. Can you tell me about the button? Because it must mean something.
Absolutely. So I have to cover up, the institution. This is actually my mom's button. It's Mother Mary and Jesus. And so Catholicism is an important part of my identity. And I truly believe that Mary is someone who speaks for the voiceless and who is right there with folks who usually get made fun of or not taken seriously by the governments and people in power.
I will tell you that because of that button, I'll tell you that I think that the heaven above makes children in his image, and he makes them perfect when they come out of the womb. And so I would disagree. But so you're a psychologist in 27 states and a doctor in 2, and you're going through your residency.
I'm a psychologist and a physician, and I'm licensed to practice in the states that we had already discussed, yes.
So how, because I don't know, how would it work if you're practicing both? Will it be legal for you to refer patients to yourself? Because I don't know.
I won't be doing that. I'll be practicing
But can you?
separate.
Could you?
It's a legal question. There's no precedent for that,
Okay.
and I'm not about to test it.
So I'm a little concerned.
No thanks.
I'm a little concerned when you say, you've used the terms medically necessary and life-saving treatment.
Absolutely.
We've talked to some detransitioners, both earlier today I have, and we'll probably hear from them later. But we've heard today how that exact terminology is used. This is life-saving. This is medically necessary. Would you like your child to commit suicide or have these services? That's concerning to me because I disagree with you. You are very educated, but I disagree with you. I think when people think that there's something else, and look, I don't disagree that they feel that way, but we normally get them medical attention in regards to mental health. We don't transition, we don't do things to their body. And so I have serious concerns over it. I'm going to ask you a series of questions, and I'm hoping that you'll answer these for me because you are a medical professional. Same question. What's a woman?
Absolutely.
What is a woman?
What is a woman? So in general, most women have XX chromosomes. They get a bunch of estrogen at puberty. They have ovaries, they have a uterus, and a vulva and a vagina.
Can any man have a baby?
Any man who has XY chromosomes, testes, and does not have a uterus cannot have a baby.
Okay. So if this bill passes, will you use any loopholes to ship medication to Texas or to bring people to you in Minnesota to do the things that you do with puberty blockers or with hormones? Will you do that?
Well, that's a great question. All I know is that people deserve access to care, and if this state decides that transgender adolescents cannot have access to care, then I'm going to work with legal teams to work to change that. If the bill says that I'm not allowed to help folks cross state lines or access that, then I'm going to follow the letter of the law.
So if you're doing them in Minnesota, but you have your license tied to Texas, I would think that it would. I'm certainly going to ask the author and some legal folks.
If the patient's in Texas, that's where that counts. But
So
if my patients are not in the state of Texas,
So would you do that? Would you bring them to Minnesota to do whatever it is, surgery or transition or medication?
I wish I had enough money to be able to help people access care. I'm
The question is, would you bring people to Minnesota to do it?
personally no. But I would be in support of folks who are trying to help others access health care, absolutely.
Now, I'm going to challenge you on the fact that no surgeries happen.
That's not a fact.
Well, a moment ago, you said these surgeries don't happen, and I'll tell you, I'm not going to give you the clinic. If you want to know, I'm not going to say it here. I'll let you come up and look at this. But there was a doctor in Austin that at the bottom said top surgery in patients under 18 requiring 2 surgery referral letters from mental health care professionals to conduct surgery. It happens, and this individual now, if you go to their website, has removed that, ironically. I disagree. You say that surgeries don't happen to the children. I'm looking at the website that was pulled up.
That was mastectomy, which is considered top surgery. I was referring to genital surgery.
So
which
you
does
know,
not
so,
happen.
so are you saying that you know what types of surgeries this doctor was doing?
I'm not sure which doctor you're talking about, so
So
it's
you
sort of hard
can't
to
say,
answer.
that's my point.
I
So you
don't-
can't say that it's mastectomy, right?
I mean, that's what you said, so.
No. I said that surgeries for patients under 18 require 2 letters. I didn't tell you what types of surgery. I haven't read the whole thing.
Sure.
I'm just telling you that I believe that what you said is not accurate. It's just not. The surgeries are happening to children in the state of Texas.
Not genital surgeries that I am aware of.
Okay,
or have
see,
been
but that's a
involved.
different answer that I'm not aware of. To state something as fact is not fair when it's your opinion or your knowledge. I think that's disingenuous, and I'm concerned. I'm concerned that you might carry 2 licenses and bring people to Minnesota as well to conduct these. I look at these differently than you.
I'm okay with us having different ways of
I agree.
thinking, but I'm not okay with limiting access to health care for a population of people.
But when you're talking today, you're using the exact same terminology that other people tell us is used, that it's life-saving and medically necessary.
Absolutely, which is agreed upon by multiple professional associations,
Like-
AMA, APA, Pediatric Endocrinology Society, Endocrine Society.
So they say that this is medically necessary and it's life-saving to transition or
In-
use medication and
In
hormones
certain cases,
for
yes.
children that are 12, 11, 9.
In certain cases, yes.
All right.
But like I said, with any medication, it's a trial. Start someone on puberty blockers, and if that medication is not working for them and it doesn't work, doesn't work.
I respect all the work you've done, but I have serious concerns, like the author of the bill does, about the data that's being used and the research that's been done, the lack of it. And so I can't support it. I can't trust the data that I hear.
Then I need to know what your commitment is to helping kids who actually do need care to obtain it.
My commitment is to stop allowing the mutilation and gender modification of children in the state of Texas.
I don't
That's
want
my
any
commitment.
mutilation to happen to.
I'm just telling you, you asked me, that's my commitment to you.
So it sounds like the youth who do need the care, you are okay with them not being able to access it in our state.
I think that they need mental health assistance. You asked what my commitment is, and that's what my commitment is to stop children in the state of Texas from being taken advantage of.
Can we
by
really get
medical
some
professionals.
funding
I'm
for
telling
these
you, you
youth
asked me
for
a
this
question,
mental health treatment?
and you keep interrupting me. That is my answer.
I would love the funding for that mental health that you suggest, sir.
Thank you.
Representative Smith?
Just trying to get down to some details. Have you had a chance to look at the bill by chance?
Yes, in the latest edition that I found, yes.
All right. Under one section of it, it lists out a number of procedures, and I just want to make sure I understand your opinion on this. It lists out a number of prohibited procedures that it would make them illegal for the purpose of transitioning a child's biological sex to perform a surgery that sterilizes the child. Okay? Would you think that a surgery for the purpose of transitioning a child's biological sex, which sterilizes the child, falls below the standard of care?
In terms of genital surgeries that sterilize a person, those need to be done 18 years of age or older.
Okay,
So I'm fine with that.
So that's a yes? Yeah, in other words,
However, you do list many procedures that do not sterilize, and I'm not in agreement with that.
okay, so let's just go down through this list. Castration, you would agree that to perform castration for the purpose of transitioning a child falls below the standard of care?
They need to be 18 or older.
Same with the vasectomy?
A vasectomy, I don't have any patients wanting a vasectomy at this age, so I wouldn't give them, I wouldn't refer for that.
I think he heard you.
I don't even know why that needs to be on the bill. That doesn't make a lot of sense.
I'm sorry, but did you say mastectomy?
Vasectomy with
Okay,
a V.
Yeah.
You're right, that's very close,
I'm
one
just
letter
going
off.
down to the
Very
list.
different surgeries.
It's on there.
Yeah, and that's not a, vasectomy is actually not a gender-affirming surgery, so I'm not quite sure why it's on there.
Okay, so, but
Yeah, so
you don't
no,
have a-
we agree.
Okay,
No.
we agree on that.
Move along.
Hysterectomy.
Hysterectomy is sterilization, and so I think the issue is if they have an actual medical condition where they need the removal of the uterus, we have to have a clause for that, because that does occur in some cases. But if they don't have a different medical condition, then 18 would be appropriate.
And I think that's covered because it's for the purpose of transitioning a child.
Okay, same page.
Is
Yep.
qualifying.
Okay.
Okay. Oophorectomy, I don't know if I'm pronouncing that right.
That removes the ovaries and sterilizes, so I agree.
METOIDIOplasty.
That does not necessarily, it doesn't take out any reproductive organs.
What is that?
So metoidioplasty is a surgical procedure to, if somebody's already had testosterone, it takes the clitoris and it makes it more prominent, so it looks more like a penis. I don't have anybody under the age of 18 having metoidioplasty, so I think it's fine to make that 18 and older.
Excellent. All right. Orchiectomy.
Orchiectomy removes testes. That's sterilizing, so I agree, 18 and up.
Penectomy.
Penectomy, we really don't have penectomies. That's not how genital surgery works. We don't cut off the penis. Like, people are very misinformed about that. That could lead to sterilization, so 18 years old would be good.
Phalloplasty.
So phalloplasty, the creation of a penis. If they keep their uterus and ovaries, they're still fertile, but I have no patients, and I've heard of no patients on record that have had this below age 18. So 18 is fine for phalloplasty.
And vaginoplasty.
Vaginoplasty or vulvovaginoplasty, in most cases, this is going to be sterilizing. So in Texas, we could do 18.
And now let's talk about mastectomy.
Sure.
Would it fall below the standard of care for the purpose of transitioning to take a child through a mastectomy?
These are very rare cases, and in some cases, it would be standard of care. I think the other thing you have to think about is there are plenty of Texans who are 16 and have had a breast augmentation, and there's no issue with access to that. And so if we're going to keep allowing that in non-transgender patients, then we shouldn't have a different standard for transgender patients. And what we always see is when we're trying to make standards is folks trying to remove things from trans people. That's like always the case. So I want to notice that we're doing that again.
Is it, doctor, do you know if it's true that once a child on...
Would you mind speaking into the microphone?
Yeah, sorry. Is it true that once a child on Lupron, and then testosterone for a period of a few months, if they are, that is irreversibly sterilizes the child?
It depends on which Tanner stage they start the Lupron at. And so if they start the Lupron when they've already had a menstrual cycle, then yes, they will be able to be fertile again in most cases. But we didn't test their fertility before we started, and we're very clear with that with patients. However, if they start at Tanner stage 2 with Lupron, a pubertal suppressant, and then if the family makes the decision to go on testosterone, one of the very clear risk and benefits that we discuss with parents is that we do not believe that they will be able to be fertile in the future if this is the decision that they make.
And that difference between Tanner 1 and Tanner 2 is really based on the health.
Hair, it's a physical exam that a medical provider has to do to make that determination. That's always done before we start pubertal suppression, always.
Okay, so would you mind that particular situation falling below the standard of care for a child, for the purpose of transitioning a child?
No, the parents deserve the right to decide with the physician if that's an appropriate course of action, as long as they go over the risk and benefits.
Thank you, doctor.
Representative Jones.
Pardon me for my ignorance, but I would really love to know, why is there such an overemphasis on the removal of breasts if we're having a conversation about sterilization?
I'm not leading the conversation, so I'm not sure why they're asking these questions in the way that they are.
Thank you very much. And so the next question is, there seems to be some situations where it is appropriate for mastectomies under the age of 18. Could you speak a little bit about that? Because it seems like there was, I think for me, and I'll just speak to my own ignorance, there seemed to be a confusion around sterilization and mastectomies because we keep on talking about them.
So mastectomy is removal of breast tissue. That if I had a mastectomy, I will be open about that. But that didn't make me infertile or sterilize me in any way. It made me be able to confidently walk outside my house in Houston, Texas, in the middle of the heat and bring out the trash without a shirt on. It made me comfortable to open the door to the pizza person without a shirt on. It made me comfortable to walk down Galveston on the seawall and to be very proud of myself. It changed me in a way that I don't even remember what it was like before I had a mastectomy. It was such a positive experience. And in terms of, younger and younger people, when you have these young folks who have double D breasts, and our medical advice to them is to try to live in the social role of male, if you have double D breasts, that's almost impossible. So many of them will wear binders, and they'll get rashes under here and get acne and all sorts of issues. And so in very rare cases, I want to be very clear, most people have mastectomy after age 18. Let's be really clear. These are rare cases, but they do exist with proper psychological assessment and family preparations where it is medically necessary before 18 to have a mastectomy, which does not sterilize the patient.
Thank you. I appreciate that.
Yeah, absolutely.
Representative Jatan.
Yeah, thank you, Chair. I was just looking at the study you gave on the regret after gender-affirming surgery, and it looks like the median age is 30 and 40s.
Yeah, because most people have surgery not even in this area we're talking about, age.
Okay, so the study, so I guess the question goes back to among those that are, if the brain fully develops at 25, I mean, just looking at 18 and younger, do you know of any studies that shows the regret factors among those children that end up making lifelong decisions?
So I'm really glad that you brought up the whole brain develops at 25. So I'm a child family psychologist and an expert in development. And what we know is that gender identity develops between age 18 months and 5 years of age, not 25. So I think it's really clear that we need to get on the same page in terms of when does the brain develop. In terms of knowing what gender you are, what genders other people are, between 18 months and 5 years of age is when that development is typically supposed to happen. But for me, since mine was not a girl and everybody said it was a girl, it was delayed until later. And so I think it's important to make sure that we're clear that we're treating folks based on something that's supposed to develop in early childhood, not things that are supposed to develop like, who do I vote for and how do I become a real adult? Those sorts of questions that develop later.
So society delayed the development, your development in knowing what sex you were until after 5.
And they didn't mean to do it on purpose.
Okay. So it doesn't change. So the question remains of those, so if they're 15, 16, let's say they're 5 years old and they're still trying to figure this stuff out.
Sure.
Do we have any studies or anything to support the idea that at that age, they're able to make decisions that will impact the rest of their lives?
The parents are in charge, and so the parents are the ones that are charged with these decisions. The children and adolescents are sent to treatment.
How do they know what that development factor is in their child's brain?
Sure. So we're not even talking about any of these treatments with children. They have to at least start at puberty. So we're not talking about 5, 6 years old, anything like that. We're talking about folks who have already gone through a gender identity development. Early childhood is done. So these are older folks, right? So they are able to give assent. And also part of the really important assessment process that we keep talking about is making sure that the young person has emotional and cognitive maturity to make this decision. So I'm on the same page that we need to be making sure we're doing that. And that is already part of the standard of care.
Well, I think that's part of the debate that we're having, right? Is that, so and you even mentioned, society impacts whether or not, it has an impact on whether or not you fully understand what you are. And that, when you're going through your adolescent years especially, people convince you of a lot of different things. The concern that we have is that ends up happening at an age when they don't know the repercussions that are going to be for the rest of their lives. And we are talking about them seeing a psychiatrist and answering questions and that mental health professional making that decision based on what they're told only, because there's no way to point to anything in the brain that says, all right, this confirms this is accurate. And they're being referred to a doctor who is making decisions that, while confirmed by a mental health professional, is still based on a child's assessment, their own assessment. And so this is what we're worried about, and this is what we're trying to understand. And when we look at whether or not there's regret, that's the study that we need to see. And I will add to this that the state of Texas invests heavily in mental health and is substantially increasing that in this session, because we do recognize that as an issue. But part of that mental health services is going to be helping people where they're at, especially when they're children, because there are a lot of decisions that they're just not have the capacity to make at that age.
And that's why the parents' rights are so important to protect their children. And then they need to be able to access health care and experts in order to make the best decision for their family.
To the extent that it doesn't have lifelong impacts. A lot of the stuff that we talk about within mental health, when we talk about providing assistance, they usually don't have lifelong repercussions. When we talk about depression, when we talk about a lot of different things, you're talking about putting them on medications that help stabilize and helps them to process and understand where they're at. Usually they don't have lifelong impacts.
Lack of access to them absolutely does, including increased risk of death, which is also what we're trying to talk about as well.
Repeat that last line again.
Lack of access to depression medications does have lifelong effects on people. Same with lack of access to care for those who need it in my community.
The difference being that when you get on depression medication, it has an impact at that moment and doesn't potentially have lifelong.
So it typically takes at least 4 to 8 weeks. It doesn't have an impact at that moment. And similarly, with pubertal suppression, with hormone therapy, we don't just start them on treatment and say, see you later. We have very close follow-up, at least monthly to every 3 months, to make sure that intervention is correct for that person. And so that's why it's important to see folks who know what they're doing in this area.
How do you determine if it's right for that person?
Everything is a trial. So my parents asked that exact same question to Dr. Walter Meyer.
Is it affirmed by the individual?
Can I please answer your question, sir? Thank you. My questions, and I think that's a very important question, is how will we know if this is right for the child? That is the crux of the matter. And so I want to make sure that everyone hears this question is so important. My own parents, I'm an only child, and they're both doctors, and they're trying to figure out, they've never heard of this, they don't really know what they're doing. So they talked to Dr. Walter Meyer, who's one of the leading experts who started pubertal suppression in the state, actually, and is widely regarded, internationally known. And he said, you know what? We can't know. Every medication is a trial. And so that's why we start with the fully reversible medications, and we follow up closely with them. And then we see what their response is to that intervention. And if this child comes alive, if this child is no longer thinking about death, if this child is interacting with their family, we have to look at that response to intervention. We can't deny that.
So to confirm, you are saying that the affirmation is their emotional state that changes.
The response to intervention is how the young person responds to the intervention.
If they come alive.
That's one of them, yes, that I hear all the time from families.
How long does coming alive usually last?
It depends. Does their church want them to come anymore? Do they still have friends? Did the person they were dating break up with them because they're trans? Do you see all of these outside supports are so important?
So again, I think we're getting back to the impact society can have on whether or not an individual, an adolescent, is getting the care that they need. And we should be able to, I think there is enough evidence that teenagers are usually spending most of their teenage years trying to figure themselves out. And for them to spend that time making decisions that'll have lifelong impacts is a dangerous, thing. And I think it is, I think that's inaccurate. I will have to disagree with you on that.
We
and,
require parental consent for anyone who's under
have
the
no-
age of 18.
I have no doubt
It's a-
you. I have
it is a
no doubt
fact.
you require parental
Consent.
permission. So, all right, I will leave it at that. Thank you.
Thank you so much for the conversation.
Other questions, members? Representative Jones?
Earlier, in your time here, you were talking about the importance of peer review journals. Why is that important?
Because anybody can publish things online and say they're published. But we have to hold our colleagues who say they're published to a standard, a professional standard. And so when you were asking that gentleman, do you conduct research? And he said, define research. That's a big red flag for me. You know if you do research, You went through the IRB committee, all of those things. He has not done that. He has not published in any peer-reviewed journals. So it's important if somebody purports themselves to be an expert to be able to clearly answer yes or no if they've done research, and also if the publications that they have made have actually gone through a peer review by a jury of their peers or colleagues who are experts in that same area. And that gentleman failed to meet that criteria.
You said you're a PhD in what?
Clinical psychology, child and family, University of Houston, go Cougs. I knew it.
You said you're an MD and you specialize in what? Or you're trying?
Family medicine. I take my boards in less than a month. Say a prayer.
I've heard a lot of testimony about you give surgeries, I guess genital surgeries to children. Let me finish.
Oh, yes, ma'am.
You've heard a lot of testimony about genital surgeries being performed on children.
Mm-hmm.
And then they get older and they have regret or you can't go back.
Mm-hmm.
Right? So I'm just curious. You've been here all day today.
Oh, yes.
Have you been here all day today?
Yes, ma'am.
Did you hear anyone who testified there was actually a kid that made this decision that got surgery and then regretted, or did you hear like I heard, like everybody was an adult and made the decision? Okay.
Correct.
Then also you've heard testimony today where they talked about it's irreversible. I want to sort of reverse the analogy. So you're a kid, like my client, who was getting in the girl line when she was in pre-K and didn't learn about it on the internet. And they have no peer pressure or none of those things on the internet where they say you can go there and be made crazy and brainwashed. None of that existed. You know that you are trans. Well, you don't know it's trans, but you think you're a girl.
You know
but
what
it's
you
something
like.
You got, right. So then they don't let you get surgery, and you have to wait until you're 18 before you're allowed to have surgery.
Genital surgery, yes, ma'am.
Yeah, genital surgery.
Yes, ma'am.
So this is what I'm thinking. Tell me if I'm right.
Sure.
If I know I'm a girl, but I was born in a boy body, and I don't want to get buff. I don't want to have broad shoulders. I don't want my Adam's apple to come in. I don't want my bones to be whatever, because I know the difference in my son when he went to college and when he came back. He was a boy when he went. When he came back, he was a man, right?
That part.
He gained 50 pounds from the time I dropped him off in August of 2010 when I picked him up after his freshman year. In May of 2011, he gained 50 pounds and grew 4 inches. Wow. Right? If I know I'm a girl, even though I'm born in a boy body, if I start taking whatever that healthcare stuff is, right? Because I'm not about to
medical treatment.
Yeah, that part. If now at 18 I'm 6'5", got a deep voice like this, can I go back? Can I go back and be feminine at 18? You give me hormones.
It is much, much harder So just like we talk about, some of the hormone treatments are irreversible partially, same with your own puberty. So if you already have a deep voice, I can't change that. We have some surgeries, they're not great. If you already have a beard, maybe we can pluck that, but it's still there, it's still gonna grow. So it is much easier and the treatment works much better with early intervention in the appropriate cases.
So if I'm forced to wait until I'm 18, then I will not be the woman that I was born to be. And I don't even know how to explain it. I can't go back and be, I don't know, 5'6", and petite.
Yeah.
And with feminine features.
That's so true for so many of my patients.
Because I remember when I was little, in elementary, me and the boys, we would go head to head, I would whoop them, right?
That's right.
And then I remember most in middle school, kickball, dodgeball, and all that stuff. That's when the boys started being bigger, stronger, faster than the girls, right? But are you suggesting that the science shows that if we're able to stop it when kids know who they are, that they're more likely as adults to be who they are?
Absolutely. We have plenty of research showing that. And folks that, when I talked about the regrets, they say, I wish I would have started sooner. That's exactly what we're talking about. And only going through one puberty sounds great.
You know what's really interesting to me?
Tell me.
Is anybody else came up here, Mayo Clinic, Rice, Go Cougs, specialty in this very area? I mean, correct me if I'm wrong. You're studying like in this very area about what this bill purports to regulate,
Internationally
correct?
recognized expert.
I'm just surprised that I'm just surprised that you actually have like actual education in what we're talking about, and people are trying to dismiss that. And
the people that generally have the strongest negative opinions typically know the least, and unfortunately, some are willfully ignorant.
And I'll say this. I mean, some people believe from the depths of their soul they're right, right?
Sure.
Even
We
though
all
they're wrong.
do.
But I guess my question is, there were a number of times where you were trying to talk, where you were asked a question and you started answering, and then you got cut off. So then I guess my question is there anything that you wanted to say that you weren't allowed to say to help us understand why listening to kids and their parents and their healthcare providers to make the best decision for that child is important and is based in science? Can you just share that? Because you did get cut off a lot.
Thank you, Ms. Jones. So, bottom line is everyone deserves access to health care, period. And for transgender youth, there are clear standards of care that keep getting updated with newer and newer research, just like any other area of health care. And the idea that because we have low quality evidence, which is the same standard that many other healthcare prescriptions meet, but we're not trying to ban those, is a direct affront to my community, and it's very much targeting us. We are supposed to be held to a higher or different standard than general medical guidelines, and that's inappropriate and fueled by bias, is my clear perspective that I've seen for many years. I also want to be very clear, because we keep talking about genital mutilation and surgeries on children, and so I want to really get clear with the record here. I think it would be important, if you're going to pass anything, to have exceptions for the young folks that really need the care. I am fine to sign on with no sterilization until age 18 or later. I think that's a good compromise that we can work together and make, and different states may do things differently, but I think Texas is Texas, and I think that's a fine concession to make. We do need to know that the genital surgeries that are performed on children are for intersex children, and we've talked a little bit about them before. one issue I take with testimony previously is they've said only if it's a medically necessary condition. So like, let's say a person's bladder is born on the outside or the urethra doesn't allow them to urinate, absolutely. However, there are cases of genitalia that doesn't look exactly like a penis and scrotum or a vulva, where there's actually nothing anatomically wrong with the child, that genital surgeries are actually being performed without the consent of this person. That does occur. So I want to make sure that folks do understand there are genital surgeries being done on children without their consent in intersex children, and not always with a medical indication, sometimes with only a cosmetic indication. And you may hear from some of those folks today.
And then I guess my final question is this. So some of us aren't doctors, like me. Well, I'm a doctor of jurisprudence, but
yes,
not in this, not related to medicine. Just give us some examples of you're younger than 18 and you need to have surgery. Like, give me some examples of that, please.
Sure. So, goodness gracious. So, young folks, probably 16 years old would probably be the median age come in. They've been trying to live as a boy since they were in daycare or 7 years old, you know, for like almost 10 years of their life. The majority of their life, they've been trying to live as a boy. They go to the locker room, they try to change. They're trying to live in the social role of boy, which is what we require before treatment. And they're not able to do it. They'll change in the bathroom or they just won't even go to sports at all. They many of my patients will wear these huge hoodies when they come into my office, and they'll have their back sort of like this in order to try to hide the breasts. They'll wear binders and other things that we try to do to help them appear more of a flat chest. Some of them, unfortunately, will do cutting on this area because it's so foreign to them and doesn't make sense. And so in cases like that, where we have that severe dysphoria that for years has persisted, not knock, knock, I'm transgender, can I have surgery, that some people are talking about, that is not standard of care. We've been working with these families, we've been following them, and the person has been very clear. Most cases won't have surgery before 18 because most parents will not get on board. And that's okay because parents have the right to decide about their health care for their child. But those that do, and it is medically indicated, do really well. We do have a study, actually, I didn't bring that one because we weren't talking as much about surgery, but mastectomies. Johanna Olson Kennedy did show the positive mental health effects of mastectomy in transgender boys. So that has been shown. We do have research on that.
And the last thing, you gave Dr. Oliverson a bunch of, I guess, treatises or
empirical, peer-reviewed.
Yeah, so I'd like that. I mean, you don't have to give it to me now, but can you get it to my office, please?
I'll give it to you right now. I brought this for y'all.
Is there only one copy, though?
Yes, but I can email everybody.
Okay, so why don't you do that? I want him to have it because he asked for it first.
Okay, we will
Right, so
email all the committee members, all
yes,
the research
well-
studies, including the one on mastectomy that we just discussed.
Okay, thank you.
Yes, ma'am.
Other Representative Jones.
Y'all, I'm sorry, but I'm about to go there. I just have one question. When we talk about, and I've worked in public health, but this is more community health. Wouldn't you consider male circumcision gender mutilization?
Good question. So it is not my area of expertise. I do not perform circumcisions, even though some family doctors do. It's not part of gender affirming care. So it's not related to this bill. So it's not, in my mind, related to anything that we're talking about here.
No, I appreciate it.
So
I just asked that question because that word has come up all day long.
Yeah.
And so when we talk about, there's a lot of things that have come up that's not germane to this bill or conversation. And so the definitions, maybe it's just getting lost upon me, but I'm just really wanting to really find a focus back to what we're really trying to talk about, and that's equitable health care, for young people, particularly those of trans experience. And so, thank you for your answer. I really appreciate it.
Sorry, Ms. Click.
Representative Jones.
I have one question. Is circumcision of the penis medically necessary?
No professional associations say that circumcision is medically necessary. However, they offer it because in rare cases it can lower some rare risks such as urinary tract infection. But there is no medical society that currently says that it's recommended treatment. And I'm a family doc, so I work with babies and we go over the consent form at Mayo Clinic all the time. But the parents have the right to decide
whether to circumcise their child's penis.
Yes, ma'am.
Thank you.
Other questions, members?
I'm sorry, Madam Chair. So we just had to bring this conversation up. So is that also a religious practice for some people?
I really think we should stop talking about circumcision. It's not on the bill. It's not related to trans health.
I kind of agree. I came
think
back
the
in here,
chair
I'm not
is
really
done.
sure how we got on this conversation.
So I'm going to avoid the question, just to be honest, because I don't think it's relevant to our shared goal of taking good care of Texans.
Great. I agree. It's a bad example. Thank you.
Other questions, members? Thank you.
Thank you all so much.
Chair calls Joe Burgo.
Hi. You all have been incredibly patient and thorough. I'm going to try and take up less of your time. I'm Dr. Joe Burgo. I'm speaking on behalf of GenSpect, and I'm speaking in favor of the bill.
And you are also testifying on behalf of yourself, is that correct?
Myself and GenSpect.
Thank you very much.
So thanks for inviting me to speak. My name, as I said, is Dr. Joe Burgo. I've been in practice for 40 years now. I'm a clinical psychologist and a psychoanalyst. These days, I divide my practice up pretty much evenly between seeing gender-distressed adolescents and young adults who medically transitioned, realized they'd made a mistake, and have gone back to living as their biological sex. I regularly consult with parents of adolescents as well. So besides my practice, I serve on the leadership team of an organization called the Gender Exploratory Therapy Organization. We're a professional group that promotes traditional exploratory psychotherapy for gender distress. We also provide training for professionals who are new to working in the field. I'm the vice director of GenSpect, which is an international organization that promotes a non-medicalized approach to sex and gender. And finally, I'm the clinical lead for Beyond Trans. It's a part of GenSpect. We provide social support and subsidized psychotherapy for young people who are coming to regret their transition or who may have already detransitioned. So pretty much everything I do other than the hours I see in my practice, I do pro bono. And when I tell you that I'm also the father of a daughter who pursued cross-sex hormones despite her parents' misgivings and ended up on a psych ward, you will understand why I do the work that I do. Even though I'm a mental health professional, and I know my daughter better than any doctor or therapist who advised me, who affirmed her identity, I was impotent against a kind of a team effort to affirm her identity and was monstered basically for questioning whether or not this was a good idea. I gave pretty cogent reasons for why we should doubt my daughter's belief that she had been born into the wrong body, and it went nowhere. I was overruled. So I hear similar stories from the parents of teens that I consult with of being, there being a team effort, of their doubts being overruled, of them being, treated with contempt and scorn for questioning the agenda. So I don't know. I'm a man who has libertarian tendencies, and I'm a small government conservative. But I think this whole situation has really changed my mind. I would normally oppose this kind of a bill, but the ideological capture of the American Academy of Pediatrics and other medical bodies in my own profession, it's just changed my mind. If these bodies won't regulate themselves, if they will not allow dissent from within because activists control what's allowed to come up for debate, then someone has to do something to put an end to the continuing horrors of pediatric gender medicine. In my view, I'm afraid that job falls to you. On behalf of all the parents with minor children who will be harmed if these procedures are allowed to continue, I urge you to pass the bill. And if you have questions about my personal professional experience, I'm really happy to answer them.
Questions, members? Representative Alverson.
Thank you, Madam Chair. Dr. Burgo, I appreciate you being here today, and I know you had to travel to get here, and we appreciate you coming and sharing your expertise. In your practice, it sounds like you've kind of seen the whole spectrum of people that are struggling with gender identity type issues and things like that. Right. Can you talk a little bit about we've heard a little testimony today, sort of this connection, if you will, between sort of a trans identity and also same-sex attraction. Is that a thing? And if so, can you help us understand or put some guardrails around, like why does that appear to have a correlation?
Right. Well, historically, we know that the people who showed up at the gender clinics were, by and large, same-sex attracted. There's a 2011 Dutch study on puberty suppression. There's a 2012 study out of the Tavistock. And we're looking at 80% of the kids are same-sex attracted. What's really different now is that there's this other option. It used to be that they would go through puberty, they would normally come to make peace with their body, and most of them, the majority, would realize they were gay. That's very different from the way it is now, where you're presented with this new option, which is that you actually have a different identity. You're born in the wrong body. You have a trans identity. So what I see is, one would think that being gay today would be a lot easier because we have Obergefell and there's a lot more social acceptance. It's really not true. It's still for kids in middle school coming to terms with same-sex attraction. It's very hard. I've had clients who have come out briefly as lesbian and then moved on to a trans boy identity because they felt so uncomfortable with being a lesbian. I have male patients who hated themselves for being gay and went through full medicalization, orchiectomies, or penile inversion and vaginoplasty, and realized ultimately that they were gay. That's the most horrifying part of my work, is to work with these men who have undergone these irreversible surgeries because they hated themselves for being gay. I don't know. I'm a gay man who came to terms with being gay pretty late in his life, so I understand how hard it can be to face being homosexual. And even in my own gay community in Palm Springs, where I have sat on the board and served as a director, it's not, trans is celebrated now. My LGBT center is trans this, trans that. We've got a Trans Tuesday. There's to celebrate trans kids coming out. We don't have a gay Thursday. We don't celebrate gay and lesbian anymore. If you look at our newsletters, gay and lesbian don't occur in there anymore. It's all trans and queer. So in my own community, we're celebrating trans and not helping people to feel comfortable with same-sex attraction, as we all came to do.
So you're kind of the second person to hint on this today, but I'm curious because I'm learning some things. I thought I knew a lot about this, but I'm learning some things. So do you think then that if a person is having difficulty as an adolescent accepting that they're same-sex attracted and they see the transgender identity as maybe a softer landing for them, if you will, is that really living their authentic selves, though? I guess what I'm asking is, in your experience, and you have a unique experience of working with people who've kind of gone that whole pathway and then woke up, or not woke up, but at some point in their younger adult years realized this wasn't who I was all along. I mean, is there a cohort, I guess, at least, within this population, or maybe even a large percentage of folks who are being referred to the gender clinic for transitioning who, if they were simply given the love and support that they deserve, that they would probably come to terms with their same-sex attraction, and as adults, they would have very healthy, normal relationships with the people who they most wanted to be with?
I think so. Which is why I'm so in favor of this bill, is I think finding your authentic self is a process, and it takes a long time often, so we really need to make sure that there aren't these irreversible choices that are made at such an early age.
Yeah, because once you close that door, you can't open it again. I mean, I think you were telling me at one point, we were conversing a little earlier, and you were talking to me about a patient that you had that was in his mid-20s, and just the unbelievable anger and frustration and sort of self-loathing that he had having made this decision to transition from male to female, and then realizing later in life that he was in fact a gay man and wanted to be with other men, but now his anatomy was horribly mutilated, and he was, you were describing there were profound emotions that he was struggling with to try to find some relevance in the world, having literally gone down a path from which there is no return. And it was clearly the wrong path for him.
It was clearly the wrong path. And, part of my job with Beyond Trans is when we're contacted by a detransitioner or someone who's questioning, my job is to find therapists for them. It's picking up speed. They're coming like pretty much one a day now. I've got to find a therapist. And there's a lot of young men coming through now. It's the young women who have been getting most of the attention lately, but now there's a lot of young men, and I think for them, there's more shame involved in coming forward. It's harder for them, especially if they've gone through genital surgery. It's very shaming, and they don't want to come forward, but they are there, trust me.
Okay, Doctor, I know you spent the whole day waiting to testify, but I just want to say that really appreciate you being here. Thank you so much.
Thank you for inviting me.
Representative Smith?
Hey, Doctor, can you hear me okay?
I can.
Good. I think you've been in here most of the day, if not all of the day.
Since 8 o'clock.
Oh, thank you. Well, really, thank you very much for taking part in this process. If you've been in here since then you may have heard some of the testimony concerning some statistics about the increase in numbers of folks under 18 years of age in the last 10, 15 years. Did you hear that?
Sure.
Has it been your experience in your practice that there's been a dramatic increase over the last 10 or 15 years in a number of children who are dealing with gender dysphoria?
Well, to be honest, I stayed away from gender until a few years ago. I was pretty scarred by what happened to my daughter.
Okay.
And then I got back involved and I joined the Gender Exploratory Therapy Association. There's a directory of therapists who are willing to work with dysphoria in adolescents. I'm on that list, and I get contacts every single day.
When did you get on that list?
A year and a half ago, right when it formed, maybe a year and a half ago.
Okay, all right. And so, but you've been active in a clinical psychology practice for how long?
For 40 years, and I've worked with gender throughout my career, but it was pre-trans ideology when we didn't have the option the idea that you were born in the wrong body didn't exist. So I was able to work in a space where the idea of affirmative care didn't exist.
So when did the trans ideology, as you put it, when did that start?
Well, when my daughter first got into it, we're talking 10 years ago, and I think it was, you know, maybe 15 years ago is when it really started to come in. I mean, that's the thing that's hard for many of you to understand, is this idea that a therapist would either affirm or disconfirm someone's identity is just completely alien to the way I've worked for decades. You know, you just don't do that. You go in and you explore things and you try and help people come to their own decisions. But the idea that someone would come in and state who they are and you have to decide whether or not it's accurate, it's just anti-psychotherapy to me.
And it was alien to your practice, and would you say that it was alien in the practice to do that? Before the trans ideology?
Oh, yes, absolutely. This is a totally new treatment modality. Affirmative care is the new kid on the block.
Well, this is kind of what I was wanting to talk about. I think we've, in a roundabout way, ended up kind of establishing what I'm trying to establish is that we have this new situation because this ideology has now generated, would you not agree, a larger, statistically significant large number of new patients who may or may not have this issue.
Yes.
And would you agree with me that as a result of that, whatever the cause was, but as a result of that, we now have, you know, you heard President Eisenhower talk about the military-industrial complex. We now have within our medical establishment, since it's been going on 10 or 15 years, we now have doctors who essentially have established their practices around this. We have this whole medical establishment and all this money that's being made off these children. Would you agree with that?
I do. I'm not as cynical as you sound about it. I think that most of these docs and therapists believe they're doing what's best for their patients because their boards tell them that this is the right way to go. They trust their boards because everybody can't conduct nonstop research. So, yeah, but there is a whole industry around it, and a lot of my older colleagues, dinosaurs like me who practice the old way, they won't go near it. They won't go anywhere near gender. They're scared. They're scared of people coming after their license because they don't affirm. So we've lost a lot of really qualified clinicians who might otherwise be really helpful because the dominant point of view, the affirmative care model, you know, has shut them out.
Well, going back to the cause of this sudden increase and influx of patients, what do you have things that you've experienced in your practice or from your practice that point to certain causes for this?
Right.
What are they?
Isolated, lonely, outcast, misfit kind of kid gets a smartphone, finds the internet, goes on Tumblr, goes on all the different places and gets, I don't know what the word is, but they get indoctrinated. I think it's an internet phenomenon. That's what happened to my daughter. I mean, she found everything on the internet.
Okay. Gee, sounds a little bit like COVID, doesn't it?
Things really spiked during COVID because kids were shut up at home with their computers and smartphones.
Okay. So, do you think that we have, though, some children who, in your 40 years of practice, do you think we have some children who have true clinical struggles with gender dysphoria?
I do.
Okay. Who need certain treatments?
I think there are some people with enduring gender dysphoria who have struggled with it for years, and pursuing medical treatments is the only thing that brings them relief. I have friends who are among that group. I think it's a very, very small group, and I don't think most of the kids we're seeing coming up today are like that.
Yes, well, that's where I was going next. The problem is you may have that small group, right? But now, for whatever reason, whether it be COVID, the internet, combination thereof, poor parenting, whatever, we now have this major influx over the last 10 or 15 years of new patients who quite frankly may not need to be subjected to these protocols. Would you agree with that?
Yes.
And what do we do about that?
Well, we pass bills like the one under consideration to make sure they don't do anything too soon. And we try and advance traditional psychotherapy, that isn't affirmative. I get parents calling me all the time wanting me to talk their kids out of being trans. And I tell them I can't do that. That's not my job. It's not my job to affirm their identity or to talk them out of it, but to help them explore themselves so that they can make the best decision for themselves when they're 18. We need to be doing more kind of work like that rather than trying to validate someone's identity or disconfirm it.
Why can't we trust the medical profession to do that?
In my opinion, the medical professional organizations are really indoctrinated. They're really dominated by activists who believe this ideology, and they control the agenda. I have a friend who's part of the American Academy of Pediatrics, and she's been frustrated because for 5 years now, she can't get it on the agenda for them to discuss the affirmative care model. The activists just keep it off the agenda. So, they're captured. I think that's why you would like these professional organizations to regulate themselves, to police themselves, to allow debate, but they won't, so someone has to do something about it.
Thank you.
Other questions, members? The patient population that you're seeing we've heard some other testimony today about some of those young people being on the autism spectrum. Are you seeing that as well?
I am seeing that as well. People will say there are reasons why they're particularly susceptible to the trans identification, but what I've seen is like the autistic kids growing up, they're just kind of odd. They don't read social cues very well. They don't fit in very well. They're kind of bullied and teased often. And then they identify as trans, and all of a sudden they're celebrated, they're love bombed, they're, welcomed as heroes. They're particularly susceptible, to this ideology.
Folks on the spectrum sometimes also have some compulsive behaviors. Right. Could that potentially play into it, or?
Definitely, and they're prone to black and white thinking and coming up with ultimate solutions. There's lots of things about spectrum kids that make them prone.
Thank you.
Yeah.
Questions, members? Thank you for being here.
Thank you very much.
Chair calls Gloria Valadez.
Hello. My name is Gloria Valadez. I am representing myself and testifying against this bill.
Great.
I was born and raised in Texas, and I have never testified before or even been to the Capitol before today. I hate that I'm here today sharing something that is so sad and personal for me and my family. It's especially difficult to be here today hearing you all talk about suicide for trans youth when this issue hasn't affected you personally like it has for me and my family. I have 2 younger siblings who mean the world to me. I don't think of myself as just their older sister. I see myself as their second mom. I love them so much that it's overwhelming. One of my younger siblings is transgender. He means the world to me, but I almost lost him a year ago. He attempted to take his own life on the same day that the Texas government announced it was trying to take away the health care that he needs. I'll never forget how scared I was while I was in the hospital with my brother, hoping and praying for him to survive. When asked why he tried to take his own life, what made him feel that he had no other options, he said that it was the political situation here in Texas and the directive in the news that day threatening his health care. He felt unwelcome and attacked by his own state. My brother had to miss the rest of the school year just to recover from the trauma imposed by his own state government. He couldn't just be like other kids and was scared to death that CPS would come to his school looking for him to take him away from our home and our family. My brother loved soccer, cross country, and track. I used to call him a skinny legend for how much he ran. He was always full of energy. He never sits still and loves group sports. But now he can't run track because of the cruel and stupid bill that this state passed last time. The pain that bills like this one cause is real, and it hurts. My heart breaks for my brother and other trans teenagers who have been repeatedly harmed by the state. My brother and so many trans teens can't be here today to tell their stories because of threats to their safety and well-being. But they are listening, they are loved, and they deserve the same health care as everyone else. The truth is, this health care is life-saving. When my brother was finally able to see a doctor for his gender dysphoria, he became happier, healthier, and more himself. To force him to lose this care, to not be able to get the care that he needs, is devastating. My brother is a human being who deserves to live. I'm so grateful every day that my brother is still alive and a part of this world, but it feels like our state keeps attacking kids like him. I worry every day what will happen to my brother in a world where people are taught by those in power that it is okay to treat him as less, to treat him as a political pawn. My brother deserves the right to health care like everyone else. Please stop attacking him. Please don't pass this bill. Please let him live.
Questions, members? Thank you. Chair calls Gary Floyd. Good evening, Dr. Floyd. I have here that you are representing the Texas Medical Association and yourself, and you're neutral on the bill. Is that correct?
That's correct.
All right. Thank you. Please begin.
Chair Click, members, what a day. Thank you for allowing me to testify. I am Dr. Gary Floyd. I'm a pediatrician, and I'm the current president of Texas Medical Association. On behalf of TMA and our over 57,000 members, I'm speaking on this bill, not for it, not against it, because of two reasons. Subject matter, providing gender-affirming care to children and adolescents with gender confusion or dysphoria is very complex, as you have gathered throughout the day. Second reason is we have members on both sides of this issue. I can't point to a universally accepted best practice clinical guidelines for this vulnerable population. And we do understand that there is ongoing debate over what is medically appropriate care for transgender patients. But as you understand, there's no two patients that are the same. What works for one may not work for another, which does make the relationship between the patient and the physician, as well as the physician's medical judgment, very crucial to these cases. Initially, patients, you've heard this, patients and families need their physicians to listen to their concerns and to work with them over months to years to help them understand these issues. We appreciate that this bill has not discouraged or prohibited such interactions. However, outside of mental and behavioral health treatments, this bill does eliminate most medical treatments for gender dysphoria. While TMA is generally not supportive of permanent surgical care to minors, those relatively few physicians who do try to take care of these patients feel that having medical options is very important as they try to exercise medical judgment and work with individual patients. Should this bill go on and move forward in the process and include the current prohibitions of medical treatment that are currently drafted, TMA would, at a minimum, have three requests. First, that enforcement remains strictly with the medical board. Second, that patients that are currently on hormone therapy be allowed to continue in order to try to avoid any adverse effects from suddenly being withdrawn. And third, should a child on hormone therapy or puberty blockers from another state have to be hospitalized for an extended time in a Texas hospital, we would ask that their medications be able to be continued by their attending physician without liability from this bill. With that, I'll just stop. We greatly appreciate Representative Dr. Oliverson's open door, and I appreciate the opportunity to testify. I thank you, and I'll try to answer any questions I can.
Questions, members? Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here today.
Sure.
So I watched your testimony. I watched a lot of testimony from the Senate. And it says you're testifying on the bill, but when I watched your testimony, it sounded as though your association believes these surgeries should be able to be performed on minors. Where do you stand? Because I think it's hard to be neutral. I find it hard to be neutral when we're doing some things that have permanent effects on that growth of a child and the outcome for a child. Puberty blockers, hormones, sometimes surgery. I find it really difficult to believe that you're neutral on this bill, especially after watching the Senate hearing.
So I was working, I didn't watch the Senate hearing. I'm sorry for that, but I think I stated that right up front as to why we're testifying on.
Well, but
we agree that surgery in minors should not be done. That is not standard of care. Pardon?
Mastectomies as well?
Same way, both.
Okay. What percentage of doctors in Texas do you believe agree that genital mutilation surgery should be legal in a child? You said you have 57,000 members. What percentage of them think that it's okay? Have you polled them? Have you talked to them?
Interesting, we have polled less than 1% cite gender-affirming care as a priority. So it is not a priority of TMA. We are here to testify. We do have a very split group on this, but it's a small group that when you refer to gender mutilation, I don't think any of us support that.
So you're a doctor, correct?
I am.
So where do you stand personally on this?
Unfortunately, as president of TMA, I have to speak for TMA policy. I'd be happy to talk to you about my personal beliefs.
No, you're okay.
Beyond, outside of here.
No, all right.
And I have with Dr. Oliverson.
How would the TMA define a woman?
Woman is one with XX chromosomes, has a uterus, has a vagina, has ovaries, can produce eggs, can reproduce children.
Are doctors in Texas required to know what a woman is and what a man is prior to getting licensed to practice medication? I'm asking only because I had a doctor today that couldn't really tell us.
I've been here all day. I heard that. I thought that was fascinating. And a male is XY chromosome, has penis, cannot reproduce other than with a female.
Can any man get pregnant?
An XY male cannot get pregnant.
Explain that.
Now.
No, you said an XY male. Are there other types of males?
Well, socially, our social system has allowed females to say they're male, to dress like male. We're talking now gender identity and gender appearance. We're not talking about whether they can reproduce or not. So no, an XY male cannot have a baby.
All right. Thank you.
Other questions, members? Thank you.
Thank you.
Chair calls Jillian Bai. Dr. Jillian Bai. Jillian Bai. Kurt Peters.
This is
Jillian.
Okay.
Chair Click and honorable members of the committee, my name is Dr. Jillian B. I'm a family physician who has practiced in Texas for more than 10 years, caring for children and adults. I am testifying on behalf of myself in support of HB 1686. Medical gender transition should be banned in children for the following reasons. 85% of the children will grow out of gender dysphoria by adulthood. Expensive, irreversible, and lifelong treatments are unnecessary for a largely temporary condition. Furthermore, the medical profession has no standard that predicts whose gender dysphoria is temporary and whose is permanent. When a physician mistakenly transitions children whose gender dysphoria is temporary, the damages such as sterility and sexual dysfunction have lifelong consequences. More than 45,000 detransitioners on the detransition subreddit lament the harms done to them, and the group grows by hundreds to thousands per month. It is unacceptable to take chances on children when diagnostic mistakes are this frequent because the consequences are so catastrophic. Finally, puberty blocker and hormones of the opposite sex used in gender transition are no longer recommended by the European nations that pioneered the practice due to irreversible harms and questionable benefits. Instead, Europe prioritizes psychotherapy as the preferred treatment. This drastic shift in Europe indicates that gender transition is not life-saving. Otherwise, Europe would have promoted it more than ever before. Here are my specific concerns. Puberty blocker used in gender transition stops normal puberty, but normal puberty is not a disease. It is a critical part of human development. For example, boys who never experienced normal puberty and who then took feminizing hormone could never orgasm. Additionally, puberty blocker is not a reversible pause button to allow children to explore their gender because 98% of them progress forward in medical transition. Therefore, puberty blocker pushes children to permanently alter their sexual appearance. Following puberty blocker, children are given hormones of the opposite sex to achieve levels 5 to 10 times above what their biological bodies are designed to handle. Outside of gender transition, these abnormally high hormone levels are only seen in rare types of cancer, meaning the bodies of these children are placed into cancer-like conditions. The consequences include sterility, mood instability, permanent voice changes, sexual dysfunction, and increased risk for cancer, stroke, heart attack, and fatal blood clots. These side effects are unjustified because medical gender transition is unnecessary to begin with, as discussed earlier. In closing, please ban gender transition in children. I invite any questions you have.
Thank you. Any questions, members? All righty. Thank you for your testimony. Chair calls Kurt Peters, followed by Zamina Lopez, and then Ben Wilson. If you'll state your name, who you represent, and your position on the issue.
Good afternoon, Chair Click and distinguished members of this committee. I am Dr. Kurt Peters and have provided subspecialty care for sick children since 1985 and have served as a principal or sub-investigator on 69 clinical research studies. I am here on behalf of myself and advocating for the minor children of Texas as a proponent of HB 1686. The currently allowed self-diagnosis as a criteria for gender dysphoria, GD, has led to an exponential rise in children identifying as the opposite sex and thus being prescribed puberty blockers, cross-sex hormones, and surgical reassignment surgeries. After extensively reviewing the world literature on GD, I plead that Texas enacts laws to protect our children from irreversible damage to their bodies, as excellent data shows that between 80 and up to 95% will accept their biological sex by late adolescence if not exposed to social affirmation and medical intervention. The stated goal of affirmation and intervention is to relieve dysphoria. However, a Hayes directory of 21 studies on hormone therapy showed no improvement in psychological health, substance abuse, suicide attempts, and sexual functional satisfaction. Post-transitioning, including surgery, did not demonstrate improved suicide or mental disease rates long-term, as documented by the longest, which was 30-year study in Sweden. At 10 years post-reassignment, the suicide rate was actually 19 times the general population. Gender identity cannot change a person's sex, and therefore a sex change is biologically impossible. The benefits of medically and surgically affirming a child's misunderstanding of this reality are unproven by long-term prospective studies. However, the risks are significant and irreversible. The treatment of GD in childhood with puberty blockers and cross-sex hormones effectively amounts to experimentation on and the sterilization of youth who are cognitively incapable of providing informed consent. Thank you very much for listening, and there's an outline with 48 references included.
Questions, members? Thank you for your testimony.
Thank you, guys.
Laura Cooper. Laura Cooper. Will Francis. Rachel Gonzalez.
Can you give them time to get over here?
I don't know. Landon Ritchie. You'll state your name, who you represent, and your position on the measure.
Madam Chair and members of the committee, my name is Landon Ritchie, and I'm here on behalf of myself as a Houstonian born and raised, a son and brother, an honors college student, and a proud transgender Texan who, as a minor, was able to access the very care that HB 1686 aims to ban. I am in strong opposition to this bill. Since I could walk, talk, and think for myself, I knew that I was in some way different. I felt most comfortable in masculine clothing, playing with boys' toys, assuming the male role in role-playing games with my dad, and wearing my hair as short as my parents would let me. Anything to the contrary was viscerally uncomfortable and discordant. Even though I had told my dad at 2 years old that I wanted to grow up to be a boy, and had consistently, persistently, and insistently asserted such throughout my childhood, my parents assumed that it was merely a phase, or that I was just a tomboy. But as I got older, these feelings of incongruence between who the world told me I was and who I knew myself to be only grew and became harder to ignore. Especially as I began having to wear gendered school uniforms, and my peers grew into their expected gender roles, whereas I did not. I was around 10 when I began puberty, and this further intensified my dysphoria, although at the time, I didn't have the vocabulary to identify what I'd been feeling as such. Eventually, I discovered the word transgender, and everything finally clicked. For the first time, I saw myself, and I no longer felt alone or like it was an impossibility to exist as who I was. It took me a year of sitting with what it meant for me to be transgender, of fearing the worst possible outcome, of me sharing who I was with my family, and of becoming increasingly depressed and anxious before I gained the courage to tell them. And I only felt empowered enough to do so after meeting another trans person my age. Thankfully, even if my parents, especially my dad, who was raised in the Pentecostal church, didn't fully understand what it meant to be transgender or know what to expect for my future, they were supportive. After I came out, it was still another year before I started going by Landon full time. I began using my name at home and with people in my family, and that I was out to, but at school, I was still a girl. And since it had been years since I'd worn clothes, even remotely feminine, and my hair had been cut short since the end of elementary, the only major change at school was being able to wear a tuxedo instead of a dress for band concerts and competitions. I was fortunate to be able to access a therapist, psychologist, and primary care physician that were equipped to support me and my family, and only after a year of regular, extensive psychological evaluations, therapy sessions, both individual and with my parents, and appointments with my primary care provider, and after eventual extensive conversations with my care team and parents about what it would look like to start hormones if I did, I began taking a very low dose of testosterone that allowed me to go through a male puberty at a similar pace as my peers. I want to emphasize that the decisions I and my family have made regarding my care were and are not in any sense made lightly. And now, standing here before you, I can say with complete certainty that I have no doubt whatsoever that every decision I have made about my care, under the close and careful eye of my medical team, and with the support of my parents, has been the right decision for my health and well-being, has allowed me to envision and actualize a future for myself as myself. I would not be an exaggeration to say that the care I have been able to access saved my life. Without it, I would not be here in front of you tonight.
Your time's expired. Questions?
Can I please finish? I have one paragraph.
Okay.
I implore you to consider the harm that banning this care will cause, not only for the youth who rely on it, but also for the families who will be forced to uproot their lives so they continue to care for the children in the best and only way they know how. We don't need you to understand what it means to be transgender. We just ask that you believe us when we tell you that we know who we are. And if the evidence of the efficacy of care does not resonate with you, look at the trans youth in front of you this evening who you hear from later, and let their existence and mine as a former trans youth and now thriving trans adult be evidence enough. Please vote against this bill. Thank you.
Questions, members? Representative Jones.
Hi, Landon.
Hi, Representative.
Are you one of my constituents?
I am not, but I am a UH Coug.
Oh, well, then you are.
I'm
sorry.
Okay, so I've got,
school, yes.
You said something. So you had access to health care when you were a minor.
That is correct.
Is that accurate?
Yes.
With your parents and with your healthcare providers?
That is correct.
If you don't mind sharing, how old were you?
I was 13 when I started a very low dose of testosterone. And for context, my brother, who is now 13, has had a deepening voice and has been going through puberty since before he was 12 years old. And he is cisgender.
You said something, here's what's funny. Can you explain for people who don't understand what cisgender is? Can you just explain that?
Of course. Cisgender means that you identify with the sex that you were assigned at birth, so your gender identity aligns with sex assigned at birth.
Oh, that means if you think if you were born a boy, you think you're a boy?
Yes.
Okay, that's what I wanted to know. Because I believe in translating so everybody can understand.
Absolutely.
Are you worried that banning health care for people like you would put people's lives at risk?
I do. I sincerely believe that.
Can you explain to me how?
Yes. So we've heard from testimony from medical providers that such revocation of care would put children at risk. Not only, I know that we don't like talking about suicide among this panel, but not only adverse mental health outcomes for youth, but also a delayed and often cut short ability to exist as oneself. So if I had not been able to transition with the support of my family, with the support of my medical providers, I would have continued going to school as female. I would have been withdrawn, exceedingly depressed. My mother notes that when I came out, I didn't stop talking. Before that, I'd become increasingly reserved and within myself because of everything that I was dealing with. And for kids who do not have or will not have access to this care if this bill passes, the future of what is possible for them is no longer on the table, at least in this state. And Dr. Colt talked about earlier how it's important for when children are able, when adolescents are able to access care, to socially transition, to transition in any way that is the recommended standard of care, when they are able to do so, their life does not focus on gender anymore. They are able to exist as kids, as themselves. They are, not having to worry about bullying as much. For myself, when I was considered a tomboy in middle school, I was inundated with questions about why my hair was short, why I had a girl's name, why I was a girl but looked like a boy. And I didn't have an answer for them. When I was able to socially transition, people saw me for who I was. People understood for the most part. The kids know. The kids aren't the problem here. It's the adults that don't understand. And so when I was able to transition for myself, my life was not about being trans anymore. It was about being a band kid. It was about focusing on my studies, not about how, my peers were perceiving me in a very visceral way. And in reality, it's just enabled me to live.
You said something that I thought was pretty profound. You said you being able to transition literally saved my life.
Yes.
What does that mean? Does that mean you would be dead?
I thoroughly believe that without having access to care, I came out when I was 11 years old, and it was 2 years before I was able to access medical care, aside from therapy and psychological care. If I had been forced, as this bill would, to wait to the age of 18, I would not have made it to age 18, at least not in this state, not without this care. It would have put an end to my life because there was no future for myself as the person who I was before I transitioned.
Are you now the person? I mean, you talk about who you were back when you were younger and you knew it. Are you that person now? But you're just like a grown up? Because you keep talking about was. I'm trying to figure out where you are now.
Yes, I am. When I think about how I had understood myself without the vocabulary to define that, I saw myself as a boy, and now as, envisioned a future where I grew up to be a man. And that's where I stand before you today as a young man, and that is who back in when I was 2 years old, I envisioned myself growing up to be and understanding myself to be.
And have you been here during this whole thing since this?
Yeah, I've been here since 6:30.
Oh, okay.
This morning, a.m.
Okay, so what, if any, misinformation about who you are, who you were as a minor who had access to to health care, like, have you heard any misinformation? And if yes, what is that misinformation and what is the truth?
There's a lot of misinformation, as the committee is aware. The biggest one that I think, and not talking about surgeries for a minute, is that trans youth are delusional about who they are, that gender dysphoria is a transient thing, that is, with only psychological therapeutical care, in many instances can be diminished, and kids can live as cisgender children, cisgender people. I knew who I was since, like I said, as early as I knew how to relate to myself and knew how the world perceived me. And so do many of the kids here today, many of the kids that I have met, many of the adults that I have met. And while not everybody's experience is the same, depending on the environment that you grow up in, the era in which you grow up in, that may not look the same for everybody. You may not know when you're a youth, and it may only occur to you later in life that what you had been feeling was gender dysphoria, and that it's because you're transgender. So I think that is a primary misconception that is too often believed at face value. We don't put enough trust in kids to tell us who they are, to know who they are. Like Dr. Colt's talking about earlier, the development of gender and your understanding of gender is between 18 months and 5 years. That aligns with my experience and the experience of so many others. And it should not be discounted in the conversations that we're having that kids don't understand the decisions that they're making. They don't understand the repercussions or the consequences or whatever you want to call it of socially transitioning, pursuing medical care in the future and later adolescence.
And I've got another question. So you've heard testimony about people pressuring people to say, hey, you're transgender, and this is what you can do. Did you receive any pressure saying, hey, you ain't transgender, and don't do it?
Oh, yes. Well, when I'll go back to the story about telling my dad that I wanted to grow up to be a boy. He said, no, you don't. You're a girl. You look at your mom, see how powerful she is. Boys are smelly. Something like that. Something very, understandable for a 2-year-old, but still not quite grasping the complexity of gender identity and people's individual experience with gender that differs from the sex assigned at birth. And I have experienced, like, especially from having come to the Capitol since 2015, the narrative that, you know, I am not trans, I don't know who I am, I mutilated my body, I made the wrong decision, I'll regret the decision that I made earlier. And when I was, starting the process of beginning care for myself, beginning hormones, that doubt was ever present because of what I've been told, because I had worried that maybe I will regret it in the future. Maybe what they're saying is true. What these adults are saying about my 13-year-old self was true. And that was a very challenging time to reconcile with what I knew to be true about myself, what I had experienced personally to be true about myself, what I understood was the path forward for myself, and to have that be debated and discounted time and time again. So it has definitely been my experience to have that outside pressure telling me not that I am trans, not that I should transition now that I've come out, but that I'm not trans, I'm doing harm to myself, and I'm making a mistake.
If the bill that we're here about today, if it were passed when you were younger, where would you be now?
If not dead, then not in Texas. My entire family is here. I'm a third-generation Texan. My dad went to U of H. His dad went to U of H. And we have deep community and family ties here. And so if something like this bill had passed when I was a minor and when I was seeking this care, it would have forced us to uproot our lives. In the event that my parents, as they do, did support me and were committed to supporting me and pursuing this for me, being able to access this care. But if we had not had the resources to leave, if I had not received support from my family, my school, my community, my friends, then I would not see any future for myself.
Thank you.
Thank you.
Other questions, members? Thank you. Chair calls Ben Wilson.
Do you want to say this?
That's what I'm doing. If you'll state your name, who you represent, and your position on the measure, please.
Yes, my name is Ben Wilson. I'm a physician from Waco, an associate chief medical officer of Waco Family Medicine, but I do not represent them. I speak on my own behalf. I am for HB 1686.
Please begin your testimony.
Yeah, I have a written testimony that's being dispersed. I'm largely going to actually deviate from the written testimony because I've been hearing a lot of the arguments and the rhetoric that's come forward and the evidence and such, and just wanted to speak on some of that from a medical doctor's perspective and someone who has some knowledge on how to interpret medical literature, much like Dr. Oliverson. I'm just going to, not necessarily in any certain order, just going to hit some things up point by point. So there was Dr. Zwiener's testimony. She brought up a Harvard study. I think that she's referring to Almasan et al. And it's entitled Association Between Gender-Affirming Surgeries and Mental Health Outcomes. And I think she made the statement that there's a link between some of these surgeries and decreased suicide risk. But just to set the record straight, I think that I am familiar with the study that she was referring to, and it decreases suicidal ideation. But as we've said, I think even ad nauseum here in the study, that there's a big difference between suicidality or suicide ideation and suicide risk itself. And so I just wanted to hopefully correct her statement there and offer some rebuttal. There was a witness that came from the Manhattan Institute who it was, I think, rightly pointed out that he was not a medical doctor or a psychologist, psychiatrist. But I think that Representative Jones meant well, but she discredited his testimony because of that. But I, as a medical doctor, want to say that I'm somewhat familiar with the literature on this topic, and I don't think we have any business, honestly, discrediting witnesses that frankly know more about the evidence than most of the medical doctors. He, as well as another, there was a Master's of Science, similar witness, super knowledgeable on the topic that testified during the Senate hearing that honestly knows more about it than medical doctors do. And I would just point out that a lot of the research scientists are people that train medical doctors. I was trained by a lot of research scientists in my first 2 years of med school, so I would like to be able to think that my training was still valid. To speak on another witness that, I'm sorry I didn't catch the name, but they're from the Mayo Clinic, made the statement about how, well, there are other interventions that we do, such as Tamiflu or vitamin D, that have poor quality evidence, but yet we still allow them to be administered in the medical community. The difference is that there's no measurable harm with those interventions, but there is measurable harm with gender-affirming care. This person also said that I think this person quoted controlled trials, and I'm not privy to those trials. I didn't see what she was quoting necessarily, but I don't believe that they're randomized or blinded, but she said that they're controlled. And so there's a big difference in the quality of evidence.
Your time has expired, Dr. Wilson. Thank you.
Right. Thank you.
Dr. Alderson, do you have
Dr. Wilson. No, thank you, Madam Chair. Dr. Wilson, I know you were kind of right in the middle of the thought there, and I kind of wanted to give you the opportunity to complete the thought. But I did, before you did that, I kind of wanted to go back to,
right.
You said something which I thought was really important, and that is that, we've been doing sort of a lot of sort of comparing of credentials and stuff like that, and, who's qualified and who's not qualified and all that kind of stuff. And it's refreshing, at least for me, to hear another physician get up and sort of say, well, he may not have been a medical doctor, but his conclusions, basically, as he's looking at the quality of the evidence,
right,
and whether this is something as a physician scientist that I should be implementing in my practice, I would say that very low and low quality studies are really not something that I should be doing in my practice, that this is kind of junk science. I don't know if you would agree with that statement.
Well, yes, absolutely. If there's measurable harm to the intervention, then we definitely should not include them in our medical practice. For example, if chemotherapy, is one that we refer to a lot. If there's low quality of evidence saying that chemotherapy is a benefit, well, we know there's substantial harm, so why in the world would we incorporate it in our practice?
And you would agree with me, I guess I might have gotten a little testy with one of the witnesses, but I was a little concerned that we were trying to equate studies on whether or not statins are provable in terms of their ability to lower the risk of heart attack and things like that. It was sort of a statement that was made that was observational as well. You would agree with me that there are certain things that we do in medicine that are far beyond observational. Gender medicine is not one of them, but when we're talking about aspirin after heart attacks or beta blockers or,
Right. No, in terms of the quality of the evidence, things like statins or aspirin for people who've had a heart attack, that's the bedrock when it comes to quality of evidence. If we can't say that's true, we can't say anything's true, and that stands in absolute contrast to the quality of evidence here in the gender-affirming medicine camp.
Well, I just want to say I appreciate you being here today, and I know you had to wait a long time to testify, as do a lot of other people, so I don't want to take any more time because I know there's a lot of other folks that'd like to have a chance to say something, but as I said, it's refreshing to meet another physician that is sort of looking at the literature and reaching the same conclusions that I am. I think there's a lot of us out there.
Great.
Thank you.
Okay, thank you.
Representative Tinderholt.
Thank you, Madam Chair. Sir, thank you for being here tonight,
Yes.
all day, all night. You've been here all day?
Since 7:30, yeah.
Man, you guys are, everyone that's here, amazing. Spent the whole day here, so thank you to everybody. Do you see therapy as a really good alternative to any of the the puberty blockers or hormone therapy? Do you see the mental health therapy
right
as being better or a good option?
Right. I want to be very careful as to what I say that I know. This is not an area that I would claim to be an expert in. Okay. What I do believe that I've seen, though, is pejorative terms like conversion therapy. We could call it change allowing therapy instead, where we have the option for someone to choose one way or the other, truly. And I'm afraid that if we don't allow change allowing therapy, where they can really go either way, that we put minors in particular on a conveyor belt sort of thing. And I think you see that. There's one study that, it's been brought up a lot tonight that puberty blockers are reversible, and so why don't we just do those for a certain amount of time? I believe the witness from Mayo Clinic, I think at one point said, well, maybe we could agree on no sterility prior to the age of 18. And so I think the implication there was, what if we just do puberty blockers until then, and then after age 18 we do cross-sex hormones? But the problem is that there's really just sort of a conveyor belt phenomenon here, where once you start down that road, then it's hard to get off of that road. And so having a change allowing therapy option, or what's pejoratively termed conversion therapy, I think is a good option, because it gives people the option, but it's not my area of expertise.
What's interesting is I was going to ask you something similar. The next question was going to be, do you think that a therapist trying to psychologically transition these children is healthy? Instead of just trying to help them through the process, do you think it's healthy for a psychologist or psychiatrist to try to walk them through the actual transition and going to potentially get these puberty blockers?
You mean just sort of as a social transition without the medications? Correct. Is that what you're saying? Again, not my area of expertise necessarily, but what I have seen, though, from the literature is again, this conveyor belt sort of deal, where if you start taking steps, then other steps tend to follow. And I will say that socially, you can sort of rob someone of social transition. You can, like I said, put somebody on that path. It changes their peer group and that sort of thing, and makes it more difficult for them to come back. And so I'm not personally a fan of it, but it's not my area of expertise.
Okay. So I think in here I was reading, what percentage of it? 85% of children grow out of gender dysphoria by adulthood. So I have to ask this question that I think you'll have the answer to. Is it true that once a child is on Lupron, which is a puberty blocker, and then testosterone for a period of a few months or more, are they irreversibly sterile, or can they be?
It is my understanding that once they are on cross-sex hormones, that and I don't know the magic amount of time frame. I don't know that anybody actually knows that. But yes, they are irreversibly sterile with the cross-sex hormones. If I could just say one thing that about the 85% statistic, it's not contentious at all that the majority of children, minors, desist if we allow them to. And so the doc from Mayo Clinic made the statement, 18 months to 4 years, I believe, is the time when the brain develops gender identity. Well, even according to the DSM-5, which is the American Psychiatric Association, hardly a bastion of conservative medical thought, right? They even say in their own document the majority of minors will desist. And so it wasn't 85%, but they're included in that, the vast majority desist.
So there's a reason I've asked this question 20 times tonight. What's a woman?
Woman is a person with excess chromosomes and the anatomy to accompany it.
Can a man have a baby?
No, a man cannot have a baby.
Thank you for testifying today, sir. I appreciate you.
Thank you, Representative Smith.
Well, thank you, Ms. Campos. Appreciate
You're
welcome. Doctor, where is the medical board on some of these issues? That's kind of a broad question, but you've talked about about measurable harm. Okay, for sure, there's been grievances or complaints, I'm sure, filed by the public in Texas to the medical board on doctors who have pursued these procedures with minors. Are you seeing any opinions or any rulings or any decisions being handed down by the medical board dealing with this issue?
I have no knowledge of that. What I can say, if it's helpful, is that my opinion of why the Texas Medical Association has a neutral on the bill approach to this is because they're worried about infringing upon the physician-patient relationship. But I firmly believe, and by the way, I was not polled by the Texas Medical Association, even though I'm a member. They didn't ask me what I thought about this, so their polls did not include me. But I personally think that the Hippocratic Oath really should be the overriding principle here, and it should override physician-patient relationship concerns.
Right. Do no harm.
Right.
Right. And so
right,
there's
exactly.
measurable harm in this. And so that's
Right.
why what I'm hearing from you, though, is that the medical board is just not taking up the issue, even though there's measurable harm to individuals in violation of the oath. Is that fair to say?
I just don't have knowledge on that, Representative. I'm sorry. As to what the medical board is doing, I'm sorry.
But you go to-
but I don't think that they are, but I don't have a lot of knowledge on it.
Right. You go to continuing medical seminars and that sort of thing, right? Do you ever
Yes.
hear any information given, any speakers who come in and say, hey, whoa, don't do this procedure, otherwise there will be a problem with the board? You ever hear anything like that?
No, I've never heard that.
Okay. You ever hear any of your friends talk about things like that, who are doctors?
No, but there are not a lot of doctors that practice this sort of medicine, and so just the statistical probability that I or any other doctor would come into contact with a doctor who practices this sort of medicine is actually fairly low.
Well, I understand. There's not been anybody, I'm in the same boat you are. There's not been anyone come in here from the medical board today and say, hey, if you go this far with this, or in this particular situation, then there will be a problem.
Right.
I've not heard one person in here. If they come in, I'm really excited to hear from them. If you're here, let me know. But I've not heard that yet. There's no parameters on this.
Right.
Is that what you got?
That seems accurate, but yeah, that seems accurate.
All right, so let's talk about the measurable harm again. Can you think of another area of the medicine or another medical procedure with this level of measurable harm that the board allows to continue?
No, I cannot.
You can't think of another procedure that maybe is in its infancy, that almost experimental, but there is measurable harm where the board says, whoa, you can keep doing that?
No, I can't think of any. I mean, there's experimental cancer drugs, but even then they have great promise for benefit. Yeah.
Do you think that the political has crept into the medicine? Do you think that the politics has crept into the medicine and caused there to be reticence among the governing body of the medical profession in Texas from doing anything that is clearly causing harm?
It is my opinion that yes, it has.
Okay.
I mean, I think we're seeing that with Europe having sort of turned a corner on their approach to this. I think that America is just yet to catch up.
Thank you.
Representative Johnson?
Would you also agree that political has also invaded your hospital rooms?
Political, can you give me an example? Or
Would you like for me to come practice medicine with you tomorrow? Or would you like the ability to practice medicine as you see fit and care under your Hippocratic Oath?
Generally, no.
Okay. Also, I know he said I haven't heard from all these folks, and I just want to make sure he's aware. There are 470 people that registered to testify, and we've only gotten through 19. We have 451 more people that want to testify on this bill before we can get out here at midnight. And there are 92 for this bill, and there are 2,702 people against it. So I hope that he gets his opinion.
Excuse me. Do I turn it down? Any other questions? Thank you for your testimony.
Thank you.
Laura Cooper. If you'll state your name, who you represent, your position on the measure.
Sure. I'm Dr. Laura Cooper. I am opposed to the legislation, and I'm representing myself. So I'm Dr. Laura Cooper. I'm a board-certified child and adolescent psychologist who has been providing mental health services almost exclusively to transgender youth and their families in Texas for the past 8 years. I'm here today to share my professional expertise and speak in opposition to the bill. I work as a part of a multidisciplinary team that provides puberty suppression and hormone therapy to transgender youth, and I have personally provided assessments to youth who are seeking access to this treatment. I also oversee one of the largest and longest running longitudinal studies of transgender youth receiving hormone therapy in the United States, so we have that ongoing, and we have enrolled nearly 700 youth from our clinic. The oldest cohort of patients is now entering their 9th year of treatment. Results from our longitudinal study have confirmed what we see when we meet with our patients every day, that this treatment is safe, effective, and life-saving. Within our study, youth report large and sustained improvements in gender dysphoria, as well as broad improvements in depression, anxiety, and quality of life. We also have closely tracked the experiences of youth who stop treatment, and this data is consistent with numerous other studies showing that the experiences of regretting treatment are extremely rare. Contrary to the misperception that there has been an explosion of youth presenting for care, as the only program in our region, which is a quite large region, and we are known to be the largest provider, our yearly rate of new patients is 0.006% of the total population of minors in our region. When youth present for care, we follow an individualized and collaborative approach consistent with established best practice guidelines. There is a robust assessment process and informed consent process to ensure that both youth and their families parents fully understand treatment options and feel comfortable and confident about moving forward. We never assume what treatment, if any, is needed without first spending the time to get to know each individual youth and their family. We also inform youth that they can decide to stop or pause treatment at any point, and we will fully support them through that process. I can say with confidence that cutting off access to this vital care will be devastating for the hundreds of youth in our program. The distress, hopelessness, and panic youth and families are already expressing at this prospect is heartbreaking to witness. I'd like to end with quotes from 2 of our patients. I'm very thankful and lucky for this program. Y'all gave me the chance to live the rest of my life. This program changed my life, and I'm always going to be grateful for everyone involved in helping me transition. I wouldn't be here without you.
Your time's expired. Members, you have any questions for the witness? Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here. Would it be how do you say your last name? Cooper?
Cooper.
Cooper, Dr. Cooper?
Yes.
Thank you for being here. If this bill passes, will you still do what you do and try to push people across state lines to get this care?
Well, I'm a mental health provider, so I will support them in the best way possible, but I also have to follow the law.
Well, if it's not put in this bill, it would not be against the law. So I'm asking, would you still do what you do and push them across state lines to get the care that you think that they need?
I would say that I have to act in accordance with my ethical guidelines from the American Psychological Association, so I would provide the same guidance and recommendations that I would otherwise.
So is the answer yes or no?
What the answer to which piece?
Whether you would still do what you do and then try to push them out of state to get the care that you think that they need, yes or no?
If it was illegal for me to do that, then I would not break the law, but otherwise I would follow the best practice guidelines and the ethics of my organizations.
So if this bill passes the way it is, it would not be illegal for you to do it. So would you push people across state lines to get the care? I think I'm looking for a yes or no.
Well, I'm concerned about this idea of pushing. I never push families in any
would you refer
direction.
and try to assist them in going across state lines to get the assistance that you think that they need?
I would provide the same types of referrals as I do now.
Okay, so the answer is yes.
I'm not pushing anyone, but yes, I'm following standards of care.
Okay, thank you, ma'am. Have a good night.
Other question, Representative Jones?
I didn't hear you use your own words and say push anybody across state lines. Is that accurate?
Yes, no, I talk to parents directly. I say, I never want you to feel pushed or pressured in any way. I'm here to support you through this process, and you're kind of at the center of that process along with your youth.
And so when you are consulting, counseling, I don't know what you call it, with your clients, or I'm sorry, with your patients and their parents, am I right to presume that you guys talk about everything and all the different alternatives that are out there for whatever their healthcare needs are?
Sure. So it's a multi-step process that's spread out over a number of months. When the vast majority of young people get to us, they've already been working with a therapist, and they see us for a minimum of 3 visits, which typically is about 7 to 8 hours at minimum.
And so would it be accurate to say you ain't pushing them nowhere?
No.
Like you come to some medical conclusion or whatever, or I should say the parents, I guess, and their children come to something after they tell you what all their issues are, and you refer them where the standards of care suggest that you might.
Sure.
Right.
Yes, the standards of care do state collaboration is key to the practice. Yes, and I am concerned with folks that are sharing that they felt pushed or pressured into this treatment, because that is absolutely not consistent with standards of care.
Thank you. I appreciate that.
Sure.
Thank you for coming.
Representative Tinderholt?
Thank you, Madam Chair. Let me rephrase it. If this bill passes the way it is, it would not be illegal for you to do so. Would you consult and work with the family and the individual and refer them out of state for the care that you think they need?
Yes.
Thank you.
Other questions, members? Thank you. Chair calls Rachel Gonzalez. Next on deck will be Abel Garcia and Will Francis. I show your name is Rachel Gonzalez, and you're representing yourself. Is that correct?
It is correct.
And you're against the bill.
I am in opposition. Thank you. Thank you, Chairwoman Click, members. I am the mother of 3, and you heard from my husband, Frank, earlier. Many of you have seen my children up here testifying before, and we would really love to not be involved in politics. I am so tired. I am trying hard to balance all the things that a mom like me is balancing. School, sports, extracurriculars, my work, trying to make sure that my kids get a healthy dinner on the table every night. And my daughter Libby asked me a few weeks ago, why do so many people hate me that don't even know me? I wanted to point that out because, as you heard from my husband, we have a lot of support around us, and our family didn't lose our friends or our family that personally knew Libby before she changed her name. That's not to say that it was easy. There was a lot of long conversations and research and patience that was required through the process, but we were not alone through this process with her. One day I was stopped in the school parking lot by another parent in tears who wanted to let me know that if she hadn't known my daughter and watched our family over the years, she would have been on the other side of this. Today, Libby has the same best friends that she's had in school and a ton of new friends that she's made since preschool. She's surrounded by people who love her. Her teachers, neighbors, school administrators, classmates, a ton of friends and family. And she knows how fortunate she is. She knows that not all kids have the love and support that she has, which is why she's continued to show up at the Capitol until today. Today, she decided to spend her Monday where she prefers, at school. She loves school. When we parted ways, she told me she was so nervous about what might happen here today. She's really scared about what this bill might mean for her and our family. Every night during dinner, my family takes turns sharing our gratitudes. It's my favorite moment of the day, especially because some days I don't really want to share, but it pushes me back into being grateful for the many blessings we have in our life. Among the most common gratitudes shared by all 3 of my kids are their teachers and classmates, reminding me how many amazing people we have in our lives. And I cannot fathom uprooting our entire life because legislators insisted they know my child better than me. If you pass this bill, we will be forced out of our home, which is something that is not possible for many families. I would hope that every member in this body believes that every child deserves love and support and safety from their family. This bill would make it impossible, and I'm begging you, as a mother, please stop hurting us and my children. Let my husband and I give our children the childhood they deserve. Thank you.
Questions, members? Thank you. Abel Garcia, followed by Will Francis and Prisha Mosley. Mr. Garcia, I show that you're representing yourself and you're for the bill. Is that correct?
Yes, ma'am.
You can begin.
My name is Abel Garcia, and I am a detransitioner. I grew up in a traditional Hispanic family. My parents arrived to the U.S. illegally from Mexico. Being a non-traditional male in my family was hard. I started my transition in 2016, and on my first appointment with a therapist, I was affirmed as a trans woman and immediately offered a letter to receive hormone therapy. My therapist explained she did not want to gatekeep my care. In 2018, I had breast implant surgery, and several months later, I regretted my decision, and it began to settle in. Between 2018 and 2019, I had multiple therapists deflect my attempts to talk about detransition. Although HB 1686 covers minors, and I started medical transition at the age of 19, it was when I was a minor that I first began researching the possibility of transition. Minors need better safeguarding protections against irreversible medical decisions on their behalf. I was misled to believe that these procedures were perfectly safe, but now I am 26 years old, and I'm dealing with genital atrophy, urinary difficulties, possible sterilizations, tremor on half of my body, back pain, memory loss, loss of my eyesight, and many more issues that may develop as I age. The current affirmation model validates a patient's transgender identity while discouraging therapists from exploring underlying mental health issues. The medical care that is offered can lead to castrations of males and females through invasive surgeries or sterilizations through puberty blockers and cross-sex hormones. The puberty blockers themselves are not tested nor approved for use in medical transition. Instead, they are used off-label. My story is not an outlier or that of a failed transition, but the realization of the truth of this practice. If you look online, you will see many stories like mine, those currently of young men and young women who were lied to and damaged as minors. Since my detransition, I have ended my relationship with my parents, and I've tried to move on with my life. One day, I would like to be a role model to my own son and give him everything that I've missed from my own childhood. Unfortunately, due to being on hormones for 3 years, my ability to have my own children may be permanently lost. When I was 19, transition became the main thing I cared about, and everything else became a blur. I would have not wanted my own children. I was too young to know what I wanted as an adult. I hope, like many of you, I would be able to raise my own family one day. Because of my experience with so-called gender affirmation care, I no longer have faith in doctors or trust the medical care system. I hope you take my testimony to heart and protect the children from this misapplication of medicine.
Members, do you have a question? Representative Smith?
Thank you, Mr. Garcia, for being here. Appreciate your courage, sharing your very intimate story. How old are you?
26.
26. All right, thank you.
Other questions, members? Representative Collier?
Mr. Garcia, thank you so much for being here. I appreciate you sharing your personal story. I just heard you tell Representative Smith you're 26 years old. You live in Dallas.
Yes, ma'am.
When did you move to Texas?
I just moved here last year.
Last year? When? I mean...
May of last year.
May of last year. Okay, so you shared a little bit of insight into your transitioning and then transitioning story, but I want to ask about why did you your transition? Why did you transition in the first place?
I was a very shy, quiet, timid young man growing up. I did not feel adequate enough in my culture, which is very masculine as a Mexican. And because of the stereotypes of men and young boys, I did not feel I could step up to those standards. And for some reason, my mind assumed that if I can't be a man, I should have been a woman.
And so when did you start to detransition?
Medically, I stopped detransition in April of 2019. Socially, I detransitioned in December of 2020.
Okay, so 2019, you did it how?
I stopped taking all my medication cold turkey, which is not medically recommended.
Oh, okay. And then you started going socially, detransitioning a year later?
Yes, ma'am. That was because I had surgery to remove the implants, and I was able to live my life as a man.
Okay. And so is there anything, well, you're 26 now, and then when you first started to transition, were you an adult?
Yes, I was an adult when I transitioned.
Okay. So you weren't under the age of 18?
No, ma'am.
Now, your family, did you talk about your family and how they responded to your transitioning?
My mother was not fond of the idea of me transitioning, cried and asked many questions. And due to that, I did not tell my father. My mother informed my father. And unfortunately, due to my culture, my father thought the perfect idea was to take me to Mexico with a $100 bill and go with a prostitute and have sexual relationship with a prostitute. As prior to that incident, I had never had sexual relationships with anyone. That I later learned was the trauma that wanted me to transition, because prior to that, it was only an idea. I didn't want to transition. I thought of it, but after that incident, I did not want to be in my body anymore, as I had been dealt with trauma and I wanted to escape it.
That's very sad. I'm so sorry you had to go through that. That's very unfortunate. Did you get help, any type of psychological or emotional help following that?
I have never received any proper help for that. I've just moved on with my life and rebuilt my relationship with my father. My father has realized that it was a major mistake on his end, especially after being scolded by his half of the family.
Did that incident contribute to your decision to detransition, or did it have any impact on that?
No.
No? What about the way people perceived you? Did that have any impact on your decision?
I lived in the state of California, a very liberal and very progressive state, and I was affirmed in my gender identity as a transgender woman. So I had nothing but support and affirmation. It was not until after I was kicked out of the community by asking a few questions that I was removed.
Kicked out of what community?
The transgender community.
In California?
Yes, ma'am.
Oh, okay. Well, that's unfortunate as well. So I also want to ask about what type of transitioning treatment did you have?
I took estrogen and spironolactone, which were the medications prescribed to me. I had breast implants. I was approved for bottom surgery, even though I had never requested it. That was immediately given to me by a doctor less than 1 year after I started medical transition.
Okay, now you've never been to a therapist for any treatment?
I have been to multiple therapists. The therapist who affirmed me immediately as a trans woman, when I went back to her, went to detransition, she said I had childhood traumas that we had not discussed, and I had just recovered surgery, which were the reasons of my wanting to detransition. We never discussed anything else. She never explained on what she meant. A second therapist, my medical records state that he said that I should not be too cavalier with my gender identity regarding detransition, because I do not know the harmful effects that could be done to me by detransitioning. He was not supportive of my detransition either. Finally, a third therapist that I had received under California law, he is a criminal because he did what is considered conversion therapy. But all we did was just talk about my feelings, why I wanted to transition, why I wanted to detransition. And unfortunately, under California law, that is conversion therapy, since I detransitioned in the end.
So none of the transitioning or detransitioning treatment that you received or healthcare was in Texas?
No, ma'am.
So everything was out of the state of Texas?
Yes, ma'am.
So you haven't had any experiences with the healthcare professionals here that have attributed to your cause?
That is correct. I have I guess I could just say my detransition has been here in Texas. And unfortunately, my health has been failing since I've done everything. And I've been honestly too scared to go to a doctor, even though I know I need to go see one.
Yes, you definitely should. Definitely. Well, thank you for being here.
Representative Alverson.
Thank you, Madam Chair. Abel, it's great to have you here, and I appreciate your testimony, and I'm sorry for the experience that you've had at the hands of my colleagues as other doctors. I feel like you were mistreated. And I don't say that lightly. I really do feel like malpractice was committed against you. So I want to talk about this timeline. I understand that this is in California and this is not Texas, but you presented to a therapist, and this was after the experience that your father traumatized you with, or before?
That was before. So I had told my mother in December of 2015 that I was thinking about transitioning.
Yeah.
It was about within the first 3 months of 2016, it's when I went to see the therapist.
Okay.
And it was May of 2016 that my father took me to Mexico.
Okay, and so then how long after, so you started seeing the therapist in early 2016.
Mm-hmm.
How long after that were you referred to the doctor? Did you go see an endocrinologist that gave you medicines, or was it the
I don't think I've ever seen an endocrinologist. The therapist that I had was she was working at my local LGBT center, and she was also the head of the transgender support group. So she mostly dealt with transgender patients.
Was she a doctor?
I do not recall. It's been many years since I've heard of her, and personally, I really could care less. I don't really want to do much regarding her.
Totally get that. Totally get that. Do you remember how long it was after you started the medication that you got a note that you were approved for top and bottom surgery?
So I started medicalization November 2016. October of 2017 is when I went to see another medical professional for surgery, or to be approved for surgery. I had only requested top surgery. A man like myself, that would have been breast implants. I'd never requested bottom surgery, but that was also approved without my request, I guess.
When you went for the surgical consultation, did the doctor ask for, like how long have you what is your history, and or ask a lot of questions, or did they go through a rigorous consent process with you where they sort of talked about the risks and benefits of some of these operations, or the permanent nature of some of them?
Unfortunately, it's been many years, and due to all these drugs that I've taken, my memory has faded drastically, so I don't recall completely. I know we didn't really talk much about, if any, we didn't talk about the complications. We did, I know, obviously, we had to talk about the size of the implants that were going to be inserted, and that's me trying to put it lightly.
Yeah. I mean, I guess what I feel like, and maybe I'm wrong, but I feel like this happened very rapidly for you, from the time that you saw a therapist for the first time to the time when you were basically meeting with a surgeon to have breast implants. If I calculated correctly, seemed like it was less than 3 years.
That is accurate.
That is like scary fast.
Yes. I recently just told a friend of mine who supported my complete transition from the beginning, and after explaining to her everything and as what I do now, even she admitted everything was done very rapidly and quickly. And this is coming from someone, again, from California who is politically liberal and a lesbian. So that even caught her off guard after having a heart-to-heart conversation.
Last question, I just was curious. So this obviously didn't work out the way that, at least at one point in your mind, you thought it was going to. So you said you're 26 right now.
Yes.
So if you could go back in time and counsel yourself, say past self, I wish you knew what I knew now, what would you tell yourself?
I would tell myself that, one, I'm not a woman. I would never become a woman. All I would have been is a caricature of what I believe a woman was. and that it is okay for me to be a man, even if I'm not the most stereotypical masculine man that is presented in my culture.
Okay, awesome. Abel, I just appreciate you being here today. Thanks for your courage and telling your story.
Thank you very much for having me.
Other questions, members? Thank you.
Thank you.
Chair calls Prisha Bosley, followed by Michaela Bradford, and then Jeanette Cooper. Prisha Mosley. Prisha, I show that you're representing yourself and you're for the bill. Is that correct?
Yes, ma'am.
Okay, you can begin your testimony.
My name is Prisha Mosley. By the time I was 12 years old, I was battling with anorexia, depression, OCD, and anxiety, which would evolve into an eventual borderline personality disorder diagnosis, a very severe condition. At 15, the trans community found me suicidal and unstable, and convinced me that all of my suffering was caused by being born in the wrong body. This includes a rape in the previous year at just 14 years old, which I believed only happened to girls. It did not feel safe to me to be a girl, and even less safe to become a woman. I believed that something was deeply wrong with me, and my doctors agreed. They assisted me in mutilating myself, even eventually removing body parts. By the time I was 17 years old, testosterone was being injected into my anorexic body. This was after a single appointment with a WPATH certified therapist who asked me a few questions and told me that I was a boy. These vague questions included things like, do you dislike your period? Do you get along better with boys? 1 year after the testosterone injections began, my healthy breasts were removed. I now experience phantom breast syndrome, but my breasts are gone. All I have now is my scarred, numb chest. At the same time that I was given top surgery, I was denied liposuction. My doctors knew that I was too unwell to consent to radical surgery, but they cut my breasts off anyway. I realized recently that they have been incinerated. My testosterone came from a pediatrician, where I was also seeing a nutritionist for my severe eating disorder and receiving stitches for cutting. There were no safeguards in place, no one to question me and ask why I wanted to look different so badly, so quickly. Instead, I was told that anyone who did not affirm me wanted me dead, and my belief that I was born in the wrong body was affirmed. My parents were blackmailed into the idea that I would kill myself if they did not go along with hormones and the surgery. My previous suicide attempt was used as proof that I was not being affirmed fast enough, so medicalization came quickly. Testosterone had severe side effects, more of which are coming up every day and which I was not warned about. This includes chronic pain in the form of aching joints and burning in my neck, back, and shoulders. My shoulders broadened beyond what my frame was meant to carry, and my hips are too small to hold me up without causing this pain. I suffered with ovarian cysts for years. When my cyst burst, I would go to the hospital.
Still got time.
Oh,
You've got 30 seconds.
Oh, and they would tell me it was normal, give me morphine, and send me home. Now I do not know if I'm fertile. I do know that I will never be able to breastfeed, however. Even with a breast reconstruction, this will not be possible. I will go my whole life without experiencing feeding a baby. I trusted my doctors when they said it was transition or suicide. I thought that this was life-saving medicine, but I was sold snake oil, and the price was my healthy body, my voice, and my joy.
Representative Alverson, do you have questions?
I do, actually. Prisha, thank you for being here today. This started a lot younger for you than it did for our previous witnesses. How young were you when you started this pathway?
I began my social transition at 15 years old.
And when did you start medications?
17. I had not completed puberty, however, due to the eating disorder. I didn't even have a period.
Of course, and you obviously you've expressed that you had multiple sort of comorbid mental health issues going on while this was going on, and yet this was sort of given to you as a cure for all of that, or at least an explanation as for why you were anorexic, why you were suicidal, why you had self-harming behaviors, that this was all because you were just trans and you didn't know it. Is that?
That's what my letter of recommendation says from my therapist who was treating me for all of those problems.
Where was this? Was this here in Texas or
No, I was actually in North Carolina, right in the middle of the Bible Belt.
in North Carolina? Okay, all right, okay. So I know that's a question that we've kind of been asking as a group, is sort of like, where is this happening? So I wanted to see. My goodness, my heart goes out to you. I can't imagine there's a person in this room that doesn't have empathy for you, and we wish you the best. I want to say the same thing to you I said to Abel. I am sorry that my colleagues completely failed you. You deserve better than what you got. And my sincere prayer for you is that there will be compassionate physicians that will help you pick up some pieces and live the best life that you can now. And I'm going to be praying for you.
Thank you. Unfortunately, no doctor will touch me. The nicest thing I've been told since detransitioning is, I don't want to treat you like a guinea pig. I don't know what's going to happen.
Well, you deserve health care, same as everybody else.
Thank you.
Thank you.
Other questions, members? Thank you for sharing your story.
Thank you.
Michaela Bradford, Jeanette Cooper, and Shelley Skeen. Michaela Bradford, Jeanette Cooper, Shelley Skeen. Okay, next on deck will be Luca Morris.
Oh, I'm Jeanette Cooper, but I was waiting.
Okay.
I'm Shelby Chestnut.
I don't think we called you yet.
Good evening.
Please state your name.
My name is Jeanette Cooper.
Okay.
I'm here in favor of the bill, House Bill 1686.
If you'll, who you represent and your position on the issue.
I'm in favor of the bill. I represent Partners for Ethical Care. If I'm asked about my own story, I would be representing myself.
Already, please begin.
My name is Jeanette Cooper. I'm here to state my support of House Bill
Can you hold on
1686.
for just a second? I'm sorry.
It says she's representing Partners for Ethical Care is who she's representing.
And you're representing Partners for Ethical
I'm representing
Care.
Partners for Ethical Care. If you ask me a question about myself, I will speak about myself, representing my story.
For herself too, in which case
Are you testifying for yourself also?
If you ask me a question, otherwise, no.
Okay. Okay.
Parents are asked, would you rather have a living son or a dead daughter? It is the greatest fear of every parent to outlive her own child. It makes sense for a parent to choose a physically harmful intervention when they are faced with that choice from unethical and misinformed healthcare providers. It makes sense for a mother to choose a sterile, desexed child over a dead child. It makes sense for a parent to consent to the removal of healthy breasts rather than the removal of her daughter's body from the morgue. It makes sense when a parent is surrounded by people repeating the mantra of life-saving care. The fear is immense and nearly unbearable. But this is the suicide myth, which assumes only two options, transition or suicide. It's a false dichotomy, and there are always more than two options. Gender dysphoria is a psychological problem that deserves ethical psychological care. It is impossible to be born in the wrong body. The mind is part of the body, not separate from it. I help run an online group of thousands of parents. I am probably the person in this room who has talked to more parents than anyone on this issue. We are a group of parents who do not affirm our child's transgender identity. Rather, we support our children's social, emotional, and physical needs as human beings. We let our kids wear what they want, cut their hair however they please. We accept and love our children as lesbian or gay. We are liberal like me and conservative. We are atheist like me and religious. We are former Democrats like me and former Republicans. I am not aware of any children of parents in our group who have committed suicide because they were not affirmed. I am aware of parents, and have talked to them personally, whose children have committed suicide after transition. I am here to talk about the 4 things that you need for a completed suicide. Jack Clott, a suicidologist in 2012, talked about these 4 things. You need 4 things: hopelessness, aloneness, self-hatred, and the inability to cope. If you have one of them, you are still alive. There's no injection, not wrong sex hormones or anything else that can be given to prevent suicide. Suicide prevention is about social and psychological supports, not surgeries. It is about changing your mind. Gender medicine is the latest miracle drug sold to desperate parents and young people. I wish it was a miracle cure, but it isn't. I feel for the parents and young people who have been emotionally coerced into believing this lie. It's not true. No one needs gender medicine, and no one must kill themselves if they don't get it. We want to tell young people and their parents, you can and will survive the psychological and emotional pain that you feel at this moment. You and your children deserve ethical care, and we are deeply sorry that you're not getting it from the professionals that you should be able to trust. We trust that the state will vote to protect the children of Texas from this multi-billion-dollar unethical gender industry. This small group of unethical practitioners peddling gender medicine should not taint the reputations of the thousands of ethical mental and medical health care providers in Texas.
Thank you. Questions, members? Representative Tinderholt.
Thank you, ma'am. Did you have anything additional that you'd like to share with us?
I'd like to answer the question that you're asking everyone else.
What is a woman?
No.
Can a man have a baby?
No. I want to know whether you think that I think this is child abuse.
Do you think this is child abuse?
So you have some sort of process to investigate abuse. You have some sort of criteria and mandated reporters. I assume that you do, like you do in every other state. So what happens when somebody, like I have maybe 20 or 25 parents that I know personally in Texas in my group, and I'm sure there are many others, but some of them have had Child Protective Services called on them by their own pediatricians. And they come to their home and they open an investigation. So at that moment, they kind of investigate what's going on. If there's an actual threat of some sort of physical violence or they're lacking food, something that is immediate, of course, they will remove their children at that moment. But most of the time, there's some sort of investigation. And to be honest, every single parent, probably I'd say about 45 of them, who have had Child Protective Services called on them, all of their cases have been dismissed. So in the case that it isn't dismissed for, let's say, people who are affirming their children, what happens is they're given kind of a list of criteria, is my understanding, of things that they have to do in order to provide real care for their children and to not be under this idea of abuse or neglect. And if they comply with those things, maybe they say something like, a doctor told me that this is the right thing to do for my child, and so I'm following her advice. And maybe they say, you shouldn't be following that advice. That's wrong. That's harming your child. And then the parent has an option at that time. They can choose to continue with that kind of treatment for their child that is harming that child. And then, of course, that investigation continues and they could possibly lose their children. But if they go along and they can say, okay, I'm complying with the things that the Child Protective Services has listed out and I'm doing those things, then their children stay in their home. And that's my understanding. So there is an entire process for that. So I wanted to address that particular thing about abuse because the idea that somehow people come and rip your children away is not true. It doesn't happen that way. Only middle and upper class white people think that because they've never had Child Protective Services come to their home.
Thank you for being here.
Of course.
Other questions, members? Thank you. Chair calls Shelley Skeen, followed by Michaela Bradford. Ms. Skeen, I show that you represent Lambda Legal and yourself. Is that correct?
Yes, ma'am, I do.
And you're against the bill?
Yes, ma'am, I am.
All right, you may begin.
My name is Shelley Skeen. I use she, her pronouns, and I am a senior attorney with Lambda Legal Education and Defense Fund, Inc. Lambda Legal is celebrating its 50th anniversary this year. We are the oldest and largest national civil rights organization working for full and lived equality for LGBTQ people and people living with HIV. We do that through impact litigation, public policy work, and education, and we do it regardless of economic status. I urge this committee to vote no on HB 1686 for 3 reasons. First, the Due Process Clause provides parents with broad discretion over the care, custody, and control of their children, including a parent's right to make medical decisions for their children. That right is at its apex when the parent's right, the young person's right to consent, and the doctor's recommendation are in alignment. This bill would undermine all three of those decision makers, and the parental right is the oldest of the fundamental liberty rights. The Supreme Court of the United States has said that time and time again. Second, this bill violates the Equal Protection Clause guarantees of the U.S. Constitution because it prohibits age-appropriate, best practice, scientifically proven, life-saving medical care only for transgender adolescents. Non-transgender adolescents can receive the exact same medical care that is being prohibited here for other conditions. The purpose and effect of this law is to exclude transgender youth from receiving this medically necessary care that every major medical association agrees is necessary for gender dysphoria. Third, this bill will have devastating unintended consequences on Texas families, healthcare providers, and Texas as a whole. This bill will have a chilling effect on the healthcare providers and physicians when Texas already suffers from a shortage of physicians and mental health professionals. We saw this after the governor's directive in February of last year, when Texas Children's Hospital in Houston stopped providing care for transgender youth. This bill will also cause Texas to lose important talent. Adam Briggle, a plaintiff in our PFLAG versus Abbott case, who is a tenured professor and head of the department at the University of North Texas, said he and his family will move if Texas prohibits the health care that doctors have recommended. I urge you to listen to the science, listen to the families, listen to the healthcare providers, and send a message that Texas wants all Texas residents to thrive. And you all have heard time and time again from the families here today that they will leave our state if this bill passes. Nothing further.
Questions, members?
If I may.
Representative Johnson?
Have you gotten a chance to listen throughout the day?
A lot of it, yes, okay. Not all of it. I was actually working.
I'm struck by solving the problem of underage Texas youth versus the detransitioners who none of them to date have been treated in Texas, and the procedures that they've had have been when they've been over 18. And I notice a thread with them that many of them did not have the approval or love of their parents. I don't know that that problem is anything that we've seen, and we haven't gotten to hear from the Texas families yet. But in your experience with Lambda Legal, is this a problem that needs to be solved in Texas, or is this something else?
So my experience is no, not at all. And in fact, we get about 7,000 phone calls a year, not all of them from Texas, but I can tell you that we get a good portion of those from Texas. And I've had in the last 2 years, hundreds of families call and text me. I've had many families just in the last few days call and text me. They love their children. Mm-hmm. They want to have the right, without governmental intervention into their lives, to make decisions with their medical providers. Mm-hmm. This is gross governmental overreach into an area where you have heard there is science, and I think that there's boxes that are going to be brought in with all of the studies for you all to look at peer-reviewed, best practice, life-saving, scientifically proven medical care that has been given to kids who have precocious puberty and who don't perhaps develop as they should, so you help them out a little bit. 50 years worth of studies on that. I'm not a doctor. I'm not here to talk about that, but that is the reality that I'm aware of.
You've also talked about the potential legal implications with, as you say, a certain segment of population can continue to get surgeries and hormones, but if you're trans and identify trans, then we're going to cut that off to you in Texas. Is there a concern that this will also impact funding that would include our overall healthcare system and a risk of federal funding because we are improperly making a judgment on one population versus another?
The short answer is yes. Under the ACA, Section 1557, it prohibits discrimination based on sexual orientation and gender identity. That's pre-2016. And so where we are now, there's been notice and comment period. The comment period has been closed for new rulemaking guidelines that would specifically include sexual orientation and gender identity. And so in the interim, what that would mean is that hospitals and healthcare providers could be subject to investigations by federal government and also lose their funding.
Thank you.
Other question, members? Thank you.
Thank you. Thank you all.
Catherine Oakley, Irene Erickson, Dara Jackson, if you'll state your name.
Hi, I'm Catherine Oakley, and I'm the State Legislative Director and Senior Counsel at the Human Rights Campaign.
And your position on the measure?
Against.
Okay.
Thank you so much for having me here today. HRC is the nation's largest organization fighting for LGBTQ equality, and on behalf of our thousands of supporters in Texas and our 3 million members and supporters nationwide, we urge you in the strongest terms to please reject the discriminatory legislation before you today. You've heard a lot of statistics today, and I've been sitting here all day, so I've rewritten my testimony several times to try to cover points that you haven't heard as often. And I want to be sure to deliver this point to you precisely and emphatically. There is no legitimate basis for the state of Texas to act to prevent age-appropriate, gender-affirming care to transgender youth. This is best practice care. Maybe you have questions about it. Maybe you have curiosity about it. Maybe you'd like to see more studies about it. That's likely true of many different kinds of healthcare. And it doesn't change the fact that the experts on this kind of healthcare have established best practices. And this body is substituting its judgment for that of the medical experts who've just devoted their careers to learning about it and delivering the best care they can to the patients before them. Not hypothetical patients, real, live patients. Gender-affirming care is age-appropriate care recommended by every credible medical organization, including the American Medical Association and the Academy of Pediatrics. These doctors represent over 1.3 million doctors in the United States. Why? And all of this care is dependent on the informed consent of the parents. Why regulate this kind of medical care specifically? Well, I have to point out, as others have, that this is not the first time that I have come to this podium, nor for many of the other folks in this room come to this podium. Because over the course of the last several legislative sessions, there has been one attack on the LGBTQ, but particularly the transgender community, after another. Texas has a track record of discriminating against transgender people. Advocates for this legislation nationally have said very clearly, including recently to the New York Times, that they don't support anyone accessing gender-affirming care, including adults, not just limited to children, because they don't believe in quote-unquote gender ideology. That is, they don't believe people can be transgender. Preventing certain types of people from receiving best practice medical care simply because of disapproval of those people is discrimination. The science simply does not support there's any reasonable reason to do so. And laws similar to these bills have been challenged in other states where they've been passed, including in Alabama and Arkansas, where Republican-appointed federal judges in both states have issued injunctions preventing these laws from going into effect. These bills have significant constitutional implications as well as run afoul of federal civil rights law.
Your time's expired. Questions, anyone? Thank you. Chair calls Irene Erickson, Dara Jackson, followed by C.C. Cox. Ms. Erickson, I show that you are testifying for the Institute for Research and Evaluation and yourself, is that correct?
Yes.
And you are for the bill?
Yes.
Okay, please begin your testimony.
I've been an invited speaker or consultant at the National Academies of Sciences, the CDC, the Department of Health and Human Services, and United Nations conferences. I'd like to address just one particular thing today that maybe nobody has as well as I could. And that is the problem with the research. There's a lot of smoke and mirrors that goes on in this research, and I want to give you some examples of that. The Turbin studies have been mentioned earlier today as the best evidence that gender-affirming care reduces suicidality. The Turbin studies were correlational. They did not have comparison groups, so they could not test cause and effect. They both found that there was a decrease in suicidal thoughts. This was reported in the abstract. Not reported in the abstract, which is the only thing most people read in a study, was that both of these studies found no reduction in suicidal thoughts with plan, suicide attempt, or suicide attempt requiring hospitalization. All are more serious measures of suicidality than suicidal thoughts. The 2022 study also found that 16 and 17-year-olds who received hormones were more than twice as likely to report a past year suicide attempt with a p-value of less than 0.01, and that a second analysis of the same data set found that there was a significant increase in suicidality, nearly twofold, for biological males receiving estrogen. Suicide thoughts with plan, suicide attempt, and suicide attempt requiring hospitalization all increased for this group. I'd like to address the study that was mentioned previously by Dr. Cooper. That is a longitudinal study that's coming up, and they have reported on early results already. But in doing so, they've come under some scrutiny and criticism with issues of research quality. The study had no control or comparison group, again, so not able to test causality. The study abstract did not report that there was no improvement in mental health for biological males who took cross-sex hormones, but only for females. And there were 2 patient suicides, but no report on hormones' impact on suicidality, which they did measure. 2 suicides in a patient group of that size is a very high rate of suicide. They also did not control for the documented receipt of psychotherapy and antidepressant medication, so they couldn't distinguish those effects from the effects of the cross-sex hormones. So this, I hope, will give you an example of some of the problems with this research. It's really a lot of it is what I consider smoke and mirrors and misrepresentation of the findings. And these were all peer-reviewed, published studies in mainline journals. So it's, anyway, yes, thank you.
Your time's expired. Members, questions? Representative Alverson.
Just real quick, Irene, I know you put a lot of effort into this, and you've done a lot of research on the research.
And I've got...
I just wanted to give you a chance if there was something else in your testimony as you're talking that you didn't quite get to. And I know, we have lots of folks who want to testify too, but if there was some other study that you specifically needed to mention, I wanted to give you an opportunity because I appreciate
Well,
being here today.
it kind of goes on and on. The DeVries study that got this whole ball rolling way back in 2014 at the Dutch study, the Dutch
right,
clinic.
The original Dutch protocol.
Yeah, the Dutch protocol. They had, no control group, non-representative sample, an inadequate sample size. Get this, there were only 32 patients for the mental health outcomes with subgroups on key outcomes of 15 kids. So if 3 kids changed their, reply on the survey, the whole, results change. And so those 15 kids basically, determined national and international policy on cross-sex hormones for the next decade.
And as I recall, and correct me if I'm wrong, I think you came and testified on the other side about this issue as well, did you?
On the Senate side,
right,
not on the other side of the
And I know there was some questions about your credentials and stuff like that.
Yeah.
But if I remember correctly, your area of expertise and specialty is that you have a great deal of knowledge and training and experience in really analyzing research methods and looking at the quality of data and outcomes and being able to sort of give almost like an A through F rating. Is that a fair assessment of your expertise?
One doesn't want to oversell a person's expertise. I have published on that. I was asked to be a consultant, one of 6 national consultants to the CDC's landmark meta-analysis on sexual education effectiveness 10 years ago, and I'm a co-author on that study.
So we've heard from multiple people today on both sides about the quality of the data and the research and what the research says. So in your capacity as someone who is an expert at looking at data and analyzing if the methods were free from bias, if they were adequate sample sizes, if the study was appropriately powered and appropriately designed to reach the conclusions that the authors reached. In your opinion, is there any study out there that provides convincing, prospective, or significant power that would say that these medical treatments for kids that have gender identity issues reduce the risk of suicide or significantly resolve the issue of gender identity?
Yeah.
Are there any good studies
I
out
would
there?
say, and I'm not alone in this, that probably one of the best is this Swedish study from 2011, because it's a population-based study. They had health records on everybody because it was a national health system.
Not a self-reporting
Not a self-reporting
survey
that
or any of that
got
kind
off
of
the internet websites.
Okay.
So, and they did a 10-year analysis. Now, in fairness, they didn't have really a comparison group either. So they rightly said, we can't attribute the cause of, so they found 19 transgender patients were 19 times more likely to die from suicide than the typical Swedish population. And they can't say that's because of the transgender surgery. But what they concluded was that after accounting for the differences, that these transgender procedures, our findings suggest that sex reassignment, although alleviating gender dysphoria, may not suffice as treatment for transsexualism. These are older terms, because this was an older study. They said surgery and hormonal therapy is apparently not sufficient to remedy the high rates of mental illness and mortality, meaning suicide, found amongst transsexual persons.
And that's the best, I don't mean to cut you off, but that's the best, in your expertise, that's the best we got as far as, because that's a population study, and so it's, right, I get it's not prospective, but at least it's not someone filling out a survey.
And the male to female part of that population were at higher risk, like 40 times the risk.
Wow.
So,
Okay, so bottom line, best study we got, all the drugs and surgeries in the world did not significantly reduce the risk of.
The authors did not think so.
Did not think so.
And
but they also couldn't say. At least they knew what they didn't, what they couldn't prove, and they didn't try to extrapolate
when Medicare did their own analysis of all of this, and they decided that there wasn't enough evidence to say that surgery had benefits for the population. Okay. But they also said that they could not rule out that the therapeutic intervention in this study, the Swedish study, as a cause of the observed increase in mental illness and mortality. So
bottom line, what I hear you saying, despite what we've heard repeatedly, there are no good studies out there that prove that this is a benefit in terms of.
Well, I can tell you, I've been really disappointed in this one that was just reported on earlier by Dr. Cooper, because this is coming new. I mean, this is new on the docket, and it's several studies all over the country, and yet they've left out crucial things like controlling for psychotherapy and antidepressants. I mean, so this is why notwithstanding what was said earlier, England, Sweden, Finland, and Norway, all within the last year, so very recent, these are not 2018 systematic reviews, very recent systematic reviews, Norway was just 3 weeks ago, have all concluded that this medical transition procedures should not be the standard of care for minors. Okay?
Right.
And they have been very clear about that.
Okay. Well, I am grateful for your expertise in being here today, and I agree with you. And I guess, what I appreciate about your testimony the most is that, for me, the biggest struggle throughout this whole process has just been finding what I would consider to be those gold standard, high quality trials that,
Yeah.
that basically show one way or another, does this work? Does this not work? Does it cause harm? Does it not? They're not out there.
Well, and it's
this
hard
is
to
kinda
know
like the
what we
Wild
know,
West.
and that is part of the problem, because we're not just saying we know these things don't work, we're saying we don't know a
Right,
lot.
and I think you said it exactly right, and it bothers me immensely that there are far too many people out there claiming to know what they actually don't know. They
Yeah.
don't even understand the limitations of their own
Yeah,
research.
and what the British National Health Service decided was the risks are too great, and the benefits are uncertain, and the harms are known.
It's like everybody should go back to college and take biostatistics over again, don't you think?
I guess, I don't know. But, it's, yeah, I had another thought, but it's escaped me, so.
Well, I'm grateful to you for being here. I
Thank you.
thank you for coming to testify.
Chair calls Dara Jackson, followed by C.C. Cox and Louis Appel.
Hi, Dara Jackson, speaking in favor of the bill. I came here today to speak as a former psychologist with the Texas Department of Mental Health, Mental Retardation, a former college instructor in child development and mental health.
You're representing yourself, is that correct?
Representing myself, sorry.
Thank you very much.
And a educator who's been involved in knowing very closely 600 students. But after listening to testimony all day, I'm here today as an ordained minister to say I apologize for not praying for you as I should, as the scripture implores us to pray for those that are in authority over us. I deeply appreciate who you are and what you're doing. I appreciate the fact that you've been here since before 8 o'clock this morning, and you have patiently endured much at the hands of many witnesses. And I appreciate that. So I commit to pray for you as I should. Thank you.
I have a question, sir. Sir.
Representative Tinderholt's got a question for you.
Hey, thank you for being here today. So you're a retired psychologist?
Yes.
And a pastor?
Uh-huh.
So from what you've heard today and what you know about this, would you consider this potentially child abuse?
Yes, we have a phenomenon called social contagion that is sweeping the nation, which has resulted from a research standpoint in the biggest social experiment that this nation's ever had. And it makes some of the social experiment crimes of the past, which are many, minuscule in comparison to the size. And so from somebody that's trained, that's been around the block a long time, this is crazy, what we're doing.
Well, thank you for spending your day with us and making it important enough for you to come here and spend the day with us today. Thank you.
Thank you.
Other questions, members? Thank you.
Thank you.
Chair calls C.C. Cox, Louis Appel, and then Jeffrey McDonald.
First thing I always have to do when I speak to a public body. Up goes the microphone.
And I show your name is C.C. Cox, and you're representing the Resource Center, is that correct?
I am.
And
Testifying on behalf of Resource Center.
And you're against the bill.
That is correct.
Please proceed.
Thank you. I am testifying on behalf of Resource Center in Dallas in opposition to House Bill 1686. I am an attorney and the CEO of Resource Center, which has been serving the LGBTQIA+ community for 40 years as a frontline responder and a service provider even before the early days of the AIDS pandemic, and we have continued those services ever since. We are the largest direct service provider to the LGBTQIA+ community in Texas, reaching more than 60,000 people annually. I'm here to express my own disgust and outrage over this bill and the harmful lies that are being told about transgender youth and their families in an attempt to justify this bill. But more importantly, I come tonight to carry the voices of hundreds of youth that our organization serves. Please listen to their own words. Quote, It makes me scared for the future. As someone who plans to leave the state, I fear for the people here. Quote, it makes me feel unsafe. Quote, it's made me feel non-human. Quote, how are we supposed to be the land of the free when politicians so carelessly take away the rights of human beings? Quote, it makes me feel unsafe. Quote, now I must fear what happens to my family just because I exist. All of these bills make me feel unsafe in my life. Quote, I feel unsafe. People are making decisions that will forever impact the rest of my life. My identity is not harmful to anybody, nor will it change when my rights are taken away. Quote, the bills debated by political leaders, in quotes, in Texas make me afraid for my life and safety, and these bills could take away a vital source of care for myself and those I hold dear. Trans kids and their families are not the problem. This proposed legislation is. Mental health distress among transgender and LGBTQIA youth is at an all-time high, as you've heard today repeatedly, in large part due to the rhetoric they hear debating their very existence. I'm here to ask you to stop the misinformation, to stop the falsehoods that cause youth to doubt their self-worth. This queer person has lived through the AIDS pandemic. The government tried to ignore us then and control us and erase us. But guess what? We didn't go away then, and we're not going to go away now, and we vote. I oppose House Bill 1686, and I'm glad to take any questions that you might have.
Question, members? Thank you. Luis Appel, Jeffrey McDonald, I see on here your name is Luis Appel.
Louis Appel.
Okay, I'm sorry. And you're representing the Texas Pediatric Society and yourself, and you're against the bill, is that correct?
That is correct.
Thank you.
My name is Dr. Louis Appel, and I'm a practicing pediatrician and current president of the Texas Pediatric Society. I'm here testifying on behalf of the Texas Pediatric Society in opposition to HB 1686. HB 1686 would cause significant harm to the health of transgender youth in Texas and prohibit physicians from using their medical education, training, and experience to work with families to determine the best course of treatment for their children. There are carefully developed guidelines supported by evidence and multiple medical organizations that provide for safe and appropriate health care for transgender youth with gender dysphoria. Transgender youth are at increased risk for suicidal ideation and suicide attempts. When transgender youth with gender dysphoria are provided with appropriate health care, including puberty-suppressing medication, there are mental health benefits that include decreased levels of suicidality. The decision of whether and when to initiate treatment is personal and involves careful consideration of risks, benefits, and other factors unique to each patient and family. The process involves psychological and medical evaluations over time with the participation and consent of a child's parents. Only after the onset of puberty is medical treatment considered, and only in some patients, again with consent of the child's parents. Treatment with medications to temporarily suppress puberty is reversible, and these medications delay the development of secondary sex characteristics that often spark intense distress for transgender patients. Later, generally after the age of 16 and after living in their gender identity for some time, teenagers with the consent of their parent can consider hormonal therapy, but only after extensive discussions among the patient, family, and healthcare team. All medical treatments involve weighing the risks and benefits of both treating a condition and not treating it. Medical care in the treatment of gender dysphoria is no different, and weighing the various factors that come into play for individual patients and families is something that is best left to the patients and their families with guidance and consultation from their healthcare providers. A blanket ban on these medical treatments is a very inexact approach for the state to use and prohibits treatment options that can be critical for the health and well-being of transgender youth with gender dysphoria. Thank you.
Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here today. Are you a medical professional as well?
I am a physician.
Okay. And so do you have a board is there a board that consists of your organization, or is it you?
Well, I'm representing the Texas Pediatric Society. I'm board certified by the American Board of Pediatrics.
Right, but is there a board of people at the Texas Pediatric Society, and are you on that board? Or are you just a member?
Oh, we have an executive board. I'm the president of the Texas Pediatric Society.
And they're all medical professionals as well?
Yes, sir.
Okay. So what is a woman?
I would agree with the answers given by the TMA.
I'd like your answer.
Previously before.
You're a medical professional, so I'm hoping you can give it to me.
A woman has XX chromosomes and a uterus, a vagina.
Can can any man have a baby?
And a man with XY chromosomes, a penis, no. There are differences in gender identity that don't align with people's biological.
So what I'm asking is, can any man, can they have a baby?
No.
But you confused me because it sounded like you were kind of leaning toward a yes when you started talking about a certain type.
I'm sorry for your confusion.
Well, no, it almost sounds like you're telling me, it almost sounds like you're trying to be snarky, which is really not very respectful, but I'm okay with that because that's what I would expect with someone. Hold on. That's what I would expect.
I'm not.
Hold on. That's what I would expect from a medical professional that thinks it's okay to do what you're doing to children. So let me ask this.
I must have misunderstood your question.
Okay.
I'm sorry.
So you think it's okay to take children, which we were told earlier, 85% of them will grow out of just gender dysphoria by adulthood, and you think that it's okay to give them puberty blockers, hormones, and potentially do different types of surgery? Is that what I'm hearing from the Pediatric Association?
What I am saying is that these are difficult, nuanced decisions that require weighing of risks and benefits of treatment and non-treatment that are specific to individual patients, individual families, in that when you have that type of situation, that allowing the patient, family, the patient, their parents in this case with minors, and the physician to determine what the best weighing of those risks and benefits is, that's the best way to approach these types of challenging issues.
So you're saying that doing something that could potentially long-term harm a child, that 85% of those children are going to grow out of it and say that, hey, I wasn't what I thought when I was 12. You think that it's okay to even consider something that is permanent? You could disfigure them. You could change their life forever. You could make them sterile. There's so many things that could happen. And what I'm trying to get out of you, solicit you, is a yes or a no. You think that that's acceptable risk to do? Because I've heard do no harm. I've heard there's 4 tenets that you guys swear to. I don't know what they are. I think one of them is do no harm. I feel like you're doing harm to those children. What would you say to that?
I think one, the growing out of gender dysphoria number, I think, as we've talked about, I think there are different numbers that are being thrown around, different studies that are being thrown around. But I would say that again, you have to look at what the situation is for the individual patient to understand what their risk of different types of outcomes is, and you have to weigh that against what the risks and benefits of potential treatment are, understanding that there are uncertainties in the information that we're dealing with. That is true in a lot of areas of medicine.
I'm just appalled that the Texas Pediatric Society is here telling me that these types of procedures are okay. I didn't expect that from you. And you can tell that I'm visibly agitated because I'm totally caught off guard. I'm totally surprised that you're testifying against this bill when this will definitely do harm to. We've had people come here and tell us it's done harm. I'm really concerned.
Making this treatment illegal will do harm as well.
If this bill passes, we're making it illegal for children. We're making it illegal from children. We've heard where children get to self-diagnose. We've heard today that children learn from the internet how to tell their psychologist that they have these issues? I mean, I'm just caught off guard that the Texas Pediatric Society is here testifying against a bill. I fully expected that you were going to be here today telling us that you were for the bill because you truly care about kids and their well-being, long-term and short, and that you wanted to take care of these children. I don't have words, to be honest. What would you say to that?
We are dedicated to serving the health of children.
But is it really the health care of a child when you're doing this damage to them? To make them feel better about who they think they are or aren't. They've altered reality. They think that they're something different, and you're doing something that is either permanent or semi-permanent.
Again, respectfully, I would say that these are difficult, challenging decisions about care that are best made by the patient with their parent in this situation and in consultation with their healthcare provider.
I will say I have a 4- and a 6-year-old, and this scares the crap out of me that you're testifying that this is okay. I don't have words. Thank you for being here.
Other questions? Representative Price.
Thank you, Madam Chair. I assume you polled the Pediatric Society members before you gave your testimony today, and that's the basis upon which you're giving the testimony. Is that correct?
We don't poll. We have an elected executive board, and the elected executive board has approved our platform for the legislative session.
So how many members are in the Texas Pediatric Society?
There are about 4,800 members.
Okay, and so this board is how big, the elected board?
Honestly, the exact number, it's around 20 or so people.
Okay, so a majority of that board is what's required for you to give the testimony you're giving?
Yes.
And do you have any idea, and I don't know if this has come up in discussing it with your members, how many patients, children, seeing their pediatrician for a gender dysphoria or distress situation that are not prescribed hormones or other medications to treat that condition?
Can you repeat the question? I'm sorry.
Yeah, I'm just trying to get a sense. We've heard a lot today about treatment and potential side effects and all, and you mentioned yourself all the studies and all the different data, and I haven't heard a whole lot of folks get up and say folks have presented with these conditions that we've discussed, like gender distress or dysphoria, but have not been treated with hormones. I'm just curious, like as a percentage, if you could argue.
I don't specialize in this area of care myself as a general pediatrician. I would say that the number of children we're talking about is relatively small compared to other issues that we deal with, like firearm injuries or or car accidents or that type of thing that impact the health of children. So I would agree it's a small number of children. In my experience with talking with people that have done this care, typically this care happens over a long period of time, longitudinal relationships with families and patients, and some of them originally presenting do not, wind up not getting medical treatment, and others do. But it's not my area of
But you can't say as a percentage, like what,
I can't.
Obviously, that would be unique, I guess, to each practitioner and their clinical experience.
Yeah, I apologize. I'm not able to
speak. But you don't have a sense of that for your membership, I guess, is what you're saying.
I don't.
Okay. Is there any objective, medically verified diagnostic test that you are aware of that pediatricians use to then prescribe treatment one way or the other for these conditions we're discussing today?
Like a blood test or an x-ray or something like
Anything.
that? Is that? I'm not aware of anything.
Okay, all right, thank you.
Representative Alverson.
Thank you, Madam Chair. Dr. Appel, I appreciate you being here today. And I know you had to wait a long time to testify, so especially I'm glad you're here. And kind of just like Representative Price was saying, so you're here on behalf of the society. You're representing all 4,800, I think you said, members. Do you have any idea how many of those members may not be in complete agreement with your comments today? Or do you know for a fact that all 4,800 of them completely support what you're saying?
No, I don't know.
Okay.
We haven't pulled specifically on this legislation.
And that happens, and I understand, and I'm not trying to quibble with you about what percentage and stuff like that. I think the point I'm trying to make is just that you're representing an organization, but my guess is, just like the Texas Medical Association, you probably have doctors within the Texas Pediatric Society who are on both sides of this issue. Are you aware of what's been happening at the American Academy of Pediatrics with regards to some of the decisions that their board has made? I think there were resolutions that were attempted to be presented at their last meeting that would have basically called into a formal discussion the guidelines that AAP had adopted. And their board of directors essentially shot those things down and refused to allow the members to actually debate the issue. Are you aware of that?
I'm not aware of the details. My understanding is that there were procedural issues around it, but I'm not familiar with the details.
Yeah, these things, I've seen it before. There's always procedures and things like that, and obviously that we have those too. And sometimes good legislation, doesn't make it all the way through because of procedural things. But the fact of the matter is that there was a time very recently when there was a movement within the American Academy of Pediatrics to revisit and have a more robust discussion. What do we know as of right now? Go back and review those guidelines, which I think were adopted in 2018, if I remember correctly. And there, for whatever reason, there was an internal decision or there's a process that essentially squelched any debate or any rigorous scientific debate within the House of Delegates for the American Academy of Pediatrics itself to actually examine this issue and see whether or not the membership still agreed with the position of 2018.
I mean, I would just say, Representative Oliverson, Dr. Oliverson, information evolves in medicine.
Absolutely.
And I think it is absolutely critical that we all be open to new information and that we support research to try to understand things better and to get better research and better information to help us make better judgments. So I certainly have no problem with the idea of that it's important to relook at information multiple years later to reassess whether something that was felt to be appropriate previously still is.
And I think we should always do that in science. And I think you would agree with me on something I said very early in the conversation today, which is that essentially, if in fact it's science and if it's provable, then it withstands scrutiny. It stands on its own. We can examine it, we can throw rocks at it, we can be critical of it. It doesn't have feelings, it's not hurt. If it's factual and if it's supported by good quality data, it withstands scrutiny and it withstands the test of time, right?
I think it can be challenging in certain situations to get the highest level of data, and I think in medicine we've
certainly heard that today. Yeah.
I think in medicine we do often start with things that don't have the highest level of data available to them, and sometimes over time that data does develop, and sometimes things sometimes it doesn't as much. Sometimes it's difficult to get that data depending on the situation. But
completely agree. But you would agree with me that I think you would agree with me that we shouldn't be fearful as doctors and as scientists to have rigorous, honest debates about what we know, what we think we know, and maybe what we thought we knew has changed. Those are good conversations to have in healthcare.
I completely agree with you, particularly if there's openness to obtaining the information that's needed to get to an.
I'm glad you're here today, and I appreciate you coming. And
I appreciate
I thank you for
allowing
your
me to
testimony.
speak.
Representative Jones?
Dr. Appel, earlier today, someone insinuated that you might have been snarky. Was your intention to be snarky?
No, it was not. It was not.
Okay. And I think you said something like there's like maybe 4,800 members of the organization that you're the president of. It's interesting to me that there are over 30 million people in Texas. There's 150 whole Texas state legislators. And there's some kind of discussion that maybe not a lot of people agree with you. I mean, democracy works not just in the legislature, but with your organization. And I want to make sure I point that out.
Thank you. We do have an elected representative governing structure.
Yeah, and when you're testifying what you do, you follow the standard of care that's been established until the standard of care changes. Is that accurate? Or do you say, no, I'm just going to do what I want to do, whether it follows with the standard of care or not?
You know, I would say I follow the standard of care, but I do also look at information to make sure I understand what the standard of care is based on. And again, I would say in this particular case, this is not care that I directly provide.
Have you been here a long period today?
I was at work most of the day. I got here about 6 o'clock this evening.
While you were here, did you hear, like I heard, there's some trans people who had access to the health care said that it was right for them? Because I keep hearing mischaracterizations of the evidence, of the testimony, that everybody says that it was, or I guess the people who say that it wasn't right for them somehow are more important than the people who say it was right for them. But you heard both types of testimony,
I did
right?
hear that, and I have talked to providers who provide this care and have experience with very positive outcomes for the patients that they treat.
And also, as a physician, you want to take care of the health of children, correct?
Yes.
Do you do anything in your practice that goes against that?
No.
Based on the knowledge that you have and the education that you have?
No, we do our best to provide good health care for children and to seek their health and well-being, support their health and well-being, and their families and supporting their health and well-being.
And what I will say to you is I'm extremely thankful that your elected board decided it was important enough to come to the state of Texas and tell us what best practices are for your board. I appreciate that. And I applaud your courageousness to stand up for the health care of all children. So thank you.
Thank you.
Other questions, members?
I do.
Representative Smith?
Yeah. Doctor, I do also appreciate you being here today. Just taking part in the process is really helpful, whatever position on this that you take. Just to get something out of the way, do you have prepared remarks?
Oh, yeah, I'm sorry. I just realized that I didn't.
And you can hand those out. That's great. Did you prepare those remarks yourself?
I participated in the preparation of them.
Who else participated?
Our advocacy director.
Okay. All right. And I guess along the same lines as what Representative Price was trying to get at, how do we know what the position is of the majority of your board members as it pertains to those remarks?
These remarks have been shared with our executive board, and I did not see any objections to the remarks.
Okay. But they've not been shared with the membership as a whole, is that correct?
I believe they're not posted yet. They will be posted, although I'm not 100% sure about that. Typically, they get posted to our membership once the testimony has been given.
Once you give it?
Yes.
But not before?
Yeah, typically that's
Okay, so we know what the position of the executive board is of the Texas Pediatric Society, but we don't necessarily know what the position is of the majority of pediatricians who are members of that board, correct?
Well, we know what the position of the executive board that was elected by the membership of the
Fair enough,
organization.
fair enough. Well, we'll get on from that, but how long have you been practicing medicine?
Over 20 years.
Okay. And you're a board-certified pediatrician, is that correct?
Yes, sir.
Okay. But admittedly, you said that you don't practice in this area of gender transitioning?
That's correct. It's not my specialty. I do general pediatrics.
Do you deal with any children that you think suffer from gender dysphoria?
I have had patients.
Or two, maybe?
A small number. My clinic has an adolescent clinic in it, so I mostly deal with younger kids, and I don't deal as much with adolescents.
You've been here since about 6 o'clock, and I appreciate that very much. Did you have an opportunity to hear any testimony about the groundswell of numbers of children that are reporting with gender dysphoria since 2007? Did you hear any of the testimony on that?
I didn't hear that specific testimony.
Okay, I'll represent to you, and you can ask around, but what I took from the testimony was that since 2007, particularly during the COVID era of just a couple of years ago, there's been a massive increase of children presenting with what physicians and psychiatrists and psychologists are calling gender dysphoria. Will you take me at my word on that?
Okay.
Okay. In your experience as a doctor over the last 20 years, have you seen an increase in the number of children that report with that or present with that?
I have not diagnosed gender dysphoria in a child. Again, I tend to deal with younger children.
Okay, so you just can't say one way or the other. That's right. Okay. I'll represent to you that that's been told us today, that since 2007, we have this massive increase in numbers, something like 4,000% maybe, shown in some studies. I think there was a European study that was shown. Okay. There's also been testimony by medical professionals and psychological professionals that a specific time period of the COVID time period really lent itself towards that increase in that presentation, okay? If that is the case, and these numbers are far beyond what normal numbers would be for a presentation of gender dysphoria in the public, okay? Does that not in your mind, that in your mind obviously would present a question about whether or not we really have a problem with gender dysphoria to that level, and whether or not there are children who are being treated for gender dysphoria that maybe do not need it. Wouldn't you agree?
I would say it's very important that this care is dealt with on an individual basis, case by case, with the patient, with the family, with the healthcare providers, that are being very careful to ensure that only patients who truly would benefit from this care would. I think that the thing that is problematic with the legislation is the blanket ban on the treatment. I think if there were proposals related to putting some guardrails, but allowing this care to still be available to the children who definitively need it, who need it, then I think that would be certainly preferable to a blanket ban that doesn't allow for any consideration of the specific situations that families, children, and the providers trying to take care of them find themselves in.
Because I think earlier you'd said that this is a difficult, nuanced decision. I think those are the words that you used. Is that fair?
Yeah, I think I said, yeah.
Okay. So Just go with me, though. We talked about this huge increase in numbers since 2007. That causes naturally for you a question in your mind as a professional as to whether or not these are really legitimate or not, right?
I want to be careful with the language in terms of legitimate or not. I guess what I would say is it's always important in medicine that we make sure that we are making a correct diagnosis and that we are prescribing appropriate treatment.
Because especially in connection with this type of treatment, what we do have is measurable harm that can happen to a child if we get this wrong, correct?
And we have measurable harm that can happen if the treatment's not available.
Fair enough. But we've got it on both sides, right? So you've got the significant increase of children who are now presenting with this since 2007 for whatever reason, okay? We have maybe a lack of studies on it. You're in here saying, well, these children need this treatment. And I'm saying, yeah, but these children may not. And they're going through it. And so the question is, if you're going to do no harm under your Hippocratic Oath, how do you address the needs of these children?
I guess I find the way that you're defining, I guess I want to understand a little bit more how you're defining.
I'm talking about
harm.
children who present with gender dysphoria that truly don't have it. Or maybe they think they do, but they're set on a irreversible course or a reversible course that causes damage.
I think the physicians that I have spoken to that provide this care, that the approach and the time taken and the longitudinal type of care that's provided is to minimize the risk of that, of there being harm, and I would say making sure that there is clarity about risk, about what potential risks are when those are part of treatment.
Let me talk to you just a little bit as a non-lawyer, or excuse me, as a non-doctor. Educate me a little bit, okay? The medical board, all right, in the law, we have the bar, right? So if we screw up and do something bad, someone makes a complaint, then the bar steps in and they make a decision as to whether or not there was a problem, whether or not we need to have a hearing, if so, what the penalty is going to be and all this other mess, okay? My understanding is in connection with the medical board that there is also it's a complaint-driven process at its essence. In other words, it starts with a complaint from a patient or maybe another doctor or hospital staffer, whatever, nurse. And then from there it goes with the board, right? In the bar, what happens is sometimes there are opinions that are issued and the bar issues guidance to the lawyers about, hey, you can do this, but you can't do that. Okay. Does that happen with the medical board?
I can't say I'm an expert on the workings of the Texas Medical Board.
That's probably a good thing.
Yeah.
But do they have, do you get information from the medical board that gives you an understanding as to what the standard of care is?
I don't want to misspeak, Representative. I'm not sure if the Texas Medical Board puts out standards of care type of things. I know that on occasion they may make a statement related to care, but I don't want to misspeak.
So the medical board just lets you guys do whatever the heck you want to do?
I don't want to speak for the Texas Medical Board.
Well, Doctor, you've been a practicing physician in Texas for years now. You can't tell me what parameters that the medical board puts generally for the practice of medicine on physicians in Texas? Whether they can or not, you can't tell me. Is that what you're saying?
The Texas Medical Board oversees the practice of medicine.
Absolutely they do. And they provide parameters for you as to what's ethical and not ethical, right?
Yes.
Okay. Are you aware of whether or not the Texas Medical Board has issued any directives or opinions or other statements as to what is ethical and not ethical in connection with gender dysphoria?
I'm not aware of that.
If I told you that no one's come in here today and testified as to that and given us any information as to what the parameters are on this particular type of treatment, would that surprise you? Is there any other area of medicine with this type of measurable harm where the medical board has not provided guidance to the physicians in Texas?
I'm not aware of the medical board providing specific care guidelines. But again, I could be wrong on that, but I'm not aware of the medical board providing specific care guidelines.
Doctor, I'm going to represent to you that the politics has invaded the medicine, and Texas children are paying the price. Thank you very much.
Other questions, members? Thank you. Chair calls Jeffrey McDonald, followed by Fran Rhodes. And then next on deck will be Mary Smith. Dr. McDonald, show your name is Jeff McDonald with St. Paul's United Methodist Church in Self. That's who you're representing. And you're against the bill, is that correct?
Yes, ma'am.
Okay, please begin your testimony.
Thank you. I'm the senior pastor at St. Paul's United Methodist Church in Houston, Texas. Excuse me. It is an exciting place to serve. We are right at the crossroads of Rice University, just a few blocks from the University of Houston, and the Texas Medical Center, and the Museum District in Houston. Yesterday, I preached from the Gospel of John in the story of Lazarus and Jesus. And in that scripture, there is, and if you grew up going to Sunday school and had to memorize scriptures, then you'll remember that story because John 11:35 is the shortest scripture, and so it was easy to memorize. Jesus wept. It's a wonderful story of Jesus' compassion for his friend, and when his friend dies, he cries about that. And so throughout the Gospels, we see Jesus conveying compassion to others. That's the overarching message of Jesus, is caring for others. In the United Methodist Church, we do our theology by looking at the scriptures, but also tradition and reason and experience. And the United Methodist Church has determined that all people are of sacred worth, that we all are created in God's image, and that as God created, when God created, God said that it was good. But we also believe that everyone has the ability to have health care, and health care is a standard that should be given to everyone. So I rise today to speak against this bill because I believe that in the compassion that Jesus showed, that we should show the same compassion in not denying health care to anyone who needs it, regardless of where they are, who they are in their lives. Thank you.
Questions, members?
I do, ma'am.
Representative Tinderholt.
Thank you again, ma'am. So it's correct that you're the senior minister at St. Paul's United Methodist Church?
Yes, sir.
What do you think St. Paul would think about gender transitioning procedures?
St. Paul said nothing about gender transition.
What do you think he would say?
I can't put words into St. Paul's mouth. I know his theology changed over time. I know he looked at different situations and saw different things. I know that he wrote to different communities about the struggles that they were facing in those communities. We've taken St. Paul out of context because some churches have said that St. Paul said that women should not speak in church. St. Paul was talking about a particular situation in a particular church, not all of Christendom. In other places, he talks about how women are leaders in the church and that the church would be nowhere without them, the Christian church. So I can't say what St. Paul would say.
Do you think that children are made in God's image?
Yes.
Do you think that they're perfect like he does?
Yes.
So why would you support gender mutilation of children? If you think, if as a senior pastor, as a Christian, we're talking about they're made in God's image and they're perfect, how can you support this bill in very probably permanently causing harm to these children. How can you support that?
Can I give you sort of a long answer?
You can give me what honestly, I'm going to be honest, I don't know how you're going to come up with any
I think that God set the world into motion and that we are people with choices, and because we make choices that sin has come into the world, and that can be described in all different sorts of ways.
So is this considered sin?
No.
Why?
Just
you're permanently modifying God's image, which is perfect, made in his image. You're a pastor, and you're telling me that this is not sin.
Yes, that's what I'm telling you. I don't think cancer is sin, but cancer has come into the world. I don't think
But cancer's not a
hurricanes
choice.
are a sin.
Cancer's not a choice.
Hurricanes are not a choice. People's houses who are destroyed by tornadoes are not a choice. And God's not causing that to happen.
So how would you sell this to your parishioners, the people at your church? That you
I wouldn't have to sell it to the people of my church because there are people who care about.
So are you implying that I don't care about children?
No, I'm not saying that at all. You asked me how I would sell it at my church. I don't know what church you go to or how your pastor would sell it. I'm just answering for St. Paul.
This testimony to me is very similar to the pediatric folks that were here a moment ago. I didn't think there'd be a million years where I would see a pastor in front of me telling me that this is acceptable behavior and procedures to do to children. And the reason I'm talking about in God's image is you're a pastor, so we need to talk about it. And I just don't know how you make this right by coming here and saying that we can modify these children that are made in his image. We're both Christians. We believe in the same God. We just said that his image is perfect and he created these children, and you're telling me it's okay to permanently modify their gender. I just don't know how, when we have to go meet our creator, how we say that that was acceptable. Can you explain that to me?
For me, it is, we are all created by God, but I think that things happen. I don't have a degree in medicine, so I can't explain how those things happen, but there are issues that come up, ways that we change and form, and that if we don't feel like we're living into the lives that God has called us to live into, to more perfectly do that.
Are you familiar with Matthew 18:6? Talks about if anyone causes one of the little ones to stumble. What's he talking about when he says little ones?
Disciples.
So could you also insert that there's children, or no?
Sure, yeah. Jesus talks about the kingdom of God belongs to children.
So when he says it would be better to have them have a large millstone hung around their neck and be drowned in the depths of the sea, I'm not saying that that should happen to people. I'm saying that's what the Bible says. How do you square that verse with other verses that clearly demonstrate children should be protected by our belief? How do you take that verse that we just talked about, and how do you make this okay?
Again, for me, it's about seeing the Bible as a whole and not picking and choosing things.
But when you talk on the weekends, you talk about a specific section or a small section, and you do.
Yes, yeah.
So we're
Yesterday, I
talking
talked
this-
about the Gospel of John.
So we're talking about this specific section right now. I'm curious how you square this up. We just talked about the fact that those disciples could be considered the little ones too. And the fact that the millstone has been talked about 11 times that I know of in the Bible. So God must have really put a lot of value on the innocent children, right?
Yes.
How do you make that right at your church with the people that you preach to every week? I really, truly, I'm bewildered. That's why I'm asking so many times, because I just don't know how you make this right.
Are you talking about gender?
I'm talking about modifying these children that are made in God's image, and he's saying if you make them stumble, which is exactly what this does, how do you How do you make that right in your mind? Because
I think that's where we would disagree, Representative Tinderholt, is that I don't see it as we're causing them to stumble. I think it's allowing them to live into the people that God has called them to be.
But God, we just said that they were made perfect in his image. So how are they imperfect?
We change all sorts of things in us about our image. We lose weight, we gain weight, we grow hair, we don't grow hair. We do all sorts of things that we change, even though that this is the body that God gave me. I do all sorts of things to change it.
So I've been disappointed a lot today. Appalled twice within the last 30 minutes, and this is one of them. I just got to be honest with you. Thanks for being here.
Other questions, members?
Yeah, thank you.
Representative Johnson.
Senior Pastor McDonald, I'm a proud member of St. Paul's United Methodist Church. And I'm always grateful that my Christian faith is one of compassion. And so Representative Tinderholt has said that he has expressed deep disappointment, or whatever he said, of the day of a man of God coming in to say that he rejects a law that would pick and choose health care between children. And so he gave you the impossible task of the image, and let's talk about intersex. So when a baby comes out with two genitalia, and those physicians make that decision, that would cause him, I guess, great pain. So I always get disappointed when people use the Bible to put us in impossible positions in a battle or a fight. And I'm grateful that you would have the courage to come up here on behalf of the children of the state of Texas as a Christian man, that we as a body could work together to find compassion. Have you experienced these families struggling to find the best path for their children and their faith? And do you think that those Texas families take their faith and their responsibility to the safety and security of their children seriously?
We do have families at St. Paul's who are struggling with this issue. We have youth that are seeking treatment. We've been sitting around today, and I've had the honor of listening to a lot of families who are grateful and thankful for the treatment that they are receiving.
Other questions, members? Thank you.
Thank you.
Up next is Fran Rhodes, followed by Mary Smith, and then Bill Taylor. Fran Rhodes. Okay, we'll go to Mary Smith. Good evening, Mary. Show your name is Mary Smith, and you're testifying on behalf of Concerned Women for America, and you're for the bill. Is that correct?
That is correct.
Okay, you can begin.
Chairman Click and committee, thank you for the opportunity to appear before you today. Thank you. I am Mary Smith, Area Director of Concerned Women for Texas, and I am speaking in favor of House Bill 1686. As a retired teacher and a great aunt to many nieces and nephews, I am saddened to be here to speak on this subject, but I cannot be silent today. Many of my students were joyous, fun-filled young children, and many were never burdened with the issues of today's students. I wish we could return to those days, but because of our culture's intent on telling kids that they were born in the wrong bodies, that they can change their sex, that they don't have to listen to parents, that others know better for them than they do, they are burdened children today. Some gain their feelings from friends, some from teachers, some from the media, and some from those with intent to harm. How did that happen? Doreen Denny, who's the Vice President of Government Relations for Concerned Women for America, states this: radical gender ideology has a chokehold on the very institutions that are meant to protect, educate, and uplift our children, and I agree with that statement. In our schools, the sex curriculum begins sexualizing children at a very young age, insinuating that a young child has to make a decision at a very, very early age. Thankfully, some states have moved forward quickly and with care. South Dakota, Alabama, Arkansas, and Utah have banned puberty-blocking drugs, hormone therapy, and gender change surgeries for minors. And as of March 23rd, 2023, Iowa has joined the laws banning gender transition for children. May Texas be added to that list of states. Thank you.
Questions, members? Representative Tinderholt.
Thank you, Madam Chair. Thank you, Mary Smith, for your service to our amusing community as a teacher, but a lot of people in this room don't know that for years, since almost the day I was elected, you've been volunteering in our office. I love the fact that you came all the way to Austin for this, and I just want to say thank you.
Thank you. Thank you, Sam.
Next up is Bill Taylor, followed by Emily Schmidt and Miriam Reynolds. Bill Taylor, Emily Schmidt, Miriam Reynolds. Just state your name, please.
Emily Schmidt.
Okay, Emily.
I am a Houstonian. I am for the bill. And I am speaking on behalf of myself.
Very good. Thank you. Please begin.
I'd like to start off by thanking everyone for their time. My name is Emily Schmidt. I am 24 years old. As a preteen, I was riddled with depression and anxiety like most teens are. I also struggled with my body image due to puberty and polycystic ovary syndrome, also known as PCOS. PCOS caused me to have higher testosterone levels, which resulted in me being different and not quite fitting in with the other girls. My depression and anxiety started to get better just before I discovered the trans community. This community latched on to my insecurities and illnesses, teaching me that my body was wrong and needed fixing with harmful hormones and surgeries. I was the most depressed and the most suicidal when I was deep into this community of adults telling me that my body was wrong. My parents are amazing, though, and love me very much. But scarily, this community made me believe that my parents wanted me dead just because they wouldn't let me start hormones or call me by my preferred name. At school, however, teachers were required to call me Jacob and use he, him pronouns. I believe that if they would have called me by my real name, that I would have came out of my delusions and depression sooner. I am proof that a child can overcome gender dysphoria by not feeding into their delusions. Affirming a child's gender dysphoria with hormones and surgeries only furthers their delusions while keeping them in a dark, unhappy place. Every child hates their body growing up, and they should not face lifelong consequences because of that.
Question, members? Representative Smith.
Thank you. Emily, thank you so much for your courage. And you've been here, over here, like, most of the day or?
Since 7:30 a.m.
Okay, all right.
Yeah.
Well, thank you for being here.
Thank you for being here.
Yeah, thank you, and appreciate your courage and explaining some things to us. Now, let's talk about this transgender community, okay? What is the source, for you, what was the source of the community?
For me, I mostly found my communities online through forums such as Facebook, Reddit, and Twitter. On these forums, I had several adults contact me as a child telling me how to make DIY HRT.
And what year would you point to as when this began for you?
2015 through 2017.
Okay, all right. And so, did you ever, how old are you?
I'm 24.
You're 24, all right. So did your parents ever act on this in any way? Did you go to your parents and say, hey, let's go? Did they take you to the doctor? Did they take you to a psychologist?
Sadly, just before I came out, my parents lost their insurance, so I wasn't able to go to any doctors. But I said sadly, but I'm grateful for that. And my mother told me that if she believed I was truly trans, she would have supported me, but she didn't believe it. She knew it was a delusion.
Okay, all right. And so for you, how did it progress? Did it just naturally work its way out, or what happened?
I was always a tomboy growing up, and then right after puberty, I started seeing all this trans stuff on TV, and I remember the show I Am Jazz. They were talking about, oh, if you don't fit in with your classmates, if you're a tomboy, you're probably trans. So I started looking into that, and that's what really got me involved in the trans community, where these adults, when I was a child, would talk to me and affirm my gender identity and push me to start hormones legally or illegally.
Now, let's talk about your age group, and I mean that broadly, like maybe 4 or 5 years either side of you, okay? Have you seen what, some of you've heard some of the testimony today about the numbers of children, about the social contagion. You've heard it put a number of different ways. Do you believe in your age group that exists?
Yes, sir. I believe a lot of people my age have been harmed by this social contagion. I think a lot of people my age are confused about what it is to be a woman or a man. We are now being taught that if you're a masculine woman, that you're not a woman anymore. You have to transition to be a man. And we're also taught that if you're a feminine man, that means you're not a man anymore, that you have to become a woman. And that's just not true. Women can be masculine, men can be feminine. Just because a man likes wearing dresses, that does not make him a woman.
And so you're being taught this. Where are you being taught this? Is this maybe through social media? Is that what you're talking about?
Through social media, yes. My teachers at school, they didn't get too much into it because it was still new at the time, but my principal did require all students and teachers to affirm my gender identity, and I believe that if they didn't affirm my gender delusions, that I would have come out of my depression sooner.
Where did you go to school?
Port Neches ISD.
Well, thank you so much for your time.
Yeah, thank you.
Thank you for your testimony.
Thank you.
The chair will call Cameron Wright. Marion Reynolds, and then Cameron Wright and Maya Staton.
Good evening.
Good evening. Just to confirm, you are Miriam Reynolds, is that
Yes.
correct? And you're here on behalf of yourself, and you are against the bill, is that correct?
That's correct.
Thank you.
My name is Miriam Reynolds. I'm from Denton, Texas, and I'm a licensed professional counselor and a mother of a transgender child. I am here representing myself and speaking in opposition to House Bill 1686. I have worked in nonprofit mental health since 1996. I have provided care to the most underserved in our community for most of my career. My role as a mental health professional has brought me so much fulfillment and purpose. The most difficult aspect of my job right now is trying to meet the overwhelming demand. As a nation, we are in a mental health crisis that was only exacerbated by the pandemic. Unfortunately, Texas ranks at the bottom for mental health access for youth in the United States. We have such a shortage of providers, and the acuity of clients is rising. As a provider, I have more calls and emails than I can handle, and my colleagues report the same. Providers who have experience working with transgender youth are even more in demand. If you pass this bill, you will create a mental health crisis in our state of epidemic proportion. You will leave the providers that are already stretched to their limits to mitigate a problem that could be avoided by shifting more resources to increase access for mental health care for youth in our state. Our governing ethics bodies agree that affirming support of trans youth is best practice and standard of care. It's ridiculous to be considering restricting health care, especially affirming mental health care, considering this. I can tell you firsthand that my experience is that my clients who have had supportive parents and access to health care are thriving in comparison to their peers who had to wait until they were adults to pursue treatment. I can also tell you, as a parent of a transgender child, that the health care my child has received has been nothing short of life-saving. My child is healthier and happier than he ever was because he's been able to receive the care he needs. And I do want to say that we took our time to carefully consider what steps to take. None of this was done impulsively without lots of thought, lots of consultation with our medical providers. And I take that same approach with my clients. We are very carefully considering all of this, and there is no me pushing anything forward for clients. It is their choice to do what they do. I do not have any say in that. I follow the client's lead. Thank you.
Thank you, ma'am. Any questions? No questions? Thank you, ma'am. The chair calls Cameron Wright. Hi,
Good
Cameron.
evening. Hello.
Thank you for being here today, and I show that you registered at Cameron Wright. You're here on behalf of yourself, and you're against the bill. Is that correct?
Yes, it is correct.
Thank you. You may begin your testimony.
Well, good evening, members of the committee. Thank you for hearing my testimony. My name is Cameron Wright, and I am a 17-year-old from Denton, Texas, here in opposition of HB 1686. I'm finishing my senior year in high school, and I'm looking forward to graduating, traveling, and saving for college. I love my friends, and I love my family. I love music and writing songs. I play multiple instruments, including guitar, drums, trumpet, and saxophone. I have a really great group of close friends. We are good kids. We hang out and watch videos, play games, goof around, and sometimes talk about our futures. My friends describe me as courageous, goofy, fun, smart, patient, outgoing, honest, fearless, self-aware, determined, funny, helpful, reliable, awesome, creative, and a great cook and friend. Over the years, I have had some pretty awesome animal friends, including a special chocolate lab who passed away last summer. He was such a support to me when I was a little kid. I now have a 25-year-old rescued green-winged macaw named Mango. I have a loving and supportive family consisting of my mom, my dad, and my sister. I consider my best friend Camden a brother. When I was little, I had a foster sister that lived with us, and I consider her my sister. My mom, sister, and aunt are here with me today. Even though some of my family really struggle to understand how to support me, I am so grateful for the support of my family. I know that not all trans kids have that. I wanted to come here today to hopefully show you all that even though I am trans, I'm just a regular kid, and I deserve to access to health care. Please vote against HB 1686.
Thank you. Any questions? Thank you so much for being here this
Thank you.
evening. Thank you. The chair calls Maya Staton. Thereafter, the chair will call Sunny Bryant. Only Maya speaking. Okay.
Hi.
Okay, so who's Maya? Okay, Maya.
My mom.
So just to confirm, your full name is Maya Staton. You're here on behalf of yourself, and you're against the bill. Is that correct? Thank you. You may begin your testimony.
Hi, my name is Maya Stanton. I am 12 years old. Ever since I was born, I knew I was a girl. I always questioned, why did God put me in the wrong body? I tried to tell my parents, but they didn't understand for a long time. I have a twin brother, and he was the only one who got it. My parents used to dress me and my twin brother in matching clothes, and I hated it. I never smiled, and I wanted to die because I thought I would always be stuck in the wrong body. After therapy, my parents understood. I am a girl. They started letting me dress in clothes that matched my gender identity. I finally felt free. That little frown that always stuck around moved into a beautiful smile. These past 6 years, I've been able to live as my true self, are the only time I've been happy and been able to imagine a future for myself. I know you don't understand what it's like to be trans, and that's okay. You don't have to. You just have to listen to us when we tell you who we are. Lots of my friends' bodies are changing, and I so badly want to look like they do. When I think about if I woke up one day and I looked like a boy, I would be terrified and depressed. I could not live that way. This is my body. This is my future. You shouldn't have any right to tell me how I can live or what I can do with my own body. Do you understand how brave I have to be to come here and tell you over and over again to leave me alone and that I deserve the same rights as everyone else? Close your eyes and imagine for 1 minute what it's like to be me. Can you appreciate how certain I am in my identity to continue showing up in a world that does not understand or accept trans people? That I insist on living as my true self, even when it makes my life harder. These laws do not help anyone. They only hurt kids like me. I am a straight-A student, but this year, because of all the stress and anxiety from you, I have got my first B on my report card. It is getting harder for me to concentrate at school because I feel scared for my future. You are ruining my life. If I didn't have to worry about these anti-trans laws, I could just focus on school, friends, and my hobbies. I'm a really good person, a kind friend, and I want to make the world a better place. But I won't be around to do that if you continue to take away my health care. Please mind your business and vote no on this bill so I can continue to be who I am.
Thank you, Maya. Do we have any questions for Maya? No questions? Maya, thank you so much for being here. Sorry, Representative Jones.
So, thank you for being courageous. So you have a twin brother,
Yeah, I do.
and I'm sorry, tell me how old you are again. Did you say 12?
I am 12 years old.
And you said something about your friends' bodies are changing, and you said something like you wish yours would or something. Can you explain that to me, please?
So a lot of my friends are going through puberty now, and I want to look like them. I think I should be a girl, and you guys shouldn't be telling me what I should look like or be.
So, is the health care you want for yourself as a 12-year-old, with your mom's, I guess, support, and with your medical doctors, you would like the opportunity to be able to take, I guess, hormones so that your body can like be like a girl, like the other girls that are your age? Is that what you're asking?
Yeah.
Boy, you know what? More kids your age should know who they are. I'm seriously impressed. You are way more mature than any 12-year-old I know. So I support you. I support you. And I think
Thank
that's
you.
great, Mom, for you to support your child.
Thank you.
I've got a question, Mom. When this happened.
Wait, we can't.
Okay, I'm sorry. My bad. Okay.
Am I next or no?
No, ma'am.
Even though we registered at the same time?
She's talking now.
Be very quick.
Should she register?
No,
Yes,
she's
she
registered.
registered.
She is. Wait,
Okay,
what's the name again?
She'll just,
It's Stanton. Hold on.
I just need to
This is
finish this
taking
little
up
note.
Yeah, finish up the little.
Okay, so Maya, thank you so much for being here and for being strong, and you're absolutely beautiful. Thank you for your testimony.
Well, welcome.
Give us just a minute.
Just Lisa Stanton.
Thank you for being here, and I show that you're registered as Lisa Staton. Is that correct? And you're here on behalf of yourself, and you're against the bill, is that correct?
That is correct.
Thank you. You may begin your testimony.
My name is Lisa Stanton. I'm testifying on behalf of myself in opposition to HB 1686. My grandparents came to this country in search of a better life after surviving the Holocaust. My grandfather called America the land of milk and honey and the only place where people could be truly free. I cannot believe that 74 years later, I am having to think about fleeing this state because this legislature insists on limiting the rights and freedoms of my child. I am a mother of 12-year-old twins, one of whom is a transgender girl. When I gave birth, I assumed we had 2 sons. My husband and I named them after our grandfathers, one of whom was a state legislator here, just like you. Even though we dressed our kids alike and provide the same environment to both children, our daughter consistently and persistently told us she was a girl. She was extremely anxious and depressed. She cried all the time. We struggled to accept and understand what she was telling us. But once we finally got on board and she was supported and affirmed, she began to thrive. I have been racking my brain about what I can say to help you understand how wrong this is. You are not experts in this field, and yet you have positioned yourselves to make decisions about what medical care my child can have access to. Do you really think you could possibly worry more about my child than I do? Do you really think you are better equipped to make determinations about what is appropriate treatment for her than her own parents or doctors? It is not the place of our government to dictate medical policy. It is not the place of our legislators to limit access to best practice life-saving care. We have so many problems in this world and in this state that need fixing, and yet you all seem so focused on interfering with the lives and liberties of such a small percentage of the population. You are creating legislation that will prevent our children's access to medical care. We have the right to decide what is best for our own children, and we deserve privacy when making those decisions. I am begging you to please leave us alone and focus on the issues that affect everyone in this state. There are plenty to choose from.
Thank you for your testimony. Is there any questions? Representative Jones?
If this bill is passed, how's it going to affect your family?
I will have no choice but to leave this state. And my husband's entire livelihood and work is here. And while I have a job that I may be able to relocate for, we have literally been having conversations about whether we will have to separate and move somewhere else and have him just visit us on the weekends. This is ruining our lives.
As it relates to your baby, what would happen to her if she was not, if you couldn't move to somewhere else? What would happen to her here?
I will not allow her to not have access to the care she wants and needs. She has persistently and consistently told us who she is. She has also consistently and persistently expressed ideation when she imagines the idea of having to go through the wrong puberty or develop secondary male sex characteristics, and it is extremely distressing for her.
When you say ideation, are you talking about suicidal ideation?
Yes.
And you say, well, you say that she was like depressed. How old was she when she started crying because she wasn't treated like she knew she was?
From the time she could talk.
When did she start talking?
2 years old. She started telling us, and I had no idea. I initially conflated gender and sexuality. I didn't understand the difference between the two. I didn't even understand kids could be transgender. I didn't really know what being transgender was. But when your child starts telling you that they want to remove certain body parts or that they don't want to live unless they can be a certain way, you wake up real quick and you say, I'm going to get them the best care they need. You bring them to the doctor, you get them the care they need. She has had no medical intervention. She has only had therapy. And with therapy, and before all this legislation started happening, she has thrived. She is happy. She is well-adjusted. She is popular. She's a straight-A student. She's in a competitive choir. She swims. There is nothing wrong with her as long as she can be who she feels she is.
You've been here since 5-something this morning?
5:30 this morning.
So you heard all the other testimony?
Yes.
You heard testimony about kids being brainwashed that they're trans because they were on the internet. So at 2 years old, was she on the internet?
No, she was not on the internet, and this was prior to all of this really being in the public discourse. I didn't even know what it was.
All right. Thank you.
Thank you.
Thank you for your testimony.
Mother's going to tell the same thing. You just interferes. You're too short. Thinking that it should just. I mean, she's too sunny. Sunny is the daughter. But she's going to pull the same thing. just so you know. Okay. And there's other people that other members have stated.
Right. Thank you for being here today. I show that you are registered as Sunny Bryant. Is that correct?
Yes.
And you are here on behalf of yourself?
Yes.
And you are against the bill?
Yes.
Okay. You may begin your testimony.
Hello, I'm Sunny Bryant, and I represent myself. I'm 9 years old. Here I am again, missing school to sit all day in the Capitol to try to convince you I'm a human who deserves the same rights as every other Texan, the right to a happy life. And I'm always happy, except when I have to come here. Coming here reminds me that there are people like you who don't believe me, and that's hard to think about. Everyone I know sees me as a girl. My friends just know me as Sunny. Why do you spend so much time thinking about whether I'm really a girl? Why do you think you know me better than I know myself? I've been me my whole life. I've known I was a girl so long that I don't remember life as a boy, probably because I was never a boy. The medicine they're trying to make illegal is something I will need one day to let me be the girl I am. If you take it away, I'll start to look like a boy, and I'm not a boy. And that scares me. Why do you get to decide if I get to be happy? If you pass this bill and we stay in Texas, I'd grow up looking like my dad, and that's a scary thought. I want to grow up looking like me. Nobody else, just Sunny. If you pass this bill, I'll have to leave my home. I don't want to leave Texas, but we'll have to. If you pass it, I'll have to say goodbye to my friends at school, my teachers, and my family. I don't want to move. This is my home, and I should be in school, learning history, not making it.
Thank you so much. Thank you for your testimony. Any questions? Members, any questions? No questions? Thank you so much for being here, Sunny.
Of course.
I appreciate you. Thank you. The chair calls Gregory Porter. Gregory Porter?
Mitchell Tillison, Ted from Malone.
The chair calls Mitchell Tillison. Mitchell Tillison. Okay. Thank you, sir, for being here today. I show that you are registered as Milton, right?
Mitchell Tillison?
Mitchell Tillison, and you're here on behalf of yourself, and you're against the bill, is that correct?
Absolutely.
You may begin your testimony.
I had spent all day thinking about what I was going to say and had multiple versions of a beautiful speech written out. But at the end of this day, I am emotionally wrung out. My ADHD meds wore off a while ago. And I am a desperate, desperate father. I'm also a proud educator in the state of Texas. I have a 12-year-old trans daughter at home. And her story is exactly like all the ones you just heard. I don't need to reiterate it because all of our stories are the same. But I didn't know, I would not have known what I needed to do for my kid if it hadn't been for my experiences in my classroom. It was the kids in my classroom who were queer who helped me understand when my daughter came to us what it was I needed to do for her. I have spent the last year and a half, 2 years of my educational career being called an indoctrinator, a groomer, a pedophile. I am called a child abuser because I choose to love my child. So somebody please explain to me why, according to the Texas Legislative TIA incentive allotment, I am an exemplary teacher if I am so terrible at my job. Somebody please explain why my T-test scores are a 4.8 if I'm so bad at my job. Somebody Please explain to me why I'm so terrible at my job when I can even help GT children grow 200 to 300 points by the end of a year on their STAR tests. Explain to me how I'm able to get emerging bilingual students past their TELPAS if I'm such a bad teacher. It's because the relationship between teachers and students isn't about sexualization. It's not about gender identities. It's not about any of that crap. I take whatever the kids give me. They tell me a name, I use it. They tell me a pronoun, I use it. I don't care. I'm not there to be their therapist. I'm not there to be their mom or their dad. I am there to see when they're in pain. But we have a crisis counselor for that. When they're in pain, I take them to the crisis counselor. But I've also seen what happens when those kids don't get the support they need. And it's bad. So I knew exactly what I had to do to help my daughter, because the other options I've seen is when they get what they need and those kids succeed. You have to vote against this bill, because you'll lose me, like all the other parents, if these bills pass.
Thank you. Are there any questions? Thank you for your testimony. The chair calls Topher Malone and then Julie Rutherford. Thank you for being here. And I show that you're registered as Topher Malone, and you're here on behalf of yourself, and you are against the bill. Is that correct?
Yes.
Thank you for being here. You may begin your testimony.
Good evening, Madam Vice Chair and committee members. My name is Topher Malone. I live in Round Rock, Texas, and I am testifying against HB 1686 and representing myself. I'm the president of my high school's Gender Sexuality Alliance Club. I am a national council member of GSA Network's Gender Justice Leadership Program. I am the youngest person in the Texas ballroom scene, a community that started in New York City more than 50 years ago by Black and Hispanic trans women as an escape from the transphobic world around them. I am here as a girl who has been accepted into Columbia University in the city of New York for my prolific work for the trans community on a national scale. But foremost, I am here as a Black transgender teen whose rights are about to be stripped away. History backs the validity of transgenderism. Transgender people have existed in pre-colonial indigenous cultures around the world for millennia. So to think this is something new is simply false. I am not confused, nor am I a product of gay and trans indoctrination. No one influenced me to be trans. They only supported what I always knew was there. In fact, I honor my trans ancestors. It was their endless fighting that allowed me to begin medically transitioning at 17 years old with the care of a doctor. HB 1686 would be stripping my rights away, and just like prohibition, banning gender-affirming care won't stop transition. It would only make our source for it unsafe and unregulated. You have the chance to be on the right side of history. The question is, will you? I had to skip school for this. I sat in those chairs for 13 and a half hours just to speak for 2 minutes, just to beg for what should be a human right. It's wrong and it's disgusting. And this bill makes me not want to be a Texan. It makes me disgusted of this state. And today, Rice's decision came out, and I didn't even check it because I don't want to stay here for college anymore because of what this government, what this state government is doing to trans people like me, and I can't stand it anymore. I would accept questions.
Any questions? Representative Jones?
I may have missed it. Did you tell me how old you are? I know you said you're a teenager.
I'm 17 years old.
Are you a senior?
Yes, I'm a senior in high school.
And you say you've been accepted at Columbia?
Yes, Columbia University.
And when you said the Rice decision came out today, did you mean Rice University?
I meant Rice University. I haven't checked the decision because I've been up here waiting to see if I would get to speak or not.
Where do you live?
I live in...
I think you might be here.
I live in Round Rock, Texas.
Okay. Well, I hope this bill doesn't pass, and I hope you stay, because you seem like you're seriously bright, and I would really love a mind like yours to stay in Texas. But I certainly understand if you have to leave to save your life. And I wouldn't do anything to cause you to have to do something to try to save your life.
Thank you.
I don't think somebody 17 years old should have to worry about whether they're going to die or go to jail for trying to be human.
I appreciate that.
So I apologize that you have to be here, but thank you for your testimony and thank you for your, I guess, resilience in staying here, because the world is run by those who show up.
Thank you so much.
You're welcome.
Any other questions? Representative Collier?
I want to ditto what Representative Jolanda Jones just said to you. And also, can you repeat what you said, that this is not new, this is not something that just happened?
Yes. History backs the validity of transgenderism. Transgender people have existed in pre-colonial indigenous cultures around the world for millennia.
Thank you.
You're welcome.
Any other questions? Thank you so much for being here this evening.
Thank you.
Thank you. Okay, but just to have fewer people, just to hold the crowds. I'd like to ask the audience to please just hold on, no clapping allowed, if we can just get through the process. Thank you. The chair calls Max Alexander and then Julian Mace. Max Alexander? Okay. Did you call this person also? Oh, she was just done. She's the one that we just did, right? No, we just did Topher Malone. Oh. So we can call her. She may have gone home. The chair calls Julie Weatherford. Julie Weatherford? No, she's not here. Max Alexander. Julian Mace. Max, okay. Thank you for being here. I show that you're registered as Max Alexander. You're here on behalf of yourself, and you are against the bill. Is that correct?
That's correct.
Okay, you may begin your testimony.
My name is Max Alexander. I'm here on behalf of myself. I am an educator who also happens to be transgender, and I'm here in opposition of this bill. When I see the state that I love proposing legislation that could hurt children, it is my duty to speak up and to advocate for my community. Leaving children in fear of losing access to life-saving medical care is not protecting them. Interfering with private family decisions made by loving parents is not protecting kids. I have seen firsthand the effects of these family and medical decisions being threatened. Even hearing this legislation has created a climate so hostile that we are unsafe in this state, both kids and adults. Pushing bills that marginalize this at-risk group of youth further is not protecting them, it is killing them. As an educator, as a former trans youth, and as a trans adult, I urge you not to have this bill move forward. Thank you so much for listening to me speak. I'd be open to questions if anybody had any.
Questions, members? Thank you.
Thank you for listening to me today.
Is Julian Mace here? Julian Mace? Andrew Brown? Andrew Brown? Brian Klosterbore? Brian Klosterbore? Ash Hall? You'll state your name, who you represent, and your position on the bill.
Yep.
My name is Ash Hall. I represent myself and the ACLU of Texas, and we are against this bill and any bill like it that would endanger the lives of transgender children in our state. First, I want to start by saying that this bill is part of a national coordinated attack on transgender people. And so far throughout this hearing, that's been supported with disinformation provided by political organizations that profit off of the animus towards transgender people. I am trans myself. I have been in this community for nearly 13 years, and I can tell you, this care is life-saving. Trans youth are telling you this, parents are telling you this, trans adults are telling you this, our communities are telling you this. When an entire community is telling you that taking away their health care will kill them, our job as public servants isn't to prioritize our own comfort over the lives of children. And I expect more from people who serve on the House of Representatives, which is supposed to be the more reasonable branch of the Texas legislature. I can't even express how disappointed I am right now. The risk of suicide without this care is real. When Arkansas passed a bill similar to HB 1686 in 2021, 4 trans youth attempted to take their own lives in a 2-week period. That we know of, mind you. There could have been more. In fact, the Trevor Project went ahead and surveyed Texas transgender youth following the last legislative session and found that in the past year, 47% of them seriously considered suicide, and 86% reported that recent politics negatively impacted their well-being. I think the stats kind of speak for themselves there. What we are doing in this building right now, what we have done passing anti-trans legislation, and what we are doing by possibly taking away health care from trans youth is going to kill people. That is not an exaggeration. And I need you to take this seriously and recognize that if we pass this bill, there will be blood on your hands. And I don't want that for you, because in spite of everything I have seen today, in the past 12 years, I have looked to you all as an example of leadership, and I have done my best to learn from each of you as I've pursued my own path of leadership. I want what's best for you as well as my community. I think we will all sleep better tonight, Representative Click, if we don't have to worry about whether or not we wake up tomorrow and a trans child is gone forever. I think we will all sleep better if we know that we're making decisions that keep our kids alive. Thank you so much. And please note that there are 450 other people who would love to speak to you tonight who probably won't get to, who will tell you more often than not that they support trans Texans. Thank you.
Questions, members? Thank you. Andrew Brown. Next on deck will be Jonathan Covey. Just a minute. My computer's a little slow.
Oh, no.
Okay. I show your name is Andrew Brown, and you're representing Texas Public Policy Foundation, and you're for the bill. Is that correct?
Yes, ma'am.
Thank you.
Thank you all very much, and good evening. As you've heard today, systematic reviews of evidence relating to the efficacy of medical transitioning of children and adolescents have been conducted by a number of European countries as well as the state of Florida. I won't belabor going into the details, but rather would fill in a few aspects of these studies, these systematic evaluations that I think are relevant to our conversation this evening. As you've heard, these reviews have all come to the same conclusion. The evidence supporting the medical transition of minors is of very low quality, and there is low certainty that these interventions are beneficial for patients. Quoting from the systematic review published by Sweden's National Board of Health and Welfare, the board said, quote, "The risks of puberty inhibiting and gender-affirming hormone treatment for those under 18 currently outweigh the possible benefits for this group as a whole." And as a result, these jurisdictions have all sharply restricted these medical interventions that we are discussing today. The moves being made by European nations are particularly important, but it's also critical that we understand what these nations are and are not doing. First and foremost, when describing how European nations have curtailed the medical transitioning of children, I use the phrase sharply restricted intentionally. You often hear it say that Europe is not banning these procedures for minors under 18. Although this is technically true, it is also highly misleading. The European nations discussed are allowing a limited number of children to continue to receive medical interventions within a tightly managed research setting. All have been very clear that, to quote the Finnish review, quote, gender reassignment of minors is an experimental practice. By prohibiting the performance of these unproven medical procedures on children and adolescents, House Bill 1686 is actually more faithful to the findings of the European reviews than the countries who have performed them. Second, the current approach to treatment in Europe is arguably more conservative than the approach being pushed in the United States. In her interim report on gender identity services provided to youth by the British National Health Service, Dr. Hilary Cass was critical of what she referred to as the, quote, affirmative model that originated in the USA. According to Dr. Cass's report, this affirmative model, which affirms a young person's subjective gender experience, is at odds with the standard process of clinical assessment and differential diagnosis. You heard the Dutch protocol discussed today. That is a more rigorous approach than the affirming model. It was one of the problems that Dr. Cass pointed to with respect to the British approach, was that they had diverted from that Dutch model. But more importantly, it's important to note that the Dutch model has been included in each one of these systematic evaluations and was also rated of very low quality. And I heard the timer, so I thank you for your time this evening, for being here for many hours, and for your attention.
Questions, members? Great, thank you. Jonathan Covey, followed by Nova Mize and Evan Weinecke.
Madam Chair and members, my name is Jonathan Covey, and I'm the Policy Director for Texas Values. I'm testifying in favor of HB 1686. It helps children struggling to embrace their sex by protecting them from harmful drugs and surgery. If a profession can't regulate itself, someone needs to step in and help them. A small segment of the American population experiences distress identifying with their sex, and studies consistently demonstrate that the majority come to embrace their sex in adolescence or adulthood, thereby rendering most medical and physiological interventions unnecessary. However, in recent years, politicizing medical organizations have pushed referring children for invasive, harmful forms of treatment. They can include off-label use of puberty blockers, administration of cross-sex hormones, far above naturally occurring levels, and even sometimes surgery. The result of this is that children with gender dysphoria are sent down a one-way path to transition by making it appear to be the only treatment option available. This is especially alarming since the fact that 80 to 90% of children will outgrow gender dysphoria and embrace their biological sex if these experimental treatments are not used, but 100% of children go on to transition if these harmful treatments are used. I would respectfully ask you to vote in favor of this bill, and like Dr. Oliverson has said many times, this is about the science, real science, actual science. We are standing with the science, and we will continue to stand here and be here and come back every day and every night. And I've been here since 7 o'clock this morning, and we'll be here till tomorrow at 7 o'clock if we have to protect children. Thank you.
Question, members? Representative Tinderholt.
Thank you, Madam Chair. Would you consider this child abuse?
Yes.
Thank you.
Thank you.
Nova Mize, or Mies. If you'll state your name, who you represent, and your position on the measure, please.
Hi, committee. My name is Nova Mies, and I am here in opposition against this bill, HB 1686.
And you're representing yourself, is that correct?
Yes, ma'am. I am representing myself. I am born and raised here in Texas. I also will apologize beforehand. My notes are not with me, but my parents raised me in a God-fearing home. My mom was also born and raised in Texas. She was gifted her first horse by LBJ. My great-grandfather was a Texas Ranger, and I have deep love for this state. It is a part of me, it is a part of my existence, and it is something that I cannot leave. I moved away for 4 years, and I immediately came back after I served as a missionary for 3 months after college. And after that, I worked at Second Baptist Church in Houston as a youth pastor as well. I'm here today as a trans and non-binary Texan who uses they, them pronouns to oppose this bill because I am appalled that anyone would take away the rights of these children. If you were to show up at my mom's house or talk to her and tell her she was a woman, she would laugh in your face. She is a Texas woman, and she will let you know. Even my very own Senator Ted Cruz fought for his right to identify as a Texas man in Congress by wearing his gender-affirming cowboy boots. This right is not something that should be taken away from any Texans, no matter if you agree with how they identify or not. There is legislation that is worth your time, however. In 2019, the Houston Chronicle and San Antonio Gazette reported over 700 victims of sexual abuse and sexual assault by the Southern Baptist Convention. Pastors from the very own church I worked at, Second Baptist, have been found to be guilty and to have abused children. The Southern Baptist Convention themselves have refused to regulate and keep a database on those accused of sexual abuses. So this internal system is continually being used to put abusers in power.
That's not the subject of our bill. We need to stick to the subject of the bill, please.
Understandable. And so, with that knowledge, I am ashamed that this body would spend its time taking away rights from trans kids who deserve health care and deserve your time and respect and honor. And with that, I yield my time.
Question, members? Thank you. Evan Wynick, Alicia Weigel, Jonathan Sines,
Good evening, Madam Chair. Members of the committee, my name is Jonathan Sines, the president and attorney for Texas Values Action. We are the largest faith and family nonprofit policy organization in Texas.
And you're testifying for?
And I'm testifying in favor of House Bill 1686. Thank you. Being passed around is a copy of an article.
You're also representing yourself.
And I'm representing myself as well.
Thank you, I'm sorry.
Being passed around is an article about Chloe Cole, who talks about some of the things that she's gone through in her life and the regrets she has of, as a teenager and a child, having to go through a harmful gender transition process. But I want to remind this committee, 2 years ago, this committee heard a long and robust and shocking testimony about the harm that children are subjected to with child gender transitions. 2 years later, we know so much more. 2 years later, we now have close to 7 states that have protected kids by banning these harmful procedures. Florida, New Mexico, Iowa, Tennessee, Utah, Arkansas, and likely more. 2 years later, we see more and more young people bravely coming before testimonies like this and telling their detransition stories on social media and wherever they can. People like 18-year-old Chloe Cole, who you see the article. Chloe talks in this article that one of her most regrets is now how the beauty of motherhood was stripped from her at an age when she wasn't able to fully comprehend that loss. At age 15, she says, I wasn't really thinking. I was a kid, just trying to fit in, not thinking about the possibility of becoming a parent. And here we are, 2 years later. We heard the Texas Medical Association no longer is in opposition to this type of legislation. Clearly, in my opinion, because they have concerns, mounting concerns about these procedures. And 2 years later, our governor, our attorney general, and lieutenant governor have publicly voiced their strong concerns about harmful child gender transition surgeries and drugs. 2 years later, 730 days, 17,520 hours have passed in those 2 years. Let's not wait for another 2 years. We have an opportunity to do the right thing today. This committee and members of this body have studied this issue thoroughly. They have heard from the public. They have heard from people from the medical community and many people throughout the state of Texas. Some people believe that Texas is now the leading state for the growth and increase of these harmful child gender transitions and surgeries. That's the wrong type of category for Texas to be leading in. Let's exercise real leadership and protect our children. Let's help, not harm. Let's pass House Bill 1686. Thank you.
Question, members? Thank you. Amanda Bowman, Mia Cabrera, Amanda Bowman, Mia Cabrera, Molly Carnes, Molly Carnes, Susanna Carranza, Susanna Carranza, Asher Thigh, Asher Thigh,
Charlie Apple.
Could you state your name, please?
Yes, ma'am. I'm Molly Carnes.
Okay, just give us just a minute. It takes computer a minute to catch up.
I'm tired.
Okay, I show your name is Molly Carnes. You are representing yourself and you're against the bill. Is that correct?
Yes, ma'am.
Thank you. You may begin.
I'm Molly Carnes, and I'm the Christian parent of a precious transgender daughter. I oppose HB 1686. So here we are in a public health committee meeting in Texas where we set the record for having the highest number and the highest rate of uninsured people in the country. But what we're talking about today, trying to ban medical care that every major medical association endorses, trying to take away treatment from poor kids and adolescents in the foster system by barring the use of public funds for this care, instead of fixing that child welfare system that lost the lives of 100 children since 2020, you're taking actions that could cause real harm to these youth, but you don't care because you're convinced that you know better than parents and specialists and transgender people themselves. And it appears you even think you know better than our Creator. My daughter was created in God's image for a good purpose, and her being transgender gives her a unique perspective to serve the world. The body she travels in is but a temporary home for the beautiful soul that she carries. As a small child, my daughter told us she needed 10 hugs a day to be happy. By adolescence, she was so uncomfortable in her own skin, we had to ask permission to touch her. The young woman who now says that her love language is physical touch couldn't bear to be touched for years. As a parent, I have witnessed what life-saving medical care did for her. She is now joyfully living into who God created her to be, and hugs are back in abundance. We had the right to obtain appropriate medical care for her, and we did, because we were smart enough, informed enough, and diligent enough to do so. I don't need you to protect my kid. I'm trying to protect my kid from you. HB 1686, just riddle me this, still carves out the rights of parents to consent to genital surgeries on babies who are intersex. Your bill literally endorses gender treatment for babies who cannot consent and denies such treatment to youth who want it. If you want to dig in about medical treatments on children that have nearly ruined their lives, go talk to intersex adults. Transgender people are not broken. They do not need to be cured. They need to be allowed to thrive. They are God's beloved, and the way they understand the soul is a gift. And nothing you can say or do can change that. And Tinderholt, you want to know what Paul said? He said, Galatians 3:28, neither Jew, nor Greek, nor slave, nor free, nor male or female, because we're all one in Christ, buddy. Thank you. You got questions?
Questions, members?
Thanks.
Susanna, a chair calls Susanna Carranza. Asher Thigh. Please state your name.
Hi, I'm Dr. Susanna Carranza. I'm a cisgender woman. I don't have kids. I'm not a teacher, but I oppose this bill because I'm a human. Just leave kids alone, and I would just be done so you can call other folks in the community. Thank you.
Oh, just a minute. You are representing yourself?
Myself.
Okay.
Yes.
You are against the bill?
Yes.
Thank you. Asher Thigh, Charlie Apple, Michelle Evans. You'll state your name, please.
Hi, my name is Asher T. I'm here from Euless, Texas, representing myself, and I am in opposition of this bill. So introducing myself, I'm a college student with a full ride merit scholarship to college and multiple leadership roles on my campus. And I'm not only that, but a semifinalist for the prestigious National Fulbright Scholarship currently. I've come to a place in my life where I'm happy, loved, and successful. And this has only been made possible because I've had access to healthcare for my severe gender dysphoria. As I underwent puberty in middle school, I saw my mental health decline as my physical appearance no longer matched with how I wanted to present myself to others. And despite incredible support from my family, and after years of struggling, I invested in gender therapy to address the dysphoria I was feeling and its mental health consequences beyond the existing mental health care I was receiving. And these consequences included being suicidal. I took it slow, and coming out helped to show me I was on the right path, but the dysphoria was so severe that this mental health care and social support was not enough. And by 16, I could not imagine continuing to exist in a world where I was forced to look like someone that I'm not. So I began the process to further care through hormone therapy. And my providers were clear with me and family about the potential health outcomes and consequences, and I underwent several evaluations to make sure that my individual care plan made sense for me. I quickly came out of my shell because I felt comfortable in my body for the first time. Anyone in my family will tell you that I rarely spoke before the age of 16 because I hated my voice so deeply. And then now I've given dozens of speeches like this. I have guest lectured on my research because I've become that confident in myself and the way that I present myself to the world. And that's not a fleeting thing. That is an intrinsic part of how I've wanted to navigate the world for years, and that this has enabled for me. So 6 years later, I'm now confident and comfortable with my loving family, my beautiful partner who's here with me tonight. But without this care that I received at 16, after years of already waiting, I would not be standing here at all. And so I say this to say that trans youth suicide is not a hypothetical scenario, and there's the survivor's bias where the kids who don't make it are not the people that you're hearing from, and the kids who make decisions and change their minds later aren't the ones that you're hearing from, because if you make that decision and you're in that moment of desperation where you feel like you have no choice over your own body, those kids aren't the ones that are standing here talking to you. It's the ones who do get the care that they need, who are able to make it this far. So I want to end by saying that as a Texan born and raised, I hope you can understand that importance for me of having the freedom and privacy to make decisions between myself, my parents, and trained medical professionals for an individualized care plan, not because of what's fashionable or easy, because it took years and I lost relationships over it, but because it's the healthcare that I needed to make it to adulthood and have a bright, vibrant future. So I'm asking you to not only not let this bill pass, but to at the very least make an exception for extreme cases of gender dysphoria like mine. So thank you for your time.
Questions, members? Already, thank you. Charlie Apple, followed by Michelle Evans.
Hello.
Can you state your name, please?
I'm Charlie Apple, and I'm here in opposition of this bill, and I'm representing myself.
Okay, please begin.
All right. My name's Charlie. I'm 19. I'm a college student. I'm from Corpus Christi, Texas, and I'm a transgender man. 3 years ago, I started medically transitioning, and as I'm sure you've already heard, it was probably one of the best decisions I've ever made. It gave me the opportunity to go through a normal male puberty and just be a teenager. I was able to make friends, do extracurriculars, and even date. It was a gift that my parents and my medical team gave me. But I'm one of the lucky ones. Transgender suicide is very real. With the kids that I came out with, that I got to know, my other trans siblings, more than 50% of them are dead today. And that is no accident. All the transgender kids that you hear today are the lucky ones. We are the ones who can speak to you on behalf of the ones who are just watching with their bated breaths. Their lives rest in your hands. And I implore you to make the right decision. These are kids, and they deserve better from our state and our legislator. So I implore you to vote against HB 1686. Thank you so much for your time.
Questions, members? Thank you.
Yeah.
Michelle Evans, followed by Barnes Daniels, and then Amanda McLaughlin. Hi, Michelle.
Hi.
If you will state your name, who you're representing, and your position on the bill, please.
Yes, Michelle Evans, representing myself for HB 1686. I want to preface my testimony by saying that my oldest daughter in prepubescence experienced what many have shared here today, insisting on wearing oversized hoodies, cutting her hair short, etc. She then texted me at 12 years old saying that she had a crush on a girl. Soon after, she asked to be called they, them, and labeled herself pansexual. Instead of affirming these pronouns, I set boundaries based on truth and reality. At almost 16 years old, she is a happy, thriving, confident girl with whom I have a very close and loving relationship. I'm also the mother of another girl with diagnoses of autism, generalized anxiety, and major depression who has had multiple bouts of suicidality. What we've so far failed to acknowledge in this hearing is the misogyny and homophobia that is inherent in trans ideology. Adults who affirm children as trans are, at their core, unable to merely accept a child who is effeminate or butch, who doesn't conform to often sexist stereotypes. Boys who don't like cars or sports, girls who beg for a short haircut and don't want to wear pink. These social constructs aren't related to biological sex, nor are they related to gender. They are nothing more than cultural norms, norms that have morphed over our history and norms with exceptions on either end of the spectrum. This phenomenon is borne out for those who transition, as well as those who do not, and those who desist or detransition. Homosexuality is overrepresented in all of these populations. Many, up to 50% or more, report internalized homophobia as a factor in seeking transition. So while those who perpetuate the idea of transgenderism and gender identity ideology have intentionally and cleverly co-opted the LGBT rights movement, they are actually harming this population. This becomes even more evident when we uncover more than a decade of efforts by trans-identifying men to infiltrate or force their way into lesbian-centered women's-only events and groups, the inability of lesbians to find a safe women's-only space to seek partners, the violent threats against lesbians when they insist on being same-sex attracted, which naturally excludes trans-identifying men. If we truly want to discuss inclusivity and acceptance, we must lift the veil on transgenderism and gender identity ideology, revealing it for the homophobic movement that it is. Healthcare providers who are happily following the guidance from medical societies captured by activists are quite literally transing the gay away by confusing children about sexuality and gender, acquiescing to internalized homophobia, and ultimately sterilizing these children and potentially hamstringing their future for love lives. Thank you to those detransitioners who are strong, beautiful, and courageous and now know who they truly are. May we all be that brave.
Questions, members? Great, thank you.
Thank you.
Barnes Daniel and Amanda McLaughlin. You'll state your name, please.
My name is Barnes Daniels, and I represent myself, and I am against House Bill 1686. My daughter told us she is transgender in her senior year of high school. She was 17. She had known for a while, but was too scared to tell anyone. She was terrified we were going to reject her and kick her out of the house. As soon as we found out, we did what any loving parent would do. We told her we love her no matter what. We asked her how to best support her, and then we researched. We researched to understand what it means to be transgender. There is a lot of science behind being transgender. Psychologists, psychiatrists, and other medical professionals that you have all heard here today agree on this best form of health care. We found her a good counselor and an endocrinologist. And as Christians, we look to see what Jesus and the Bible said about being transgender. Do you know what I found? Not one bad thing. And you can go look for yourselves. We didn't contact our legislators to see what they thought about medical care. Why? Because our doctors are the experts. We put our faith in God, we put our faith in science, mental health, and medical experts. This was not a fast process. There was no surgery, there was no body mutilation involved. It was as simple as wearing the clothes she wanted to wear and changing her name. She started hormone therapy, her mood improved. Her smile came back, and guess what? She hasn't had any regrets, and neither have we. The only thing her medication has done is improve her quality of life, just like if she was diabetic and needed to be on insulin. My daughter is now a very happy and healthy adult. She is living her best life at college, getting her degree in computer science. She has a significant other, and she is thriving. This is what she is not. She is not a pedophile. She is not a groomer. She is not a pervert, as some would have you believe. She is, on the other hand, a Texan and a voter who is funny, kind, and she has the most beautiful, long, curly red hair. She just wants to live her best life, use the bathroom in privacy, and be offered the same medical rights as every other human. Please protect her and others, and please oppose House Bill 1686, and do not let it out of this committee. Thank you.
Members, questions? Thank you.
My name's Amanda McLaughlin. I'm a transgender woman from Garland. I'm against HB 1868, or 1686.
And you're
And I
testifying?
represent myself.
Okay, thank you.
Okay. The professional counseling and medical care that I've received have been critical to my transition into my mental health. It's helped guide me on a safe path with the providers I've had. They've been very careful. They have not tried to steer me in any direction. They have not pushed me in any direction. They have listened to me, and they have worked with me to give me a safe path. It has been important because it took a lot of discussions before they would actually approve my hormone therapy. So I finally did get that after, serious discussion with my counselor. And without it, I really would have been depressed. It would have put me in severe depression. So, before I could get the gender reassignment surgery, I had to wait for the hormones to reach their potential. I had to get letters from counselors and medical doctors. And I had to wait. I waited several years after I started transitioning before I had surgery. Without the support from the professionals I've received, I would be in a very dark place. Every step I've taken has been very well vetted. If there's any concern with medical care, then we should put more effort into fixing medical care. Let's just not break the system. Let's fix the problem if we have a problem. My experience has been very positive, and I think I'd like for other people to be positive. Whether you're an adult or a child, you can't ignore that you're transgender. So I ask you, please do not let this bill get out of committee. Thank you.
Question, members? Alrighty, thank you for your testimony. Members, per our committee posting, we are now going to close public testimony. I'd like to remind everybody that the public comment portal is open. We opened it when we posted this bill for hearing on Wednesday afternoon, and I'll direct the clerk to keep it open until Friday at 5 p.m. For any witnesses that were not able to be heard today. The chair recognizes Representative Alverson to close on House Bill 1686.
Thank you, Madam Chair, and I close.
If there's no objection, House Bill 1686 will be left pending. Is there objection? The chair hears none. The bill is left pending without objection. Members, that concludes our agenda today. The chair moves to adjourn. Is there any objection? Hearing none, the committee stands adjourned, subject to the call of the chair.